Good afternoon, everybody. If you could start taking your seats, please. Okay, so it's 2 o'clock. We're going to call the Appropriations Committee Human Services Subcommittee public hearing to order. And we're going to start off with some special speakers. I want to welcome Carter here. Carter, it's a real pleasure to have you here, and we can't wait to hear what your mom has to say. So first up, we have Carter, Ashley Berkman, and Bridget Fegan. I don't know if I said your last name right.
You did.
Okay. All right, guys, the floor is yours.
All righty. Good afternoon, everyone. Senator Austin, Representative Walker, and members of the Appropriations Committee, thank you for the opportunity to testify today. My name is Bridget Fegan, and I am the Chief Financial Officer at Connecticut Children's.
Hold on one second. Can one of you guys close the door over there, please? Thank you. Go ahead.
All right. I'm speaking today to testimony that was submitted by Shannon Sullivan, our new president and CEO. Over half of our patients rely on the state's Medicaid program. In adult medicine, Medicaid payments cover 62% of hospital costs, but at Connecticut Children's, Medicaid payments covers only 51% of our costs. We are very disappointed to see the governor's budget does not include Connecticut Children's in the hospital tax, even though the legislatures voted last year to include us. In fiscal year 27, the state can support children's access by including a $49 million increase in Connecticut Children's dish payment. Our submitted testimony includes details about our role as a pediatric safety net, but today I want to yield the remainder of my time to someone who represents why we are all here today, to support families. I am so grateful that Ashley and her son Carter are here to share their story. The family's journey has kept them closely connected to our pediatric experts, and today Carter is a social kindergartner who loves PE, art, and music. I'll now turn it over to Ashley.
Thank you. I'm here today on behalf of Connecticut Children's, my son Carter, and the many children who rely on Medicaid to maintain their quality of life. When my twins, Calvin and Carter, were born, we quickly realized that Carter's journey would be different. Within the first weeks, we were admitted to Connecticut Children's, where testing revealed he had markers indicating muscular dystrophy. After 6 weeks, we found genetics confirmed congenital muscular dystrophy, LAMA2 CMD. In that moment, our lives changed forever. Since then, Carter has required care from numerous physicians and specialties at Connecticut Children's, including neurology, pulmonology, gastroenterology, cardiology, endocrinology, the surgery team, orthopedics, physical and occupational therapy. Carter has a big team. He has been hospitalized multiple times and depends on specialized equipment and ongoing therapies. Connecticut Children's has supported not only his medical needs, but our entire family, providing expertise, compassion, and guidance during some of the most difficult times of our lives. About a year ago, after a 6-year wait, Carter was awarded a Medicaid waiver. This has been life-changing for our family. It has allowed him access to critical care and has helped to offset the extraordinary costs associated caring for a child with complex medical needs, including adaptive equipment, home modifications, and specialized care. Medicaid has made Carter's care possible. It allows him to access specialties, therapies, and services he needs to stay active and healthy. Without Medicaid, families like ours would face the impossible choice between financial stability and their child's care. Medicaid is not a luxury, it is a lifeline. Carter is a bright, determined, and full of personality. He deserves the opportunity to grow, learn, and thrive. I ask you to please continue protecting and strengthening Medicaid so our children, like Carter, can continue to get the care that they need. We appreciate your time.
And Ashley, I need you to say your name for the record.
Ashley Berkman.
Thank you. Thank you for that. Carter, do you want to say something to all of us? Because I know you, I met you in my office and you know how to, can you help out with that? Thank you, Taylor. Good afternoon, Carter. How are you?
Good.
I I hear you have a brother. What is your brother's name?
Calvin,
Calvin. Oh, very nice. And how old are you?
6,
And where do you go to school?
in Bolton Center School.
In Bolton Center School. I know where to. I've driven by that school before. It's beautiful. Do
Thank
you have?
for your time.
No, thank you for your time. Thank you for coming because we love having you here. So we're going to do something that I never let anybody do here. We're going to give a round of applause for you for being just a tremendous little boy.
Thank you. Thank you so much.
Thank you so much. Thank you very much.
Thank you.
You can leave it. We can take care of it. We're going to have a ton of people here tonight. Don't worry. Up next, we have Lisa Flaherty.
Hello, everyone. I am Lisa Flaherty Vaughn. I'm from Enfield, and I am deafblind, low vision. I have Usher syndrome. So I want to thank you. I want to request that the Appropriations Committee restore the $20,000 funding to CAN's services, which are essential for me to have autonomy and communication as a deafblind individual. CAN services provide necessary peer monitoring, mentoring, advocacy, and communication access for those of us to be able to be supported in the community. Without the full funding, these services will be severely impacted, leading to isolation for me and others. And we will lose the co-presence support. It is crucial for our well-being. Our deafblind culture and community are invaluable, and it's time to ensure that we have the support needed to flourish. I urge immediate action to restore the $20,000 funding. Please recognize the value and worth of deafblind lives and culture. One last thing I wanted to add is that I know in Connecticut there are many organizations, but there's only one CAN. There's only one that serves the needs of those of us who are deafblind. They know what to do. They work with us. They have supported us forever. And other communities, other agencies have no experience with us whatsoever. Forget communication access, but other types of access also. So please help to keep CAN alive. We need the funding. Thank you so much. Hi, everyone. I am Michelle Clark. I am a resident of Bristol, Connecticut. I am deafblind. I was born deaf and lost my vision as an adult. And that was a huge change in my life. I am still receiving services to allow me to be independent from Communication Advocacy Network, we refer to as CAN, C-A-N. I now have a support service provider, we call those SSPs, that allow me to have transportation anywhere that I may need to go, such as food shopping, medical appointments, and deaf-blind community events. I do not want to have to depend on my family too much, as it can be a burden for them, and it strains our relationship. The SSP program allows me to feel more independent without any barriers. CAN is very important to our deaf-blind community because they continue to provide support and guidance to our community, making sure that we receive proper services to ensure that our deaf-blind individuals will never be left out and isolated. CAN makes a very positive impact. Please restore the $20,000 funding. This impact on my life has helped me to feel independent and puts a big smile on my face. Thank you very much for your support.
Thank you. Up next is Ed Pelletier.
Good afternoon, Senator Austin, Appropriations Committee. Thank you for the opportunity. My name is Edward Peltier, and I am a resident of West Hartford. I serve on the board of Communication Advocacy Network, CAN, a not-for-profit that serves Connecticut's deaf-blind adults and deaf elderly citizens. CAN's essential services provided to deaf, deaf-blind, and hard-of-hearing adults enable them to live independently and enjoy a full quality of life due to CAN's staff ability to communicate in a variety of ways, including American Sign Language and the use of various assistive technologies. CAN and its specialized staff provide essential services to a marginally communicatively challenged community. CAN staff proficient in the variety of modes necessary for deaf-blind persons to communicate that includes ASL, American Sign Language, Protactile, and the use of current and emerging technologies. These services enable deaf-blind and deaf elderly to remain in their homes, live independently, take care of their health needs, and enjoy a full quality of life. CAN has an outstanding record of cost-effective, efficient services that are not otherwise available in the state. The deaf-blind and deaf elderly persons we serve are in support of this request to reinstate the $20,000. Thank you for your consideration of this request. Please let us know if you have any questions.
Thank you,
Thank
Mr.
you.
Thank you, Mr. Pelletier. Up next is Leroy Terrario.
Hello, everyone. Senator Austin and honorable members of the committee, thank you for the opportunity to testify. My name is Leroy Terrio, and I am a member of Communication Advocacy Network. CAN is a nonprofit organization dedicated to assisting elderly and deafblind adults in Connecticut to allow them to live independently. Our mission is to empower these individuals to live independently by providing them with personnel who are skilled in the language that they communicate in most effectively, whether that be American Sign Language or other communication technologies. There are different kinds of assistive technology, such as, VP and ProTactile. Over the years, we have supported individuals, helping them to attend their medical and legal appointments, shop, participate in religious or cultural activities. CAN also organizes regular bi-monthly peer mentoring sessions to promote social inclusion and support mental health. These meetings offer our deafblind and deaf elderly adults an opportunity to engage in a range of structured activities,
Health program is not in
including games, workshops, educational opportunities on how to make independent decisions, and also Braille instruction. The feedback from our participants indicates these sessions are well received and valued. Given the importance of these services and activities, we respectfully request the reinstatement of the $20,000 reduction. Restoring these funds is essential for maintaining CAN's operations for the fiscal year 2027, particularly to support the recruitment and training of additional support service providers. Thank you for your consideration of our request. Thank you.
Thank you. Up next is Sherry Humbry. Sherry?
No, she is not here.
Okay,
Yeah, she won't be testifying.
thank you. Up next, Marianne Langton. Is Marianne Langton here? Oh, yeah. All right. Hi.
Hi. Members of the Appropriations Committee, I'm speaking on behalf of Connecticut Adapt, Marianne Langdon, and Patty will also be speaking on her behalf. Connecticut Adapt is a chapter of the National Adapt organization. We, as the national organization, fight for the civil liberties of people with disabilities by advocating before governmental agencies, networking with organizations, and engaging in nonviolent direct action. All these strategies are used to ensure the civil and human rights of people with disabilities to live in freedom. People with disabilities have been devastated ever since the governor gave a State of the State address to the Connecticut General Assembly on February 4th. One of his proposals is to eliminate the Community First Choice, or CFC program, which is a Medicaid-funded option made possible by the Affordable Care Act. This allows individuals needing institutional level care to receive assistance from personal care attendants and support services at home instead of living in a nursing facility. Presently, there are 7,250 individuals who rely on this program. Connecticut Adapt has 40 members, 12 of which, or 30%, are on Community First Choice. The program has enabled us to live fully independent lives by working with PCAs so we can stay in our communities. This program allows some of our ADAPT members to pay taxes and work while others volunteer in their community. As a matter of fact, one of the ADAPT members is in the process of returning to home from a nursing facility, nursing home, skilled nursing. She's been there for 2 years. However, this goal may be shuttered because she cannot obtain the support and services from the CFC entitlement. This individual, Sandra Roberts, will be sharing her story at the hearing. Please listen to her. If CFC is eliminated, people would be forced to look at one of the 10 Medicaid waivers, which have strict limits on how much funding each person can get for their personal assistance, regardless of their actual need. Some will not qualify at all under the eligibility standards for these waivers. In addition, there is a 4 to 10 year waiting list to actually receive services under several of these waivers because of inadequate funding. So in the meantime, how will people with disabilities live with no assistance? Oh no, you cannot lock up ADAPT members in nursing homes, right, Marianne? People with disabilities will die in nursing facilities. Nursing facilities are already understaffed and cannot give the necessary assistance to the people living there currently. This was sadly illustrated by the 2 recent residents' deaths and the lack of oversight from staff, which resulted in the deaths. Please put yourself in our shoes. Would you want to be taken from your home and community and institutionalized? Would you want this? Would you want this for those you love? We urge you to consider the real impact this decision will have on those who rely on it. CFC gives individuals a life worth living. Do not take this away. And I'm urging you to also look at the testimony I'll be submitting later, written. And Connecticut ADAPT urges the Appropriations Committee to consider the harm and unintended consequences this abrupt change will cause to the 7,250 persons currently on the program. Thank you.
Thank you. Up next, we have Joseph Young. Oh, I'm sorry. Did I go beyond you? I apologize. I
more, please.
apologize. Go ahead, Mary.
Hello, Senator Austin, Representative Walker, and distinguished members. My name is Marianne Langton from West Hartford, and I ask Patty Ellis from Windsor to read my statement that I have prepared. My life has been upside down ever since the governor gave his State of the State address to the Connecticut General Assembly on February 4th. One of his proposals is to eliminate Community First Choice, which is a Medicaid-funded state option made possible by the Affordable Care Act. This allows eligible individuals needing institutional-level care to receive help from personal care assistants, called PCAs, and support services at home instead of living in a nursing facility. As of today, there are 7,250 people who rely on this, myself included. As a woman with a physical disability requiring assistance for all basic activities of daily living, I have been on CFC since the beginning of this entitlement. I am also proud to say I was one of the principal contributors to the original writing of this entitlement, and now I participate on its advisory committee. This program has enabled me to live in the community with 75 hours of personal assistance per week, and as a result, to be a very productive disability advocate fighting for civil liberties throughout the state. I have successfully lived in a housing cooperative for 35 years, which I created with the support of personal assistants. By being on CFC, I can be the employer for my PCAs and arrange them to come at needed times to help me. I have been able to live a very productive life, giving back to my community and also paying taxes. Please do not lock me away and let me remain in the community in my own home.
Thank you.
Thank you.
Thank you. Thank you.
Good job, Marianne. Good job.
And now up next is Joseph Young. Is Joseph Young here?
I don't think, are they in the queue, Kyle?
Is he online? Okay. Up next is Abdul Wahid Sabori. Okay. Up next is Sharon Tierney. Is Sharon Tierney here? Up next is Apostle Beverly Jackson. Up next is Mariam Hakim Zargar, MD. The floor is yours. 3 minutes.
Good afternoon, Senator Alston.
You got to push that button there. Thank you.
Good afternoon, Senator Alston, Representative Walker, and distinguished members of the Appropriations Committee. Thank you for this opportunity to testify today. My name is Dr. Mariam Hakim Zargar. I'm president of the Connecticut State Medical Society and a solo private practice independent orthopedic surgeon practicing in Torrington, Connecticut. I'm here on behalf of the State Medical Society to support meaningful use of increases to the Medicaid physician payment rates. We appreciate that the governor and the legislature recognized the issue last year and allocated some funding. However, this amount falls far short of what's needed to meaningfully improve access to care. Across Connecticut, Medicaid patients struggle to find primary care, mental health services, and specialty care because reimbursements often fall below the cost of providing care. Physicians want to care for all of their patients. That's why we went to medical school. But when rates have remained stagnant for nearly 2 decades, while practice costs continue to rise, many simply cannot afford to participate. In my practice, about 20 to 25% of my patients are covered by Medicaid. I run a lean office, yet a typical Medicaid visit covers only about half of the overhead costs. Every time I see a Medicaid patient, my practice loses money. I was fortunate to graduate without significant educational debt, so I can absorb these losses or some of these losses, but most physicians cannot. What does this mean for patients? Imagine a young mother in her 20s working multiple jobs, part-time, no benefits, slips and fractures her ankle. She's splinted in urgent care and told that she likely can be treated non-operatively. She calls multiple orthopedic offices, can't get an appointment because no one accepts her insurance. She can't drive because it's her right ankle that's injured. Eventually, she ends up in the emergency room because it's her only access point. By the time she sees a specialist, her fracture is now displaced and requires surgery. What could have been managed conservatively becomes a far more expensive, complex problem, more disruptive to her life, and results in months of time away from work. This is not an isolated story. Low Medicaid rates are a workforce issue. Connecticut ranks near the bottom nationally in retaining the physicians we train here. Young doctors look to states where reimbursement supports sustainable practice. It's also a health equity issue. Inadequate physician network disproportionately impact underserved communities, rural residents, and those with complex medical needs. And it is a cost issue. When patients cannot access timely care, conditions worsen, leading to more emergency visits, hospitalizations, and higher long-term costs. If Connecticut wants better access, better outcomes, and a stable healthcare system, we must invest in Medicaid physician rates at a level that makes a real difference. We urge the committee to allocate funding that meaningfully strengthens the Medicaid physician network so patients can access the care their coverage actually promises. Thank you, and I'm happy to answer questions.
Thank you. Up next is Kara O'Dwyer. Kara?
We actually made a swap.
I don't know what that means.
So I was gonna go for Kara because she's not here yet. Is that all right?
Who are you?
I'm Deidre Mertz. I'm assuming you talked to the clerk. Katie Traber. Okay. Katie, let me know too. You're fine.
Go ahead. Go ahead.
Thank you.
Do I need to press the button? I'm good. All right, good afternoon, and thanks for allowing the swap. Kara's en route. My name is Deidre Murch, and I'm the Home Care Director and one of the Vice Presidents at 1199, representing over 14,000 PCAs who care for individuals with physical and intellectual disabilities. All of these folks are funded through Medicaid. We've been testifying about problems with PCA payroll now. I counted. This is the 12th year. And to be honest, I'm really tired of testifying about this. And I bet you guys are pretty tired of hearing about this too. Though, to be honest, none of us are as tired as our members are of not being able to count on their paychecks on a Friday. In November alone, according to DSS, 5,000 PCA paychecks were shorted or missing entirely. 5,000 in 1 month. Today, almost 4 months later, 1,000 are still unpaid. Since then, we've had nearly a dozen PCAs report being evicted from their homes. In November, we worked with a PCA. Senator Lesser helped us out quite a bit with this one, and her son, who has a spinal cord injury and open wounds, who were living in their car after they were evicted from the hotel they were staying in. In December, DSS and the Workforce Council heard from Jashelle, who's en route also, and you'll hear from her today, who was living under a bridge in Bridgeport after her pay stopped. She and a friend took turns watching each other while the other one slept to stay safe. In January, we watched a PCA close to many of us descend into a psychiatric crisis because she lost access to her medication when both she and her consumer were cut off Husky without notice and her paychecks stopped. Years of stability were destroyed for 2 families within a matter of months. And today we have a PCA here, Kimi, in the audience, whose car was repossessed when his pay stopped and will be auctioned 9 days from today because he hasn't been paid since October. He still cares for his mother because care doesn't stop even when the paycheck does. Like Ally, GTI simply can't do the job, but is making a much greater profit to leave PCAs falling short. In 2024, the year GTI took over the PCA contract, their annual profits doubled from the prior year to $75 million. But the problems are not just GTI, they're actually closer to home with DSS. DSS has been unwilling to notify PCAs if their consumers face Medicaid eligibility problems that are going to stop their paychecks. Further, DSS has made huge sweeping policy changes without notifying either PCAs or the union. Most recently, a unilateral change switched consumer budgets from annual to monthly. Consumers received notice via a letter sent on September 30th for a new policy that was set to take effect October 1st. That's 1 day notice. To make matters worse, GTI didn't do the math correctly. We found and reported countless examples to DSS where the monthly hours budgeted didn't actually add up to the annual budgeted hours, which effectively blocks consumers from using all of their budget allocated to them. In all instances, the same number of hours was assigned to each calendar month, whether that month had 28 days or 31 days. I'm sure it's not going to be a surprise to you all to hear that consumers don't need less care and can't suspend their disabilities for a few days in the longer months. To Commissioner Barton Reeves' credit, she has paused the policy shift from annual to monthly budgets, and she is working with us to try to make PCAs whole for hours worked in October and November. But as of today, we still don't have a payment date for the 1,000+ people that are still missing money from October or November. And in the meantime, countless PCAs continue to live and work out of their cars or from homeless shelters or motels until these problems are fixed. And finally, while we share the Office of Policy and Management's goal of reducing payroll errors and providing wraparound services to assist consumers with employer functions, we're really worried about the proposal to shift all consumers to Medicaid waivers and sunset CFC. We're concerned that a major programmatic shift like that is much more likely to create a huge amount of chaos for PCAs and consumers when right now stability is desperately needed. While we appreciate the intent shared by them, we believe the solution is not capping enrollment, but instead bringing PCA payroll in-house, as there are a variety of ways the state already fulfills the payroll function for other workers. So we urge you to reject the CFC proposal and instead increase transparency and accountability with GTI, or frankly, to get rid of them entirely. We need a payroll system that allows PCAs to get back to the job they're called to do, caring for their loved ones so their consumers can live independently with dignity and purpose in their own homes. Thank you.
Thank you. Up next, we have Giselle Johnson.
So we did another swap here for Milagros because Giselle is en route.
Milagros Birosak. Come on.
Good afternoon. My name is Milagros Biroshak, and I have been a personal care attendant for 20 years. Caring comes naturally to me. When I was a young girl, I watched my niece struggle with serious health issues. She was born with cerebral palsy, and as a 9-year-old, I watched my sister struggle to manage her needs. So I stepped in, I helped with everything, comforting her, providing care, and later help her administrate medication. Give me a sense of purpose, and after my sister moved away, I decided to pursue my career in healthcare. Unfortunately, year by year, I've been dealing with significant issues with GT independent, not properly handling my taxes withholding. As a result, I keep finding myself owing taxes to the IRS. Despite requesting that they take a specific amount of my check, they refuse and say I don't make enough for them to do so. Instead of they do what they want. And I am left to clean up the mess every April. On top of that, I've been had paycheck missing hours that actually work. This is the money we spend on. We have bills to pay, and we need to feed our family. Those expenses can wait. We can tell the electric company to not charge us late fee because our paycheck is short. And we can feed our family with excuses about why they pay and why my pay is missing. How does a payroll company operate like this? It doesn't have the best interest of employees in mind. I know I am not the only one dealing with tax or payroll. Thank you so much.
Thank you. Up next is Linda Busk. Is Linda Busk here? USK. Up next is Emerson Zacina. Emerson? Emerson? Going once, going twice. Up next is Ryan Solar.
Madam
Ryan.
Chair, we will have, someone will be reading the testimony on their behalf.
On who, Ryan?
Yes.
Okay. Okay.
Hello, my name is Patty Ellis, and I'll be reading on behalf of Ryan Solar from Stamford, Connecticut. Regarding the proposal to transition Community First Choice participants to waiver programs, page 10 to 11, I am extremely concerned as a person with a disability. This would be catastrophic for Connecticut residents like myself who are relying on this program to survive day to day and avoid institutionalization. The waiver program and other agency-based home health services are not an adequate replacement, as the wait list is years long as it is, and will only be worse if the CFC program is no longer an option. Vulnerable people already die waiting for caregivers on these wait lists. The CFC program, on the other hand, does not have waiting lists, and all who are eligible receive services. The CFC program is unique as it allows disabled people to choose who provides their care, as well as the authority to oversee their own service plan, budget, schedule, and hiring process. Agencies have their place, but have high turnovers, chaotic scheduling, and cannot replace self-directed care options. Being able to hire people who you trust and are already a part of your own community is essential and life-saving. Not to mention all the caregivers who will lose their income. Please reconsider. Thank you.
Thank you. Up next is Rian Drenzik. Is Rian? Thank you.
Good afternoon, members of the Appropriations Committee. My name is Ryan Drenzik, and I'm the Executive Director of St. Joseph's Parenting Center, which is a nonprofit that serves families in Stamford, Danbury, and Bridgeport, Connecticut. I'm also here with Michaela Malin Bernstein, our Director of Development.
Hi, good afternoon, everyone. I may not need to use the microphone. I'm a little loud for a little girl. My name, as she said, is Michaela Malin Bernstein, and I am the Director of Development at St. Joseph Parenting Center. We are here today on behalf of the parents, caregivers, and children who rely on community-based human services to remain safe, stable, and supported. St. Joseph Parenting Center provides prevention-focused family support services across Connecticut. Our work strengthens parents during moments of vulnerability, before families reach crisis, and before costly state intervention becomes necessary. Recently, SJPC experienced a sudden and devastating loss of federal funding. Overnight, we lost 40% of our annual revenue. This loss was not due to performance, compliance, or outcomes. It was the result of federal cuts that are now having immediate and severe consequences for human services organizations serving families with the highest needs. As a direct result of this funding loss, we were forced to lay off 50% of our staff, dedicated professionals who provide direct support to families every day. This decision was heartbreaking, and it comes at a time when the need for our services continues to grow, not decline. The families we serve are often navigating multiple barriers at once: housing instability, economic insecurity, language barriers, and isolation. Over 80% of the households we serve are Spanish-speaking only, and many parents come to us without access to other support systems. Even as our capacity has been reduced, families continue to reach out for help. When prevention services are cut, families do not suddenly become more stable. Risk increases. Without timely support, parents face greater stress, children experience greater instability, and the likelihood of child welfare involvement, emergency services, and long-term intervention rises significantly. At SJPC, our programs cost approximately $3,000 per family. By comparison, once a family reaches crisis, state intervention can cost $45,000 or more per case. Prevention is not only compassionate, it is fiscally responsible and aligned with the goals of this subcommittee. Did you want to add, because we're running out of time?
So we thank you for your support to help continue to support nonprofits like ours in the community that are providing vital services to families and children in need. Thank you.
Thank you. And your name again?
Michaela Malin.
Okay, I found it. I just wanted to make sure.
Thank you.
Thank you. Up next is Samantha Ramon.
Hi, good afternoon. I'm on camera. Can you see me? I don't think you can.
Yep.
Can you hear
We
me?
can't see you, but we can hear you.
Okay, perfect. Sorry about that. So, chairpersons and members of the Appropriations Committee, my name is Samantha Ramon. I am the Area Operations Director for Aviana Healthcare in Connecticut and also a Connecticut resident. Thank you for the opportunity to speak today. Aviana Healthcare is a licensed home healthcare agency providing continuous skilled nursing, also referred to as complex nursing care, services in Connecticut for more than 20 years. We are the largest continuous skilled nursing provider in the state and are proud to employ more than 365 nurses who provide this highly specialized care to children and adults with medically complex conditions across Connecticut. Continuous skilled nursing allows these children and adults, many of whom require feeding tubes for nutrition, tracheostomy tubes to maintain their airways, or ventilators to help them breathe, live and grow safely in their homes and communities. Home is not only where these patients and families strongly prefer to receive care, it is also far less costly to the state Medicaid program than emergency room visits and hospital stays, which is where these children and adults are forced to go and stay when they do not have this critical home nursing care. Today and every day, children and adults in need of this care stay in hospitals longer, sometimes far longer than medically necessary, because they cannot find consistent skilled care at home. Put it simply, we need more nurses for this very demanding work. Too many children and adults needing complex nursing care in Connecticut are not receiving it, with approximately 35% of nursing shifts unfilled due to low reimbursement rates that have not kept up with inflation or the cost of care. Recent rate increases in Massachusetts, where filled shift rates are significantly higher, have increased these challenges in Connecticut. Just to give you a little bit of context here, Connecticut reimbursement rates for CSN in the home are just over $59 an hour for RNs and $50 for LPNs. In contrast, Massachusetts rates are at more than $94 an hour for RNs and $65 an hour for LPNs, which, as you can tell, that's a very, very big, significant difference. Massachusetts nights and weekend rates are even higher. While Connecticut does not offer these enhanced rates, I've included a chart where more reimbursement rate comparisons in my written testimony. We greatly appreciate the support of legislators who have prioritized increasingly continuous skilled nursing reimbursement rates in Connecticut. And despite the fact that complex nursing care was identified to be part of last year's rate study, CSN did not receive any additional funding in last year's budget. We continue to seek meaningful increases to be able to recruit and retain a sufficient number of skilled nurses to provide this care. We also encourage committee members to watch the January 15th meeting of the Complex Care Subcommittee. Oh, is that my timer? Anyways, we had some really great families that are a part of Aviana highlight their experiences, and I'd really love for everyone to be able to just hear from those families. But thank you so much for the time today. I appreciate you.
Thank you. Jennifer, you're up.
Madam Chair, if I could please remind folks on Zoom that they need to accept the panelist invite in order to be able to speak. If you are unable to accept the panelist invite, please log off the Zoom and rejoin.
Okay. Jennifer, the floor is yours.
All right, thank you, Senator Austin, Representative Gilchrist, and other members of the Appropriations Committee. My name is Jennifer Chudukowicz. I live at 161 Shunpike Road in Cromwell, Connecticut, and I'm the Chief Strategy Officer at SCAD, Southeastern Council on Alcoholism and Drug Dependence. We serve more than 5,000 people a year from across Connecticut, not just Southeastern Connecticut, for substance use disorder, a chronic but treatable condition. We operate programs in Lebanon, Norwich, and New London, and we employ 225 residents of Eastern Connecticut. I am, most importantly today, a woman in long-term recovery. Thank you for the opportunity to testify and for the fiscal year 27 increases included in the enacted budget. but we respectfully request an additional $155 million in fiscal year 27 to fully fund the Medicaid rate increases for behavioral health services, consistent with the state's own rate study. While the governor has proposed $45 million by the end of the biennium, the plan lacks details and is insufficient to meet the current Medicaid needs. Further, the $15 million appropriated in fiscal year 26 has not yet been deployed. As one of the largest DEMAS-funded providers of residential substance use treatment in the state, and as a primarily residential program, we are experiencing the same burden that you experience in your own pocketbook at home. In January alone at our Lebanon Pines campus, we paid $2,396 for eggs. And we'll talk about eggs at another time, but we have chickens at Lebanon Pines and we cannot eat the eggs because of DPH. That's in another hearing. Our food costs for the year, for one fiscal year increase between last year and this year, was $96,000 across our agency. That is not covered by any Medicaid increases. We have to pay for medical supplies, bedding, cleaning supplies, laundry detergent. 110 men at Lebanon Pines, I'm just going to say. We go through a lot of laundry detergent, thank God. Fuel, snow removal, maintenance, and repairs of 9 program locations and 22 buildings. The list could go on. Imminent changes to Medicaid and SNAP will significantly impact both the people we serve and the workforce that supports them. For individuals in early recovery, disruptions in medical coverage or food assistance can quickly destabilize that progress, leading to interrupted medications, delayed care, increased return to use, and sadly, death. In Eastern Connecticut, where access to services is already limited, even short gaps in benefits can have outsized consequences. Less visible but equally important is the administrative burden these changes place on the providers. When benefits become harder to access or maintain, that responsibility shifts squarely to the frontline staff. Case managers, recovery coaches, and clinicians spend extensive time helping clients navigate applications, resolve eligibility issues, and restore lapsed benefits. This work is essential to the recovery stability, yet it is uncompensated and not reflected in the reimbursement structures. Lastly, we are barely staffed, 25 full-time positions open. Recruitment is difficult in Eastern Connecticut, and keeping in mind the commute, being able to offer a competitive wage would help bridge the gap for most applicants when it comes to compensation. Connecticut has been on the leading edge of recovery since the early 80s. Nonprofits depend on the bipartisan support of members of this committee and others. Substance use disorder impacts 1 in 4 people. We care for your fathers, mothers, children, grandchildren, employees, neighbors, and loved ones. These are individuals who are trying to save their lives. Let us remain the experts on treating substance use disorder, caring for your family and loved ones, and the good citizens of Connecticut. And we ask you please fund the nonprofits with the additional $155 million where Medicaid funding falls short. Thank you so much for the opportunity.
Thank you. Up next is Joseph Young, number 8. Joseph Young.
Good afternoon, chairpersons, ranking members, and members of the Appropriations Committee. My name is Joseph, and I live in Manchester. Thank you for the opportunity to testify today. I'm here because the governor's proposed budget adjustments to DSS will directly affect me, and I want to make sure that this committee hears from the people these decisions hit the hardest. It's outrageous and unfair that the federal government is punishing hardworking families who need health care. We know Connecticut can't wait until families are already losing coverage to figure out our response. We need a plan with real dollars behind it. And you need it before the crisis hits. These are our neighbors, our co-workers, and our families. I rely on Husky D because I cannot afford the rising costs of Medicare. I have enough difficulty as it is affording my rent and other utilities. I cannot imagine losing my health insurance on top of that. Without it, I wouldn't be able to go to the doctor or to afford medicine. I don't ever want to be put in a position where I have to decide either to go to the doctor or to pay my bills. Health insurance, it's very pricey nowadays, and it's impossible for working class people to afford it. I urge members of this committee to uphold the promise they made to their constituents, invest in a state-run transactional benefits system to fight for mourning families and protect people who are in risk of losing Husky. We need a budget that protects working class people. Thank you.
Thank you. Up next is Kim Kalajani, number 21 online. Kim?
Yes, I'm present. Thank you. Good afternoon, and my thanks to the Appropriations Committee for the opportunity to offer testimony today. My name is Kimberly Kalajana, and I'm the Chief Operating Officer for Child and Family Agency of Southeastern Connecticut. CFA is a provider of pediatric mental health and medical services throughout Southeastern Connecticut. Our services include 4 enhanced care clinics for outpatient mental health, 20 school-based health centers offering mental health and medical clinics, and numerous in-home and safety net services throughout Windham, New London, and Middlesex counties. We're also one of the 3 locations in the state offering a community-based urgent crisis center here in New London. I want to thank you for the increases included in the fiscal 27 budget and to request that you fully fund the proposed Medicaid rate increases for behavioral health services as recommended by the state's rate study. I am here today to make you aware of the 2 most significant impacts that the lower Medicaid rates have on CFA. These negative impacts are compounded by the equally challenging private payer rate structures, which often include high deductible plans that cause many families to avoid the care they need. First, our overall financial condition as an agency is slowly eroding, given that the fact that the rate structures currently in place do not cover our true cost of care. Unlike our acute care hospitals, which have mechanisms to cost shift to private payers that offer more favorable rates and who receive state funding for uncompensated care, CFA has nowhere to cost shift, as private payers are either equal to or less than the existing low Medicaid rates for mental health services. And secondly, we continue to experience significant high turnover rates, 35% in each of our 2 prior fiscal years. The vast majority of the turnover is directly correlated to our staff's compensation, which remains below market, making it impossible for us to compete with private sector wage levels. This constant turnover creates an ongoing loss of experienced clinicians and places additional burden on training new staff. As a result, our capacity to deliver the skilled, evidence-based care required is continually undermined. The risk we collectively face if the Medicaid rates are not increased and if we are not able to increase private payer rates is that our community will have no other option than to wait as their mental health crises mount and ultimately result in increased hospital emergency department visits. While some may disagree about rate structures, we all agree that the hospital ED's visits are not the right location to care for those suffering with mental health crises. With the requested increases in funding, we will be able to invest in our staff, securing their employment and reducing our turnover rates. We will be able to hire additional staff to meet the needs of the community and eliminate our wait list. Please support fully funding the proposed Medicaid reimbursement rates for behavioral health services. Thank you for your time and your service to the great state of Connecticut.
Thank you. Up next is Carla Valentina. Carla Valentina. Up next is Letitia Council. Is Letitia Council here?
Letitia has swapped with Lynette Dockery.
Lynette Dockery.
And Lynette is number 161.
Good afternoon. My name is Lynette Dockery. I've been a personal attendant for over 3 decades. I work with a young man now that is the same age as my son. It's humbling to me because I get to watch my son go to college, be productive in the society. I've been spent caring for people for various agencies and other programs of PCA before the PCA was established. Caregiving is it comes natural to me. My family and the consumer I connect with through a program. I know how big the difference it makes for families to take a break, be able to do things for their family members, be able to take some time out just for themselves. Unlike my other brothers and sisters in care, I've been lucky enough to have my paycheck show up every single week on time. GT took over not properly withholding taxes. I didn't find this out until I did my taxes last year. I ended up owing over $700. And because now, at this point, GT is taking out almost $150 a week from my check, which is causing me now to have personal problems and having to figure out how to make ends meet. Every week I gotta sit down and figure out, what do I have left over for food? How can I pay this bill? So GTI is it's a lifetime change right now because everything is struggling for me. I'm only hoping that living tighter income now at least will pay down the tax that I owe this year when it comes time for me to do my taxes. What is discouraging, through all after my years of dedication, providing residents with care in Connecticut, this is how I'm treated. The work that we do, caregivers, is not easy. I know what you think of us. Some people think of us as babysitters. We do a whole lot more. We take care of people. We do medical things for people. We dispense medication for people. And it's an emotional, physical, and mentally challenging job. Without population of caregivers, where would the loved ones be? Perhaps in a nursing home, maybe a hospital? No matter what, not being in the situation they love, now being comfortably, again, aging at home. We need to provide DSS with additional funding so that straighten out this mess that they've made. GTI is not good for anyone, not for the PCAs, not for the consumers, not for Connecticut. It's time to bring a payroll company that knows what they are doing and for the mess to be left on the backs of PCAs, because we cannot hold it up any longer. Thank you.
Thank you. Up next is Sarah Lockery. Sarah Lockery here.
They are online. We're just promoting them to panelists.
Sarah, just unmute yourself and you have your 3 minutes.
Thank you. Good afternoon. My name is Sarah Lockery. I co-chair the DCF Statewide Advisory Council, and I work as the Chief Operating Officer at the Children's Center in Hamden. We provide a continuum of services that are licensed by DCF, ranging from outpatient counseling to intensive residential treatment. I've worked at the Children's Center for approximately 35 years. It seems children have less access to care than they did years ago. One contributing factor is provider inability to hire and retain a workforce with competitive wages. A trickle-down impact due to poor funding. I'm confident you will hear this concern repeated in the testimonies today. The Statewide Advisory Council is responsible by statute to advise DCF about their budget. In a recent meeting, we gathered representatives from the Children's Behavioral Health Plan Implementation Advisory Board, the Transforming Children's Behavioral Health Policy Committee, the Children's Behavioral Health Advisory Committee, child advocates, and others. We certainly have enough committees. Also in attendance were council members with live expertise, both former foster youth and guardians. All were consistent in their advisement about the DCF budget. We need an investment in our system so we have services to offer children. This is not a matter of DCF not doing its job. DCF needs more funding to do its job. But access is also limited because we failed to build enough resources as congregate care beds were decreased. Over the last decade, Connecticut has reduced the number of options for out-of-home placements and/or treatment for children. But when you reduce 10 beds in an agency, you then need to find 10 foster homes. And our child welfare system has not met that challenge. We have children growing up to become teenagers who have lived in multiple foster homes and whose behavioral health needs have not been successfully addressed. I was told about a 6-year-old child who has experienced 5 placements. Other children we hear about in the news, and they represent a growing number of youth our system is failing. As some of you know, across our nation, the number of Black and brown children were overrepresented in congregate care settings. And most will agree that children should grow up in a home. But efforts to address racial disproportionality in child welfare have resulted in unintended consequences in both our child welfare and behavioral health systems. Why? Because we failed to invest in a structure of services to support our children. So here we are again, asking for funding and an investment in our kids. And I question why we are not heard. I then think about the enormous mandates assigned to DCF to oversee child protective services and our behavioral health system. My last review of the DCF organizational chart showed an infrastructure of positions to address child protection and safety compared to fewer positions to oversee our behavioral health system. Are we setting ourselves up to neglect behavioral health? Please fund the nonprofit providers while those of us with the experience and expertise are still working in the system, so we can restore and enhance the robust continuum of care our children require. Childhood does not last forever, but the scars from years of neglect by our system are long-lasting. Thank you for listening.
Thank you. Up next is Orinthia Channer. Orinthia Channer here.
We have been attempting to promote them to panelists, and they have yet to accept.
Orinthia Channer, if you can hear me, if you don't accept being promoted, we cannot promote you and you cannot speak. So please try to do so.
If you could please log off and log back on Zoom if you're having difficulty. Thank you.
Up next is Thomas Farakar. Thomas?
We have number 142, Michael Bondi, going in place of Thomas.
Okay. Where is he? Michael Bondi? Is he online? Are you promoting him now? Got it.
Michael, please accept the promotion to panelist.
Up next is Ruth Groby. Ruth Groby. Floor is yours, ma'am.
Thank you. Honorable members of the Appropriations Committee. My name is Ruth Groby from Farmington, and I serve as Secretary of the Citizens Coalition for Equal Access, a grassroots disability advocacy organization. I have offered testimony for several years regarding the needs of our state's disability community, but never with as much distress as I am presently feeling at the governor's proposal to end the Community First Choice Program, or CFC. The elimination of CFC will start to undo 11 years of progress toward integrating people with disabilities into our community life. As a person without a disability, I lived the first 50 years of my life clueless, with almost no exposure to the lives of people with disabilities. But in the most recent 24 years, thanks to programs like CFC, I have made the acquaintance of extraordinarily courageous people such as Mary Ann Langton, Sandra Roberts, and Suzanne Garaffa, all of whom are giving testimony today about what a devastating impact the elimination of CFC would have on their lives. As I have gotten to know people with disabilities, it has become extremely evident that their full and equitable participation in the life of our society has been impeded by misconceptions and other attitudinal barriers. I have observed how clueless and uninterested many abled people are, and after years of trying to get the governor to learn more about disability, I deeply regret that I now include him in the clueless category. His proposal to replace CFC with some kind of adjustment to the HCBS waivers is vague, unrealistic, and disingenuous. The waivers are already underfunded, and most of them have years-long waiting lists. Moreover, the governor's claims of saving money are also unfounded because, on average, CFC expenses are less than nursing home expenses for the same level of care. My friend and many other acquaintances with disabilities are very afraid that the termination of CFC will result in their being confined to nursing homes. Which brings me to the self-interest part of my testimony. I am 74 years old and presently in good health, but serious and debilitating health issues could be right around the corner. Nursing homes are already struggling and understaffed. How much worse will it be when they have to accommodate thousands of former CFC participants, as well as people who would have been eligible for the program in the future? If I or my husband need a nursing home bed, will there be any available? At present, people with disabilities are being abandoned by the federal government, but I thought that my state was going to stand strong. The proposal to end Community First Choice will not save us any money, and it will cost us our souls. Amen. Thank you.
Thank you. Up next is Suzanne. Are you testifying now too?
Yeah, Ruth is gonna read for me.
Can somebody help her get that microphone, guys? Could you get that microphone closer to her, please?
Ruth is gonna read for me.
Okay, thank you. Never mind.
Members of the Appropriations Committee, my name is Suzanne Garaffa, and I live in West Hartford. Thank you for the opportunity to provide testimony on the governor's adjustments for human services agencies in the fiscal year 2027 budget. Pages 10 through 11 of the governor's narrative include a proposal to eliminate entirely the Community First Choice program, a critical program that assists individuals with disabilities in transitioning from and staying out of nursing facilities, including me. I am devastated by this proposal, especially since the suggested alternatives to Community First Choice are vague and unfunded at best, with most of the current waiver programs having years-long waiting lists, which I believe is a major reason CFC was created in the first place. I have had cerebral palsy since birth and have been in Connecticut since 1987. I was one of the first people to go on CFC, which allows me to hire my own personal care attendants. At the time that I enrolled in the program, I chose it because I was having so much trouble with agencies. If I have to go back to getting my PCAs through agencies, it will severely limit the activities that give my life meaning. For example, my PCA wouldn't be able to come to the Capitol with me. As another example, I would have to be home at a certain time each day in order to go to bed. Even worse, I might not get any services at all because the waiver the governor wants to put me into already has a years-long waiting list. Which brings me to the scariest alternative yet, ending up in a nursing home. After all the work I have done to stay independent, it would kill me to become non-independent. Moreover, it would be far more expensive than my present situation, and statistics show that this is true for the vast majority of CFC enrollees. And last, a word about people who will develop the need for an option like Community First Choice in the future. Since the passage of the ADA, our country has been working on helping people with disabilities to integrate into the community and be seen and heard by their fellow Americans. Connecticut's official long-term care plan calls for increasing, not decreasing, the percentage of people receiving services outside of institutions. Eliminating community first choice flies in the face of that important goal and will send us further backward as people newly needing CFC are denied any services. Does the governor really want us to go back to being institutionalized and isolated? Please help him to find a more humane way forward by opposing this deeply troubling budget item. Thank you very much.
Thank you. Up next is Meg Gorman. Is Meg Gorman here? All right, you're up.
All right, I'm next. Hello, everyone. My name is Megan Gorman. I am with Community Mental Health Affiliates, CMHA. We are one of the largest behavioral health providers in the state of Connecticut. We serve over 7,500 individuals, children, and families from all across the state. We serve at least one person from every of our 169 towns. We are an organization that provides services through funding provided by DCF, DEMIS. As an organization, over 80% of our clients rely on Medicaid. And consistently, we are brought to rooms like this where we are once again asked to provide evidence and details and statistics and numbers about why we need more funding. Why is it justified? And I've had conversations with many of the representatives, many advocates in this room, and it comes to a point where you have to ask, what are the reasons for not doing this? I have been grateful to be here today and listen to so much compassion and testimony from other individuals who really care. And I know many of you do as well. Because at the end of the day, we can care all we can, and there's a limit to it, because we are not only nonprofits, but we are employers. We struggle with the same costs as many small businesses when it comes to insurance and liability and the ever-increasing costs of just doing what we do and facing consistent, I will say, letdowns when it comes to the funding. We're grateful for the modest increases that were affected in the fiscal year 27 budget, but we are here because time and time again, we need more funding. The $155 million that myself and other nonprofits are asking for this year, it sounds like a large number, but it's truly not. Because when you measure these numbers, sure, you're looking at a line item in a budget, they're just numbers. But look at this room. These people are not numbers. The people that they are here with, who are supporting them, are community members, neighbors, friends, family. And if we don't invest in that, what are we really saving our money for here in Connecticut? I applaud the great progress that has been made in spending down on the unfunded pension liability. We're upwards of 60-something% funded now. We will likely always carry that debt, but the sins of the father, so to say, can't be passed on to the shoulders of individuals who can't do anything to change that situation, but all we can do is come here and testify again and again. I implore you all to listen to your heart and your compassion and know that it's not just a matter of applauding us or thanking us for our testimony and service, but I really encourage you to work with your colleagues within and across the aisle to draw the line in the sand, because we can't continue to survive in these situations. My organization, as I said, we heavily have so many clients that rely on Medicaid. We can't continue to stretch anymore. I encourage you to affect the Medicaid reimbursement rates that are almost 117% lower than states of comparable size to Connecticut. That is desperately needed. Please see to the Medicaid rates. And wherever possible, I encourage you to advocate for the additional $155 million for nonprofits. Thank you.
Thank you. So just so everybody knows, there's a couple things. We have 5 people that I'm going to be calling on that are on the front page that through a variety of mechanisms were not here. And I also want to say, all of us here today, many of us transfer to online afterwards, and I've noticed over and over again, CTN only shows this phalanx of chairs empty. But Representative Walker and I were online until close to 1:30, 2 o'clock last night, and so were many other colleagues. And I just want to let you all know that we are all paying attention to all that you are talking about. And I think we're going to work with CTN to come up with a visual that actually shows what's going on. Whether it can show the blocks that show that we are online listening to you, or some other method. But I just wanted to let everybody know that we are not listening to what you have to say. Up next is going back to number 14, Giselle Johnson. Is Giselle Johnson here? Okay, I'm going to go to the next one. After that is Emerson Zacina. Emerson? Okay. Did you give me a bad list? Up next is Carla Valentina. Is Carla Valentina here?
She's online.
Carla?
She's rejoining as panelist now.
Okay. Carla, there you go. Carla, just unmute. There you go. The floor is yours.
Can you hear me?
Yes, we can hear you. Go ahead.
Okay. Okay. Dear chairs and members of the Appropriation Human Services Subcommittee, my name is Valentina Diaz, and I am a college student at Gateway Community College in New Haven and a member organizer with Connecticut Students for a Dream. Thank you for the opportunity to testify on HB 5032, an act adjusting the state budget for the biennium ending June 30, 2027, specifically as it relates to the Department of Social Services budget. Connecticut has made important progress by extending coverage to all income-eligible children 15 years old and younger, as well as providing prenatal and postpartum coverage regardless of immigration status. However, too many of our neighbors still lack access to affordable healthcare. Federal policies, including H.R. 1, have further restricted coverage options for both lawfully present immigrants and U.S. citizens, putting more families at risk of losing care. I strongly support Husky funding for our immigrant communities and urge the committee to fund coverage through the state-funded program for Connecticut residents at risk of losing their health coverage due to federal costs, regardless of immigration status. I also urge to increase Medicaid reimbursement rates and invest in community health workers so that current Husky residents can access timely, quality care. Healthcare is not a privilege, it is a basic human need. As an immigrant and as someone who works closely with immigrant families, I have seen how access to healthcare determines whether a family remains stable or falls into crisis. Protecting Husky for immigrants, for protecting Husky for our immigrant community means protecting children, pregnant people, and working families who are already doing everything they can do to survive and and contribute to Connecticut. For me personally, living without insurance has been extremely difficult. When I get sick, I often push through it because I am afraid of the high cost of medical bills. I constantly feel tired, but I avoid getting blood work or seeing a doctor because I can simply not afford it. As a woman, I'm not able to receive routine preventing care like annual exams, or women health exams. Care that is considered basic and essential. It is heartbreaking to know that I am not the only one making these choices. No one should have neglect their health out of fear of financial ruin and HR1, will only make this a reality for more people in our state. Protecting access to healthcare as a budget negotiations continue this legislative session will provide stability and peace of mind to thousands of children and families across the state. It allows children to grow up healthy, pregnant people to receive proper prenatal and postpartum care, and workers to seek preventing treatment instead of waiting until conditions become emergencies. Invest in healthcare strengthens our community and reduces long-term costs because preventive care is always less expensive than emergency intervention. Thank you for your time.
Thank you. Up next is Orenthia Channer. Orenthia Channer, you are online. The floor is yours.
Hi, everyone. Good afternoon. Good afternoon, Senator Osteen, Representative Walker, and honorable members of the Appropriations Committee. My name is Orenthia Channer, and I'm a community nurse coordinator with the Connecticut Department of Social Services Central Office. I've been in this role for 6 years, and throughout that time, we have struggled to keep up with the demand because we simply do not have the staff to handle the volume of requests that we receive. We serve more than 40,000 people across the state of Connecticut, all with varying and often complex medical needs. Our role is essential to nearly everything DSS does. No program or individual budget is approved until it has been reviewed and approved by our office. So why the state believes underfunding and understaffing such a vital office is unacceptable and is beyond me. Saying we are understaffed is an understatement. We could nearly double our current workforce and still only reach what could be called manageable. We would never get truly ahead. The work never stops and it constantly evolves, and new cases come in every single day. We connect community members with critical services and determine eligibility for essential programs. Our work directly impacts whether people receive the healthcare and support they need. We want to do this work in a timely manner, but in reality, this work may be working through our essential caseload can suddenly change when more urgent situation comes in. Someone becomes hospitalized, someone in crisis, someone facing a serious health emergency. That case must be immediately prioritized. Without adequate staffing, responding to urgent needs means other cases fall further behind. We need more staff so we can respond to emergencies and keep up with the rest of our workload. Our work is essential not only for connecting people to care, but also for preventing waste of services and public funds. But we cannot oversee programs effectively and efficiently without the staffing to do so. The state of Connecticut must be willing to invest more to provide DSS with the funding and personnel that is needed to manage an ever-increasing workload. Until Connecticut truly recognizes the value of every person working within DSS, from those of us coordinating care at the system level to the frontline healthcare workers delivering that care, this problem will not be solved. You cannot ignore this any longer. The consequences are already visible. They are standing in front of you. They are at our street corners, in hospitals, in homes, wherever someone cannot access the care they need. And eventually, this will not be abstract. It will reach our own households when a family member or even you need that care and cannot get it. Thank you.
Thank you. Up next is Michael Biondi.
Senator Alston, Representative Walker, Senator Summers, Representative Nuccio, and members of the committee. My name is Dr. Michael Biondi, and I am a licensed and practicing radiologist in the greater Hartford area, and also serve as president of the Radiology Society of Connecticut. We appreciate having the opportunity to comment on the governor's proposed budget for the Department of Social Services. My colleague, Dr. Adam Kay, has also submitted testimony for your review on the issue of Medicaid rates for providers. A little background. In 2015, DSS implemented significant cuts to the fees paid to independent radiology practices. They were so steep that one office designed to serve the needs of Medicaid patients in the Asylum Hill area, about a mile from the Capitol, had no alternative but to shutter their doors and to close. Low reimbursement rates have continued to put pressure on outpatient imaging offices that provide the full range of imaging services from mammograms to MRIs to all patients regardless of insurance. These outpatient radiology offices allow patients to get the radiology services studies that they need more conveniently than going to a busy acute care hospital, especially for routine outpatient and screening exams. You can help secure the future of these critical practice settings. Better Medicaid rates will play a big role. I know I'm preaching to the choir on this subject. Your committee has always stood for doing what you can to ensure that low-income residents can access health care. Our profession is also committed to that. You funded rate increases both years of the biennial budget. Please retain this, and if possible, increase it in fiscal year 2027 to reflect the higher costs we are experiencing right now and to deliver health care to our patients. Thank you for considering the views of the Radiology Society of Connecticut.
Thank you. Up next is Giselle Johnson. Giselle Johnson. Okay, the floor is yours.
Good afternoon. Good afternoon, Senator Olston, Representative Walker, honorable members of the Appropriations Committee. Sorry about being late. My name is Giselle Johnson. I am a personal care attendant, PCA, if you will. I've been a PCA for about 9 months. And in those 9 months, my life has been turned upside down since taking this job, unfortunately. It has nothing to do with the demands of the job itself. I've always helped care for family members, compassion, desire to help. Others have always come naturally to me. This work felt like the right step. It felt like the right fit for me, if you will. So did my consumer. She is, unfortunately, a 2-time breast cancer survivor and a 2-time lung cancer survivor. At 78 years old, she is still going strong. And she is also diabetic. Yet every single day she shows up and fights through adversity and does it with a smile. And I know her own personal story. She's been surviving on her own since she was 14 years old. But in my 9 months as a PCA, I have struggled multiple times just to get paid. At first, GT Independence told me they did not have the proper paperwork for my consumer, so my hours were not approved. But then I was also still told to keep working. Then I was told by the Department of Social Services that all the paperwork was in order and that GTI was making the mistakes. Then it became a game of back and forth. Back and forth it went, with each side blaming the other and no one fixing the actual problem. As a result, I went nearly 3 months without pay. After just catching up and finding some balance in my life. Could you survive without being paid for 3 months during the holiday season? Try being 28 years old, living on your own since I was 16, mind you, paying for your first apartment with friends, then the paychecks just stopped. No warning, no heads up, nothing. It was absolutely devastating. It is impossible to stay afloat like that. You do not have the significant savings and could even start if you wanted to. Family helps when they can, but there's only so much they can do. One roommate was laid off because the holiday season was coming and going. Another was diagnosed with an illness, MS, that prevented her from working. We lost our apartment and all 5 of us quickly became homeless. The youngest of us being only 23 years old. It was preventable if I had been paid. I may have been able to support my friends and myself who fell on hard times. But because GTI didn't do its job, 5 young adults just getting their starts were all forced out onto the streets. Personally, me and one of my roommates who was homeless was living on the train tracks in Bridgeport, Connecticut. Taking shifts and sleeping just so we could watch each other's backs. Some were forced out into the streets and some were forced to go out into the streets and back to their parents' homes. Personally, I didn't have a place to go. I didn't have that option. Instead, I bounced from place to place, couch to couch, but you can only do that for so long. Still, I persevered. Through all of this, I continued to show up for my consumer because she depends on me. Every single week, I pushed and pushed for the paychecks, and I not only needed but earned. It took months, literal months, to finally restore my pay, but I still have never been paid for all that time. For those 3 months, I was going unpaid. The paperwork issues that caused the delay were proven not to be the issues at all. The paperwork had always been there, and I personally had filled out and handed that paperwork in 5 times. In the end, the only people who suffered were me and my consumer, even though we did everything right. Enough is enough, and please hold DSS and GTI accountable for their mistakes. Make DSS provide a payroll system that works, one that pays us every single week without endless phone calls, emails, and grievances that never get answered. Increase DSS funding, but make sure it is spent on programs that truly support the workers and families who depend on them. Because caregivers have suffered long enough at the hands of DSS and GTI, I think we all just need some justice. Thank you for listening. I'm happy to answer any additional questions.
Thank you very much. Appreciate it. Up next is Emerson Zacina, number 16 online.
Dear chairs and members of the Appropriations Human Service Subcommittee, my name is Emerson Zacina. I'm a student and member organizer with Connecticut Students for a Dream, and I study political science at the University of Connecticut. Thank you for the opportunity to testify on HB 5032, an act adjusting the state budget for the biennium ending on June 30th, 2027, as it relates to the Department of Social Services budget. Connecticut has made great progress to provide coverage to all income-eligible children 15 years old and younger, as well as prenatal and postpartum coverage, regardless of immigration status. I want to thank the governor for maintaining this coverage in the proposed budget. Yet, too many of our neighbors continue to go without access to affordable coverage and policies like HR, and have further restricted coverage options for lawfully present immigrants and citizens. I'm in favor of protecting Husky funding for our immigrant community, and I ask that the committee find coverage through the state-funded programs for Connecticut residents at risk of losing their healthcare coverage due to federal cuts, regardless of immigration status. Protecting the progress that we have made for immigrants across the state is a deeply personal one. I've seen firsthand the effects of what a lack of health insurance can do not only to individuals, but to entire families. Undocumented immigrants are among our most vulnerable community members, and like every human on earth, they deserve access to health care that allows them to live with dignity and safety. They deserve to be treated and regarded with respect. As someone who qualifies for Medicaid, this program has provided me with the access to essential healthcare services that I would not otherwise be able to afford. Medicaid has allowed me to seek preventative care, address health concerns early, all while I'm able to focus on my education and future without the constant fear of medical debt or untreated illness. It's given me the peace of mind knowing that my health is not something I have to sacrifice in order to survive. To me, the issue of protecting Medicaid coverage is not just about health, but it's rather about community well-being. When individuals have access to healthcare, they're able to remain productive in their day-to-day lives. They can attend school, go to work, and be active members in their community without the shadowing fear of falling ill and sacrificing their livelihood to pay for their healthcare costs. Healthcare is not a luxury, it is a necessity. And without life-saving programs, many children and young people now covered would be forced to delay or avoid care entirely, leading to worsening health outcomes and higher long-term costs for everyone. I asked the Appropriations Committee to protect Husky eligibility as budget negotiations continue this legislative session for all income-eligible kids, prenatal and postpartum coverage, regardless of their immigration status. and to create a plan that protects all Connecticut residents at risk of losing their healthcare coverage. Healthcare needs do not end because of new eligibility requirements. I also ask that the committee use the state-funded programs to protect residents' coverage, to increase Medicaid reimbursement rates, and to fund community health workers. Doing this affirms something deeply human. Our lives are worthy of care and attention, that our well-being matters, and that we too deserve the chance to wake up each day and pursue our education and build a future without the shadow of preventable suffering hanging over us. At its core, this is not about policy, it is about people, it is about dignity, and it is about hope. It is about the kind of state that we choose to be and represent. Thank you for your time and consideration.
Thank you. Up next is Stephen Thornquist. Stephen?
Thank you. Sorry, I was on mute. Thank you, Senator Austin and Representative Walker and the other distinguished members of the Appropriations Committee. Thank you for the opportunity to testify on an act adjusting the state budget for the biennium, specifically to share my concerns regarding Medicaid reimbursement rates. I'm Steve Thornquist. I'm a pediatric ophthalmologist from Bethany. Now, I retired from active practice in Waterbury a little over a year ago, but I'd like to draw your attention to the critical need for improved access to pediatric eye care and pediatric specialty care in general in Connecticut. This crisis is driven by a number of factors, but given the high percentage of children on Husky, the low reimbursement levels for care in that program are a significant driver. According to the Kaiser Family Foundation, Connecticut ranks 29th out of the 50 states in District of Columbia in Medicaid payments for all services as a percentage of Medicare. When we look at specialty care like pediatric eye care, Connecticut drops to 45th out of 50. This is not simply a problem of physician income. Every doctor's practice is not just a provider of care. It is a business that must respond to the economic pressures of all businesses. Collectively, physicians' offices in this state provide jobs for well over 100,000 residents. Every office also needs to pay rent or building maintenance, utilities, update equipment, which is very expensive, in order to remain state-of-the-art and give the best care to our patients, and to keep competitive and reasonable wages for all of those employees. Literally, all of these costs rise every year. Medicaid rates, on the other hand, were never lavish, but have maintained static for over 20 years. It is simply not practical for many offices to keep seeing Husky patients and continue to keep the doors open. When a practice closes, all of its patients lose access to that care, not just the Husky patients. Practices are therefore forced to make the difficult choice of which patients can no longer be supported in order to continue to deliver care to the remainder. This is particularly true for pediatric specialty practices like pediatric ophthalmology. A large percentage of our patient population is on Husky compared to adult practices. Over 366,000 children in Connecticut are covered by Husky out of the roughly 750,000 children who live here. Now, by my calculations, that's 48%, but Kaiser Family Foundation quoted 43% in 2023. Current reimbursement rates are often below costs, and it is unsustainable to lose money on 40% of your visits. As an anecdote, my brother is a primary care physician in Alaska, in Anchorage. He says that most physicians there see Medicaid with no trouble. It is not a problem for patients or doctors. Patients have access. Alaska pays 130% of Medicare compared to Connecticut's 66%. My retirement left only 9 pediatric ophthalmologists in the state. We are now down to 8, and of those, only 4 see Husky patients at all. 4 doctors for over 366,000 patients. That is not realistic and represents a chasm of access for our most vulnerable patients. We as a society have a moral duty to address that chasm. I guess my time is up, but I'll just say, but prioritizing pediatric eye care is not only a moral imperative, but also a smart economic strategy. Studies show that every dollar spent on pediatric eye care returns as much as $36 to the economy. Thank you for your time.
Thank you. Up next is Sasha Marie Nieves. Sasha Marie.
They have an interpreter that is online.
Go ahead.
Dear Senator Olson, Representative Walker, Senator Lester, Representative Gilchrist, and esteemed members of the Appropriations Committee. My name is Sasha Marie Nieves. I am currently a community health worker, CAC, refugee case manager, and outreach specialist for the Proyecto de Nueva Vida with Optimus Healthcare in Bridgeport, Connecticut. I work for Optimus Healthcare, which mission is to act as a lifelong partner in health delivering high-quality, patient-centered medical, dental, and behavioral health care to communities in southwestern Connecticut, regardless of their ability to pay. And that's the key term, regardless of their ability to pay. As a CHW, I am here today to provide testimony and support in regards to the HB 302. In 2023, Connecticut passed legislation requiring Medicaid reimbursement for community health workers. This was a critical decision that was recognized that the essential role community health workers play in improving associated with health outcomes, advancing health equity, preventing costly health crises, as well as cost savings associated with CHW programs. However, this policy has not been fully implemented. 30 states have already reimbursed CHW through Medicaid. Connecticut is behind. And I would say that's an understatement. This is important to me because as a community health worker, I assist patients with many disparities that affect their medical health, but also their health in general. Day in and day out, I assist patients by listening, assisting, and walking through with the gaps in care that they experience, not only with medical, but also due to the social determinants of health. And that's simple as something as filling out forms, explaining health information that's given to them on paperwork that they cannot understand because they cannot read, they cannot write. I'm also assisting with scheduling rides to and from medical appointments through Medicaid, which is non-emergency medical transportation. Also, advocating for patients and individuals who do not feel that their voice are heard. I assist these patients day in and day out. I wake up every day very thankful to be doing it for 5 years. And I wish I would have had someone in my position when I needed help and I needed guidance in the medical field. This career has not only changed my life, but has changed the lives of many of the patients that I assist, as well as many of the individuals that I work with. We do this day in and day out, understanding that we may not be paid, we may not have a position for the whole year or for the next year, but we continue to come in and day out and do what we do for our patients because we know they need the help, and the gaps in care are just getting bigger and bigger. And this Swiss cheese effect is actually taking over the state. Many states are ahead of us, and I feel like as a state and unified, we should be able to reimburse through Medicaid, but also support the other programs that we need to support. Thank you so much for everything today.
Thank you. Up next is Suzanne Lagarde online. Suzanne?
Yes, thank you. Senator Austin, Representative Walker, members of the Appropriations Committee. My name is Dr. Suzanne Lagarde. I'm the CEO of Fairhaven Community Healthcare in New Haven. Our health center cares for over 38,000 unique individuals annually, providing a wide range of services such as adult and pediatric primary care, behavioral health, addiction services, school-based health center services, midwifery, and dental care. In addition, we provide in-house pharmacy services at 3 of our largest locations, allowing many patients to obtain pharmaceuticals at steeply discounted prices. As you are all aware, the federal landscape with respect to healthcare access has changed dramatically over the past year. With the passage of the One Big Beautiful Bill Act, or H.R. 1, many Connecticut residents will lose Medicaid coverage. Many have already lost SNAP coverage despite clear evidence of worsening food insecurity throughout the state. These problems will worsen over the coming year. Additionally, the issuance of executive orders, most notably those impacting immigrants and those putting federal funding at risk, add to the uncertainty and the challenges. To date, this legislature and governor have shown remarkable fortitude in combating these challenges with the passage of HB 8002, which provides for $500 million to be used to mitigate these negative impacts imposed by the federal government. However, these dollars will run out at the end of this fiscal year, and there is little doubt that the needs will only escalate. I am particularly worried about the attempts by the federal government to reinterpret a 1996 law, Personal Responsibility and Work Opportunity Reconciliation Act, also called PERORA, also called the Clinton Welfare Act of 1996. Because of the commendable efforts of our Attorney General, Connecticut is one of 21 states in the District of Columbia that currently benefit from a temporary injunction against implementation of this new interpretation of PERORA. Without this injunction, all of Connecticut's 17 health centers would be required to withhold, quote, federal public benefits from, quote, non-qualified aliens. However, this litigation is currently in summary judgment. We expect a decision over the coming months. If the federal government's attempts to change the interpretation of this 30-year-old law succeed, the health care of tens of thousands of current Connecticut residents will be immediately jeopardized. I urge this body to ensure that dollars are available to support any and all efforts to provide basic health care to all Connecticut residents should this disaster come to pass. In closing, should the courts decide against us and determine that in the United States of America it is illegal to provide health care to non-qualified aliens, then Connecticut should do what is humanely and morally correct and ensure that no one in our state is left behind. Thank you so much for all you do for our state. Thank you.
Thank you. Up next is Danielle West. Danielle West.
They are not online.
Huh? Up next is Rigoberto. Rigoberto. Are they online?
Okay.
They are
Hello.
online. We are just.
Mi nombre es Rigoberto.
There you go.
Vivo en Bridgeport. ¿Esperamos?
Go ahead.
Okay. Thank you.
Adelante.
Mi nombre es Rigoberto. Vivo en Bridgeport, Connecticut. Soy líder de la organización Se Hace Camino Connecticut. Gracias por la oportunidad de testificar sobre H5032. Soy refugiado de este país y padre de 2 hijos, los cuales, gracias a Dios, tenemos seguro médico por el programa de refugiados. Desde que llegué a este país, nos hemos visto con el médico y hemos visitado emergencias cuando lo necesitamos. Para mí y mis hijos, ha sido una bendición tener seguro médico, pero ahora me siento ansioso porque con los recortes federales corre el riesgo de que yo, junto a otros refugiados, nos enfrentemos a más obstáculos para acceder a la salud una vez que cambien los requisitos de elegibilidad en octubre y quedarnos sin seguro médico. Solo de pensar en que no tenemos acceso médico para mí o mis hijos, esto me afectaría emocionalmente, económicamente. Tendría que pensar que voy a priorizar llevar a sus hijos al doctor o poner un plato de comida en mi mesa. Esto nos limita en muchas cosas. Yo les pido a los legisladores que defiendan el seguro médico para todos y que usen el programa estatal de Hoshki para cubrir a las personas que ya perdieron o van a perder el seguro. Todas las familias merecemos tener acceso a seguro médico, ya que esto es una o un privilegio, sino una necesidad. Exigimos como seres humanos el derecho a tener una vida saludable y prevenir otras condiciones para tener una larga vida junto a nuestros familiares. Yo les pido al comité de asignación que protejan la elegibilidad de Hoshki para todos los niños que cumplen los requisitos de ingresos, las coberturas prenatal y posparto, independientemente de su estatus migratorio, y que creen un plan para proteger a todos los residentes de Connecticut en riesgo de perder su cobertura médica. La necesidad de atención médica no termina con la nueva elegibilidad. Gracias por su tiempo y por escucharme.
Dear members of the committee, my name is Rigoberto and I live in Bridgeport, Connecticut. I am a leader with the organization Make the Road Connecticut. Thank you for the opportunity to testify about HB 5032. I am a refugee in this country and the father of 2 children who, thank God, have health insurance through the refugee program. Since I arrived in this country, we have seen a doctor and visited the emergency room as needed. For my children and myself, having health insurance has been a blessing, but now I feel anxious because with the federal cuts, I, along with other refugees, risk facing even more obstacles to access healthcare once the eligibility requirements change in October. Just the thought of losing health insurance altogether is frightening. It will affect me emotionally and financially. I would have to decide whether to prioritize taking my children to the doctor or putting food on our table. This limits us in so many ways. I urge legislators to defend health insurance for all and to use the state's Husky program to cover people who have already lost or are about to lose their insurance. All families deserve access to health insurance. This is not a privilege, but a necessity. As human beings, we demand the right to a healthy life and to prevent other conditions so we can live long lives with our families. I urge the Appropriations Committee to protect Husky eligibility for all children who meet the income requirements, including prenatal and postpartum coverage, regardless of immigration status, and to create a plan to protect all Connecticut residents at risk of losing their health coverage. Healthcare needs do not end with new eligibility. Thank you for your time.
Thank you. Up next is George Reed Perry. George Reed Perry. Thank you, sir. Floor is yours.
Good afternoon, Madam Chair and members of the Appropriations Committee. Good to see you, Representative Gilchrist. My name is George Reed Perry. I'm the Chief Operating Officer at Loomability. I'm also a board member of the Connecticut Nonprofit Alliance. Loomability is the largest nonprofit birth-to-3 provider in the state, and in addition, we provide services to adults with intellectual and developmental disabilities, serving over 2,200 children and families across 68 towns each year. I want to thank you for the opportunity to testify and speak directly to the need for funding support of Connecticut's birth-to-3 program. The governor's recommendation to increase birth-to-3 funding under DSS by $4.5 million is an important step to bringing funding closer to where it needs to be, but there needs to be more progress made. According to the state's own rate study, current reimbursement rates for birth-to-3 do not cover the full cost of services. In addition, the cost data in the report is already 3 years old, meaning that underfunding has worsened. Overall service intensity, which is the number of hours provided to each children, has decreased, and we're only providing 69% of the services that we were providing in FY29. While the demand is increasing, the workforce issues have increased significantly. Without sustainable funding for birth-to-3 services, children risk poor developmental outcomes, and families are left without the full support they need during a critical stage of growth. When early intervention isn't provided at the level needed, children may require more intensive long-term and costly special education services once they enter the school system. Limited support also leaves child care providers without the tools to address behavioral needs, increasing the likelihood of expulsion, creating unsustainable child care arrangements, and this makes it harder for parents to maintain employment, negatively affecting workforce participation in the broader economy. So our asks for this year are to add funds to the DSS line budget for a total of $17.7 million, which is in alignment with the state-sanctioned cost study, making it possible for agencies to continue to serve children and their families. Support this investment of not being tied to any proposed tiered rates, which was removed from legislation last year, but needs to also make sure it doesn't go into legislation this year, as this model will not support workforce recruitment or program stability, and implement legislative language to ensure that DSS funding for birth to 3 rates are reviewed and adjusted consistent to keep pace with inflation. I want to thank you for your time today on behalf of the families that we provide services to. Thank you.
Thank you. Up next is Dale Elliott. Is Dale Elliott here? Here you go, sir.
Good afternoon, Senator Osteen and Representative Walker, and the honorable members of the committee. My name is Dale Elliott. I am a dad and I am a personal care assistant for my son Dakota. I am also a proud member of SEIU 1199 New England. Dakota is 21 years old and lives with profound disabilities. Just like so many other families across Connecticut, we rely on Medicaid so he can stay healthy and care at home. However, the certainty here is about cuts or changes or sticklers requirements coming for Medicaid. And I stand here today because I need people to understand what all those changes will look like in real life. Sometimes it's not even the cuts you feel at first. It's the difficulties of getting there. It's the way the system makes you prove yourself over and over again. It's the paperwork, the deadlines, the letters that show up late or to wrong address. It's the phone calls where you sit on hold forever. It's the fear that if you miss one form or one appointment, one box checked wrong, your child could lose coverage, like I lost coverage. Not because they don't qualify, but because the system is being set up that way. That makes it too easy for the families to fall through the cracks. My son's mother and I have always managed this system ever since Dakota was 4 years old. He has cared for him, and for a long time it was possible. But now it's become clear that the federal government wants to make the process more complicated, more confusing, and more likely to families to lose coverage, like I lost coverage. And when Medicaid gets harder to qualify for or harder to keep people, don't just lose insurance, families get pushed into crisis. People end up in emergency room instead of getting the proper care they need. And those with disabilities get pushed at risk when they should be protected. Here in Connecticut, we can't afford that, not morally, not economically. Because if Medicaid money stops coming in to our healthcare system, you don't just hurt the patients. You lose workers, you lose jobs, and you push the whole system closer to collapsing. So my message to you, our leaders, is simple. Don't let Washington's chaos become Connecticut's chaos. Don't create systems where families lose coverage because they miss a form. We need our state to step in and provide the funding that is necessary to ensure your family, like mine, This isn't just politics. It's real life. Thank you.
Aubrey Knudsen? No? She should be on, she's not online? Okay. Thomas Fiorento? Thomas?
Hi, thank you. I'm Tom Fiorentino, a member of the ARC Connecticut Board of Directors, and also, as luck would have it, the chair of the DSS subcommittee that that advises on community first choice. For the past year, my community, those in the IDD community, have been looking over our shoulders, concerned, terrified about what might be coming out of Washington, D.C., out of the federal government. We did not expect to be blindsided by our own state government with a cut, the proposed elimination of community first choice. We hear as a rationale that this is an expensive program, costs too much. Well, it is a bargain on a per person basis when compared to other state Medicaid programs that have somehow evaded the same kind of scrutiny and review. And also, I would just say to you, the cost reflects a genuine need. These aren't people going in for elective surgery. They are desperate. So when you see a cost, even though per person it is quite reasonable and it seems like it's a lot, yeah, in part because Connecticut has so underfunded almost every other portion of its social safety net when it comes to the IDD community. Which brings me to the suggested alternative to CFC, which is to use waivers. We have a sad history in Connecticut with waivers. We don't fund them. We cap them. Currently, almost all, except for the elderly waiver that all these folks, these 7,200 folks would go to, they're all capped. And one of the problems with the waivers is for those with the greatest needs in the IDD community, they don't have enough money in those budgets to allow people to get services. That's why, in part, they're on CFC. And now we're going to eliminate it. And by the by, how are we going to eliminate it? Well, we're going to cap it. Apparently, what we're going to do is keep the people on it. All right. Anybody new coming along, though, what happens to them? Because this plan is that we are going to apply, presumably, for a new waiver, which they don't know whether they will get. And in the meantime, whatever length of time that process takes, people who are in desperate need of new services, well, they can't get into CFC because that's capped. Our waivers are capped. There's no new money going into them. And in any case, a lot of folks who are on CFC don't qualify for our existing waivers, which is why we need a new one. What happens to them? Well, what kind of, this is like someone is desperately in need of oxygen. You come in and say, we're going to replace that tube, pull out the tube and go, and we've ordered a new one. Well, that's not how you run programs. You know, our skepticism, right? I didn't realize that went by so quickly. Can I just say to you, having sat here today real quickly, it's so clear that some people in our government have lost sight of why we have a state government and that we have to get back to an understanding that it is for more than amassing budget surpluses and paying down state pension debt. I implore you, please preserve this program. And thank you so much for your time.
Thank you, sir. Yes, we should all ask ourselves, what is government for? Thank you. Next, Lisa Romero. Liza Monero. Liza? Sorry, I thought that was an S.
Dear Senator Austin, Representative Walker, Senator Lesser, Representative Gilchrist, and esteemed members of the Appropriations Committee. My name is Liza Romero. I'm a resident of Stratford, Connecticut, and I serve as the Maternal Child Health Program Coordinator at Optimus Healthcare. Optimus' mission is to act as a lifelong partner in health, delivering high-quality, patient-centered medical, dental, and behavioral care to communities in southwestern Connecticut, regardless of ability to pay. I stand in support of HB 5032. In 2023, Connecticut passed legislation requiring Medicaid reimbursement for community health workers. This was a critical decision that recognized the essential role CHWs play in improving health outcomes, advancing equity, and preventing costly health crises, as well as the cost savings associated with CHW programs. However, this policy has not been fully implemented. CHWs are trusted frontline public healthcare workers who help residents navigate healthcare, access benefits, manage chronic conditions, and address social barriers such as housing, food insecurity, and transportation. CHWs meet people where they are and provide the support that keeps individuals healthier and out of emergency rooms and hospitals. On Monday, one of our doctors came to me to ask for help for a patient who delivered 2 weeks ago via C-section. This patient had been readmitted to the hospital for wound care. The patient was discharged on Sunday and advised to come to the clinic Monday. The clinic does not have the capacity to care for the wound that she has. I was able to contact the patient and tell her to stay home while the doctor was on the phone with Bridgeboro Hospital to arrange other treatment for her. She was able to get an appointment at Bridgeboro Hospital Clinic. However, when I called back to follow up with her, she said the appointment was for 10:30. She would not have transportation or care for her baby to make the appointment. Had I not taken that additional step to call her to follow up, she would have missed that appointment. Given her delicate state of health, we might have been facing something much more tragic. These are the things that we face day to day. This is just an example. I was raised in Bridgeport. I lived there most of my life. I lost my dad 2 weeks before turning 3. I became a teen mom, suffered through major postpartum depression. I was in an abusive relationship. My husband became an alcoholic. I lost him in 2012 due to suicide. I became a CHW, and through being a CHW, I have received many trainings. Combined with my lived experience, this allows me to connect with patients and serve my community better. I thank you for the opportunity to testify in support of HB 5032. I respectfully urge you to fully fund the implementation of medical reimbursement for CHWs. This investment will strengthen our health system, support a stable workforce, and improve healthcare outcomes across Connecticut. I also implore you to keep in mind that we need sustainable living wages. As it has been mentioned, everything is rising. And last year, we lost our funding, PCMH Plus. We were in limbo. We received a grant for this year. Once December comes, we don't have any income to continue to support us. Thank you again. My name is Liza Romero.
Thank you, and thank you for your testimony. Wow. Joshua Kelly?
Thank you very much, Representative Walker. Distinguished chairs, vice chairs, ranking members, and committee members. First and foremost, I want to echo the sentiments of the previous speaker. I'll be speaking to CHW Medicaid reimbursement as well. And I just want to acknowledge that that was very powerful. Thank you for holding this public hearing today. My name is Joshua Steele Kelly. I am the CEO of the Thames Valley Council for Community Action, one of our state's 9 federally designated community action agencies with a mission to abolish poverty in our catchment area. We administer over 30 programs and serve 55 different towns. My agency is 95% state and federally funded, so we're feeling the effects of the federal government right now. In 2025, I have seen the federal government take action to cut or eliminate SNAP benefits for as many as 58,000 Connecticut families, healthcare, and specific programs that TVCCA provides, including LIHEAP and CSBG being in the crosshairs. I'm here to tell you today that we are unable to make progress on our mission in a meaningful way with the resources on hand. The reality is that more people are falling towards poverty in our community than are finding their way out of it. Brave, bold action is needed if we're to reverse this trend. Poverty is a policy choice. It's in one of the richest states in our nation and one of the richest nations in the history of this planet. Surely we can do better than 10.2% of our population, over 300,000 people living under the federal poverty line. I ask you to consider 3 steps to improve our situation this year from TVCCA's perspective. First is to support senior nutrition. At TVCCA, we not only risk federal elimination of our programs, but we're risking programs becoming so costly that we have to shutter them. Our Meals on Wheels program is operating at a $300,000 loss this year and is projected to do so indefinitely as a result of low reimbursement rates for our meals. The federal funds reimbursing $5.12 per meal despite it costing $10.01 to produce. And that's acquiring, preparing, packaging, and delivering food. While Meals on Wheels has long been a federally supported program, the state needs to intervene or we risk losing the service that provides over 260,000 meals a year free of charge to at-home, high-risk seniors with limited other options to acquire a meal. In addition, I want to mention, as I said before, Medicaid reimbursement for community health workers. Public Act 23-186 requires Connecticut to pay CHW services to Medicaid enrollees for services to those enrollees, yet 3 years later, DSS has not implemented this requirement through the filing of a state plan amendment, and funding has not been provided by the state budget to date. We need this desperately. Lastly, during the COVID-19 pandemic, the state used American Rescue Plan Act funding to create a client support fund program, which was administered by community action agencies, designed to help COVID-impacted families with financially related issues that they were faced that presented a barrier to their climb out of poverty, particularly issues that aren't covered by other programs that are administered by the state. With the expiration of ARPA funding, we at TVCCA and other community action agencies are no longer able to help these clients that approach us. I call on the state to create a client support fund to be administered by our community action agencies in perpetuity to ensure that we remain nimble, flexible, and well-resourced so that we can meet the demands of the clients who are walking through our door. Thank you for your consideration of my testimony and your service to the state, and please feel free to get in touch at TVCCA if you have any questions. Thank you.
Thank you for your testimony, and we applaud community action agencies here. Thanks. Catherine Valletta? Is that close enough? Okay. I'm sorry if I butcher your names.
You did better than most people.
That's a good way to put it. Thank you.
Good afternoon, Representative Walker, Senator Austin, Representative Gilchrist, Senator Lesser, esteemed members of the subcommittee. My name is Catherine Villeda, and I'm the Coalition Director for Husky for Immigrants. Thank you for the opportunity to testify on HB 5032 ahead of the committee. Since 2019, Husky for Immigrants has worked towards extending affordable quality coverage options for income-eligible Connecticut residents who are excluded solely due to their immigration status. Today, I want to thank the governor for maintaining the coverage. For the coverage gains we have won over the years for children up to 15 and pregnant and postpartum individuals, regardless of their immigration status, in the biennium budget. And I'd also like to thank the leadership of the subcommittee for maintaining that over the years as well. These policy changes are already having a positive impact on our state, extending Husky coverage to nearly 20,000 residents to achieve coverage that they otherwise wouldn't have had, enabling people to access the care they need in a timely manner without waiting until a condition becomes a high-cost emergency. It is no secret that we find ourselves in challenging times with impending federal cuts due to H.R. 1 that will significantly impact our healthcare infrastructure here in Connecticut, as many have voiced throughout today. As the state works to address these cuts and continues to negotiate the state budget, it is critically important to maintain the commitment to continue to protect the coverage that has been gained. Similarly, H.R. 1 has further restricted coverage options for lawfully present immigrants and citizens, putting 186,000 Connecticut residents, including people with asylum and refugee status, green card holders, and U.S. citizens alike at risk of losing their coverage. Already, as of January 1st this year, an estimated 4,850 legal permanent residents with incomes under 100% of the federal poverty level have already lost their coverage for the covered CT program because of federal cuts to advance and enhance premium tax credits. More Connecticut residents, including refugees, parolees, asylees, victims of trafficking, Victims of domestic violence, among others, will also be at risk of losing their Husky coverage in October due to new eligibility requirements. Federal cuts don't have to mean coverage losses here in Connecticut. At Husky for Immigrants, we believe the state-funded program can be leveraged to prevent these gaps in care caused by federal policy changes for everyone at risk of losing their health care. Our coalition members have felt the ongoing attacks from the federal administration, both related to immigration enforcement, but also related to cuts to health care, and urge the state to not throw immigrant communities under the bus when assessing our response to federal cuts, a tactic that we unfortunately see too often utilized in DC. Connecticut is one of the wealthiest states and one of the wealthiest countries in the world, with a budget that is currently running in a surplus. And in light of these federal cuts, our state policies should prioritize strengthening current safety net programs, like raising Medicaid reimbursement rates, protecting the state-funded program, preserving the Community First Choice program, and funding community health workers for people who need it the most so that our state can sustain its achievements and become more equitable. Thank you for your time and consideration.
Thank you. Thank you for your testimony. Have a good day. Thank you.
Thank you, Representative.
Next, Alice Forrester. Hi, Alice. There you go.
Hi, Representative Walker and members of the Appropriation Committee. I'm sorry, I'm running my board meeting on the other Zoom, so I appreciate this time. I'm the
So that's okay.
That's true. I am the CEO of Clifford Beers Community Health Partners. I live in New Haven with my 3 children, and I represent 4 nonprofits in Connecticut. I represent Mid-Fairfield Community Care Center in Norwalk, Clifford Beers Community Care Center in New Haven region, and Youth Continuum, and Clifford Beers Community Health Partners. We run from Norwalk all the way through to Madison and have about 200 and so staff. I do not need to repeat what you've heard from the providers and what you'll hear today, what you heard last night, and what you'll hear the rest of the night. I am on the cusp of retiring after 27 years at Clifford Beers at the end of this fiscal year, and I have been the CEO Executive Director for the last 16. You know, I'm sure you're tired of hearing there's not enough. You know, I'm tired too. I'm tired because I have dreams of cash flow charts with red numbers and retrenchment lists plaguing my waking and dreaming hours. In October, the Care Center at Clifford Beers had to retrench 13, the Health Partners retrenched 13 positions, Care Center retrenched 10 in December, and we are in the process of shuttering Youth Continuum. These are desperate times. These are awful. It's my worst nightmare to leave the wonderful folks who will run Clifford Beers after I retire with this awful shortfall in funding related to DCF and Medicaid rates. I've just never understood after all these years how an outstanding state like Connecticut could leave the private providers holding the debt by not paying what the true cost or even close to the true cost of providing the services and to consistently add bureaucratic administrative requirements to be able to run the clinics that we do. After all these years, I know that no matter what, we can do better. You know, we have increased caseloads, we have increased our scheduling, we went to electronic health records. I have to explain to my boards of directors every time that the reason the outpatient, the core services that we run a deficit because you pay $93 on a service that costs well over $120. That reimbursement rate does not cover the costs. Providers holding the debt are, you know, working hard. We have seen the end of that with all of the disruption that's happening on the federal government. And I work very hard on many committees with many of you, in particular on the Transforming Children's Behavioral Health Committee. And we're looking for ways to build the current system of care, create efficiencies that would reduce the cost. The Medicaid supporting needs to be increased to $155 million, which is what we're suggesting for the fiscal year 2027. I beg you to do that, not just because you know me, but but because it's just time that we have the increase that we need to be able to pay our bills. Thank you.
Thank you, Allison. Thank you for all your services. Thank you so much. Is,
Thank you.
is Gary Steck here? Gary Steck? Gary Steck, no, okay. Okay. Jennifer Johnson. Jennifer Johnson?
Hi,
Hi. Go right
good
ahead.
afternoon. My name is Jennifer Johnson. I'm the administrator at Parkville Care Center in Hartford. Parkville has been providing nursing home care services in the community for 6 years. We are a 145-bed nursing home, and we have approximately 146 employees working at our facility. We're also members of the Connecticut Association of Healthcare Facilities. And our nursing home is challenged in delivering the highest quality of care that we can for our increasing number of residents. We're almost at full capacity with a 95% occupancy rate, but keeping up with the higher cost of serving so many more residents is our most significant challenge. It's difficult to keep up with the rising costs that we are experiencing. Some examples of that are the cost to provide adequate and nutritious meals. There are increasing levels of challenge every year. Being able to maintain medical equipment and to have proper supply levels because the costs have also risen. So there's difficulty in obtaining the needs that we have to provide quality care. Utility charges have almost doubled from the previous year, and few charges have resulted in a major increase as well. Our nursing home is now serving residents with more complex healthcare needs, but because of artificial caps in the Medicare acuity payment system, we are not being fully reimbursed for higher costs of these residents. The more complex residents we are serving and the increased number also have higher behavioral health needs, and this is not reflected in the rates either. We are grateful that the Connecticut General Assembly has recognized with staff wage and benefit enhancements that paying higher wages for nursing home staff is needed to retain and recruit badly needed staff, but the higher payments approximately pass directly through to the employees. This is why an inflation adjustment, uncapped acuity-based payment, and recognizing the behavioral health needs of our residents remain our most significant challenges, and why more funding in the Connecticut budget is needed to address these significant issues as our nursing homes serve residents in ever-increasing numbers. Thank you so much for listening and for your time today.
Thank you, and thank you for your testimony. Next, Ariana Jones. Oh, and you've got, and friends? Okay. You're the spokesperson, right? Get a picture of y'all. Somebody take a picture of it. Go right ahead.
Hello. Hi. Okay, good afternoon. My name is Rosie, and I am a proud citizen of the Newington
Thank you
District.
very much, Representative Walker.
No, hold it. No.
Can we restart my time?
Okay. It took you 5 minutes to see your picture, okay? Don't forget, you guys only have 3 minutes together, not individually, okay?
Understood.
Thank you.
Good afternoon. My name is Rosie, and I am a proud citizen of the Newington District. Please allow me to briefly talk to you about the Transitional Support for Emerging Adults, TSCA. This program focuses on providing services to teens and young adults within the foster care program. As someone who has aged out of foster care, I can proudly attest to the significant difference and impact this program has made in my life. I have been in 25 homes throughout my 17 years, one being an orphanage where I stayed from birth to age 6. All the trauma led me to become a very rebellious and disrespectful child. Towards the last of my high school years, everyone believed I would improve, but I just kept getting worse. I was enrolled into TSCA, and it has supported and guided me throughout the challenges of transitioning into adulthood. Their assistance with education, including college, has been particularly valuable. Because of the TSCA program and their help, I have started classes at Capital Community College for medical assistance, hence my outfit today. And I'm forever grateful for the program's investment in my future and its commitment to helping and empowering young people like me to succeed. The program also made it possible for me to work and create my own income. I believe programs like TSCA are crucial in ensuring the well-being and success of young people aging out of foster care. I hope you will continue to support initiatives like this that make a real difference in the lives of individuals and communities. Thank you.
Hello, my name is Ariana Jones. I currently live in North Haven. I'm originally from New Haven. We have the best pizza. To tell you my story with the program TSEA, I have to tell you about my story. I'm 17. I'm a senior in high school. I have been in foster care for a little over a year now. My mom passed away almost 5 years ago, which is crucial to the story. Since her passing, I haven't always felt like I've been supported. But I've been fortunate enough to be able to enroll in this program. But I know other young adults in other areas of the state haven't been as fortunate. I believe TSEA has helped me set clear goals, and it actively helps me work towards them. Between the stresses of getting my permit and applying for colleges, my specialist has really helped me change my perspective on things. The program is greatly beneficial for young adults aging out of foster care. A lot of young adults, myself included, lack the support and knowledge of how to be a productive young adult. Foster care doesn't come with a handbook on how to grow up. It pushes us out of the nest without much guidance. But thanks to TSEA, working with someone like my specialist, Ariana, has given me the necessary support to take major steps in the right direction. Ariana has helped me advocate for myself when dealing with complicated systems of the state, which is what makes this program different from others. Using the skills and confidence I've gained from TSEA, I would like to use this platform to advocate for another important issue. Recently, President Trump signed an executive order about the orphan tax. For those that aren't familiar with this topic, it's the practice that when a kid like me, who receives funds from a deceased parent, SSI, they are diverted to the state, which is different from SSDI. Instead of receiving the benefits that are rightfully owed to us, they are collected by the state and applied to DCF. Since enrolling in TSEA, I have been able to submit college applications, advocate for myself, and so much more. I don't know where I would be right now without TSEA's help. This program has helped me begin to reach my full potential. Since entering, I have noticed a clear difference in myself and my accomplishments. I truly believe in what TSEA stands for and its ability to help other young adults across the state. It provides security, consistency, and support, which is what any young adult needs to thrive. TSEA has helped encourage me to find my voice and use it. Thank you for your time.
Thank you. Go ahead. Come on.
Good afternoon. My name is Logan Lombardi Boley. I'm 20 years old and I live in Meriden, Connecticut. I'm a young adult who is receiving support from DCF and TSEA programs. I'm here to ask you to increase funding for programs like these that assist young adults like me. When a young adult involved with DCF or CPS turns 18, typically that is the end of their care with DCF, and we are now adults who must figure out the logistics of life on our own. With that being said, that comes with a lot of added stress and responsibility, especially with things like finding a job, monetarily supporting ourselves, and having to handle all of life's unexpected challenges. As it relates to me and my life, this is where the TSEA program was a huge help for me. My TSEA worker regularly checks on my employment status, things like doctor's appointments, educational responsibilities, and career development and readiness. To put it bluntly, this program is a large part of the reason that I was able to productively progress in life while experiencing homelessness. If programs like the TSEA program do not continue to receive funding, many young adults will be thrown into the world with no support system to guide them onto the correct path to adulthood. Not only is this detrimental to the individual receiving the lack of support, but it can be detrimental to society as well. When young adults are faced with life challenges much too soon without a support system to back us up and help instill healthy living habits, we are destined for regression rather than progression. To invest in the youth is to invest in the future of leadership, accountability, and progress. Thank you for your time and consideration, and I hope the programs that have contributed to my success thus far will continue to be funded.
Okay,
Thank you, everyone.
I got to ask one question. What is TSEA?
Transitional support for emerging adults.
All right, thank you very much. They were awesome. Transitional support for emerging adults. Okay. See, I got I don't even know where I am. Excuse me. 47, okay. Alexandria Bode? Alexandria Bode? Yes? Oh, okay.
We just move these aside.
Huh? Oh, cool. Thank you so much. Oh, okay.
Yep. Good afternoon, Representative Walker and members of Appropriations. My name is Mary Caruso, and I'm here today with my 2 adult children, Sam Bodie and Alexandria Bodie. Thanks. Who live with Friedreich's ataxia, rare progressive disorder. The disease affects their mobility, coordination, speech, and heart function. What it does not affect is their intelligence, their work ethic, or their desire to live meaningful lives. Sam works in our local high school, and he helps the students do their capstone projects and produces a great career fair for the whole school. Alex runs a nonprofit focused on accessibility and advocacy. They're strong contributing members of our community. What you may not see is that neither of them can get out of bed, dress, transfer, take a sip of water, or manage daily tasks without assistance. That assistance is made possible through Community First Choice. Sam worked hard to get his college degree and pursue employment even as he was losing most use of his hands. Today, he holds a position that he loves and works hard at every day. Community First Choice is what allowed him to develop a life that's meaningful to him. Without CFC, he would not lose his desire to work, but he could lose his ability to. Alex earned her master's degree in social work and now runs her nonprofit, Peace, Love, Accessibility. She works with police departments, schools, and legislators in this building to improve accessibility across our state. None of that would be possible without CFC, which allows them to hire and manage caregivers and structure support around work and daily life. There is a promise that individuals would simply move to waivers. In reality, waivers are capped, often have wait lists, and do not consistently provide unique needs that CFC offers. 70% of rare diseases are progressive. Needs increase over time, they don't improve. Policy must reflect that reality. Community First Choice is not an abstract policy for our family. It's structure that allows Sam and Alex to wake up in their own home, to go to work, to contribute to their communities, and direct their lives and be happy. As a family, we're not asking for anything extraordinary. We're asking for stability in a life that is anything but stable. We are asking to maintain dignity and asking that the state not just cut the very support that allows Sam and Alex and so many others, not as patients, but as professionals, as taxpayers, and as leaders. Thank you for listening to our family as a whole. We have, however, each submitted our own testimony. Out of respect for your time, we decided to present together. We hope that you will take the time to read each of our individual testimonies. Thank you so much for hearing us today.
Thank you, and you've got to be an awfully proud mom.
Thank you.
I won't do it.
Okay, that's all right.
Wow. Chase Bowling, online. Chase Bowling, online.
Hi. Good afternoon, ladies and gentlemen. My name is Chase Bowling, and I've been a PCA and 1199 union member for over 7 years. I've done a lot of jobs, and out of every job I've ever worked, this is the only place where my presence really truly mattered every day, where it actively changed a life, where it's not about balance sheets or budgets or bottom lines, but it's about the life that I make better with my service. Which is why a few months ago it was such a significant blow to me when I just stopped getting paid out of the blue. I lost the ability to meet my monetary obligations on time, leaving me several $1,000s in debt, a hole I literally don't earn enough money to get out of. I missed or had to reschedule medical appointments, and that's caused my health to decline. And lastly is the stress of knowing that the predicament that I and others find ourselves in is insane, because the truth is that PCAs like myself are the human safety net between the most vulnerable members of our society and the sharp edges of the world that we live in. But there's no safety net for us. We don't even have a human resources department, which is why thousands of us that work hard and pay our taxes were forced into debt and homelessness and literal slavery while this budget issue happened where we weren't getting paid. And I can only imagine the fallout from eliminating the Community First Choice program. The people that will go without care, the burden that will be placed on families, the workers, and the individuals that need the most help. Let's face reality. Nobody listening to the sound of my voice right now wants to spend their life in a nursing home or a rehab facility, especially when you could be at home. Nobody listening to the sound of my voice right now has the means to stop themselves from aging or the power to prevent a catastrophic accident or an injury. At the moment, any of us can find ourselves in desperate need of a home health care aide, of a PCA. And you ask yourselves, would you rather go to a nursing home or a rehab facility, or would you rather receive the care you need inside your home? Right? Would you rather receive the care you need as you age, right? Where you're most comfortable, where you spent your life investing, or would you rather give all of that up and go to a home? And the thing is, if we eliminate the CFC program, will you even have a choice in the matter? And so this is why I'm asking you to take a look at it from the level that getting rid of the program will cost more money than you're looking to save by eliminating it. You're going to have jobless PCAs. You're going to have clients that go without care. You're going to have an increase in housing instability across the state. I don't know how many of my brothers and sisters in the union literally faced homelessness after a few weeks of not getting paid. I can only imagine what will happen if the program ends. Thank you so much for listening.
Thank you, sir, and thank you for your testimony. Thank you.
Thank you.
Have a good evening. Next, Burnett Lowry, online.
Yes, can you hear me?
Yes, go right ahead, ma'am.
All right, thank you. Good afternoon, Chairman and ranking members and members of the appropriate committee. And I'm here representing the Connecticut Project Fund. Thank you for allowing me to speak. My name is Burnett Laurie. I have a bachelor's degree in supply chain management and entrepreneurship, also 2 degrees in medical and administration. I currently live in Derby, Connecticut. And but for some time in my life, this program that I depend on, y'all oversee. And this is important to me. Okay. I am 56 years old. I was born with lupus, SLA, with mixed connective tissue disorder. Okay, and I currently suffer from post-traumatic stress disorder and anxiety and chronic pain. And for my lupus, there is no cure. And because of these illnesses, I depend on SSDI and SSI, SNAP, and Husky health to stay stable, nourished, and safe. These programs are not simply benefits. They allow me to live with dignity. Without SNAP, I face impossible choices between food and managing my health. Without Husky, I would lose access to my medications and care that keeps me safe and out of crisis and out of the hospital. In New Haven County, tens of thousands of neighbors depend on SNAP and Medicaid to stay healthy and fed. In some communities like Derby, many seniors and disabled residents are trying to survive on fixed incomes. When federal policy shift threatens these programs, the fear is immediate because people now know quickly their stability can disappear. We cannot wait for people to lose coverage before we step in. So I ask you, committee, to take action that protects those vulnerable among us. Create a safe, funded safety net if federal SNAP cuts move forward. Build a clear, well-supported plan to ensure Husky residents not to lose their care. Center disabled residents and working families in every budget decision. Healthcare costs continue to rise. Food prices remains high. For people living on a fixed income, even the smallest change pushes the household into a crisis. These disturbances are not abstain. They affect our lives immediately. A responsible budget protects people like before it fails. Thank you for listening and for recognizing the human impact behind these decisions. Thank you.
Thank you, and thank you for your testimony. Have a good evening. Thank you.
You too.
Joseph Short?
Yes, thank you very much, Representative Walker and distinguished members of the Appropriations Committee. My name is Joseph Short, and I'm a Southbury resident. I'm here to testify on behalf of the Centers for Independent Living and the Community First Choice Program. Centers for Independent Living have been underfunded for many years and simply cannot continue serving everyone throughout the state. Therefore, I'm requesting an increase to funding by $1 million annually so they can adequately meet the demand for service, retain qualified employees, and continue serving individuals with disabilities throughout Connecticut. The proposal to eliminate Community First Choice with no clear alternative is extremely concerning and will certainly strip people of their independence and set Connecticut back years of progress. Centers for Independent Living improve the quality of life for people with disabilities by ensuring equal access and safeguarding rights. They empower individuals to live, to work, and to thrive in communities of their own choice, offering services that foster self-reliance, advocacy, and information or referrals. These centers are operated by and for individuals with disabilities, focusing on empowerment and community integration. Centers for Independent Living have a high retention of dedicated employees that are currently working at or beyond capacity to meet the needs of Connecticut's most vulnerable population. Despite persistent inflation rates, CILs have had minimal increases or flat funded for years, while the state sits on a projected $85 million surplus. I was paralyzed in 2002, resulting in quadriplegia. Yet I've been able to continue enjoying life in a community of my choice, earn multiple degrees, own my own home, have my own family, and remain gainfully employed as an advocate for one of the 5 centers for independent living. All of this is possible because of Community First Choice program. Yes, I need assistance with my activities of daily living, but that doesn't mean I should be forced to live in a nursing home or pause my life for years while on a wait list for a Medicaid waiver with strict eligibility criteria. Look how outdated Husky C income limits are, how inadequate the PCA waiver program is, or how terrible the 10-year wait list is for the autism waiver. For those of us under 65 years old with a significant disability, Community First Choice is Connecticut's first and only choice for a meaningful life. Being able to manage your own care in the community cost a fraction of being in a skilled nursing facility, and have finally allowed Connecticut to make meaningful progress to rebalance the provision of care away from institutions. So it's unfathomable how this program is unsustainable and why cutting the Community First Choice program has even been considered. State officials have acknowledged that they intend to hold harmless the 7,250 of us already on CFC. But what about those who are newly injured, or individuals that have been living with a significant disability and finally require additional assistance to remain independent, or individuals transitioning off of the Money Follows the Person program and there's no longer a Community First Choice program? I urge you to increase Connecticut's 5 centers for independent living by $1 million to support vital services to individuals with disabilities and to begin to restore the long-term underfunding of the SILs. Additionally, I urge you to please save Connecticut's First Choice program and don't send Connecticut backward again by institutionalizing us. Thank you very much for your time and consideration.
Thank you, sir, and thank you for your testimony. We appreciate that. Next is Linda Gorell. Linda? No. Okay. Next is Cynthia Bidorini. Bidorini. Okay. I got Cynthia right.
It's fine. Good afternoon, Senator Austin, Representative Walker, and members of the Appropriations Committee. My name is Cynthia Bidorini, Executive Director of the Brain Injury Alliance of Connecticut. On behalf of thousands of Connecticut residents living with brain injury and their families, thank you for the opportunity to testify. We are deeply concerned about HB 5032, the governor's proposal to eliminate the Community First Choice program and transition participants to home and community-based waivers. For individuals with brain injury, CFC is a saving grace. I cannot overemphasize the difference it makes for people to remain in the community safely. CFC has been one of the only programs able to respond quickly when services are urgently needed to prevent institutionalization. We often guide individuals who are waiting for waiver services to CFC so they can access essential support while waiting for a waiver slot. Without CFC, many would no longer be able to live in the community. The waiver system is already severely strained. According to the DSS Long-Term Care Committee's December 2025 presentation, ABI Waiver 2 currently serves approximately 280 participants, with Waiver 1 closed to new enrollments. 70 individuals are on the waiting list, and the average wait for services is approximately 7 years. BIAC has long advocated for expanding waiver slots, yet the wait continues to grow. If CFC participants are moved onto waivers, what is the concrete plan to expand funding and available slots to prevent even longer delays? The proposal also fails to address the needs of future brain injury survivors who will require timely services to avoid institutional care. We are equally concerned by the lack of clarity about how this transition would occur. Individuals with disabilities, their families, and advocates deserve clear, detailed information to understand the impact and provide informed input. Before any final decision is made, a comprehensive implementation plan should be shared publicly. People with disabilities, including those with brain injury, have the right to live in the least restrictive and most inclusive community settings. CFC was established to address long wait lists and expand access to community-based supports. It has been a critical tool in advancing that goal. Eliminating the program without a fully developed and adequately funded alternative risks increasing institutional placements, placing families in crisis, and reversing Connecticut's progress in rebalancing long-term care toward the community. We respectfully urge the committee to preserve community first choice or ensure that any transition guarantees expanded capacity, timely access to services, and protects people's right to remain in their homes. Thank you for your attention to this critical issue and for your continued commitment to Connecticut residents with brain injury and other disabilities.
Thank you. Thank you for your testimony. Thank you. Next, Terrell Williams. Terrell Williams.
Hello, Senator Olston, Representative Walker, and all members of the committee. My name is Terrell Williams. I'm a caregiver, a PCA. I've been doing this for over a decade. I started doing it for my mother when she became ill. And, you know, my main goal was always the quality of care for the consumer. And the consumer is also the employer, the person who we care for. So my mother, I worked with her until she passed away. And every person who I cared for since then, I consider them family. So this is a program that I watched my mother survive off of until her last days, and that she was really, really elated to have. She actually made a video, I'm not sure if it's still floating around, where she said that she thought it saved her life. So I, of course, am here to ask for you guys to allocate funding to keep the DSS program going. But I also wanted to add a story that happened to me not too long ago. When I became ill myself, diabetic, I was working so many hours that I wasn't eligible for the state program, the Husky program. And when I tried to get a program off of the marketplace, it was way too much, like over $600 a month, couldn't afford it. So one day I went to the pharmacist and tried to personally purchase the insulin I needed to survive, also $600, I couldn't afford it. And I remember having the thought that I think I might actually die because I can't afford to live. So something, and I consider this amazing, I thought it was almost a miracle. About a month or two after that, there was a bill passed, and the bill put a cap on the amount of money that they could charge you for insulin. And I was like, you know, all I could remember was that I spoke at a hearing like this before that. And it dawned on me that when the people come together and they partner with the legislature, we can affect change. We can save lives when it's time to. And we find ourselves at a position like that now, especially after the impact of the big, beautiful thing, you know, yeah. It puts a weight on all of us. And it's easy, like I've heard a lot of people saying like the system's against us and things of that nature. But I was reminded of that story and the fact that when we partner together, we can overcome any obstacle that's set before us. So more than just funding, I'm here to ask you guys to partner with us, to deal with whatever we have to deal with coming forward and make sure that these programs that millions of people's lives depend on continue to function. Thank you.
Thank you, and thank you for those stories. It really means a lot. People need to hear that. Thank you.
Thank you guys for listening, and you're champions to us as well, so
Thanks.
we appreciate it.
Thank you. Daniela Capetta? Online? Okay. Danielle? Daniela?
Hi,
Hi, go right ahead.
good afternoon. My name is Daniela Capetta, and I'm a registered nurse providing care to psychiatrically and medically impaired individuals in the community. I appreciate the opportunity to speak with you today regarding Medicaid reimbursement rates for medication administration visits, specifically the need to remove the reduced subsequent visit rate for individuals residing at the same address. I work with individuals who have complex psychiatric diagnoses and significant medical comorbidities. Many of these patients have long histories of medication noncompliance, repeated psychiatric hospitalizations, paranoid or delusional thought processes, and impaired insight into their illness. Because of this, they required skilled nursing visits to administer medications directly and to monitor clinical stability. While increasing independence is always our goal, the reality is that not every individual can safely live in the community without direct nursing oversight for medication administration. For many of the patients I serve, consistent nursing intervention is what prevents crisis-level decompensation. Medication administration visits are not simply a task of handing someone medications. Each visit involves clinical assessment of psychiatric and medical status, monitoring for medication side effects and adverse reactions, evaluating changes in behavior or baseline functioning, coordination with psychiatric and medical providers, communication with group home staff and care teams, as well as documentation and compliance monitoring. These visits have been shown to reduce psychiatric and medical hospitalizations, increase engagement in outpatient care, promote safety, and support long-term community stability. They also ensure adherence to treatment plans and provider recommendations. Currently, Medicaid reimburses a reduced subsequent visit rate when multiple patients reside at the same address. While the nurse may not need to travel to a second location, the clinical workload for each individual patient remains unchanged. The complexity of care, assessment, medication administration, documentation, and coordination are the same regardless of geography. In fact, many individuals living in a group home setting are among the most psychiatrically and medically impaired. These individuals often require 24/7 supervision and present with higher acuity needs. Providing care in these settings does not reduce the intensity of nursing services. In many cases, it increases it. The current subsequent visit rate does not accurately reflect the level of skilled nursing work required per client. It undervalues the time, expertise, clinical judgment, and risk management involved in caring for this vulnerable population. Removing the reduced subsequent visit rate would more accurately align reimbursement with the actual service delivered. It would support the sustainability of community-based behavioral health services and ultimately reduce costly hospitalizations and emergency interventions. Supporting adequate reimbursement ensures that our most vulnerable residents can remain stable, safe, and supported in the community rather than in higher cost institutional settings. Thank you for your time and consideration.
Thank you, and thank you for your testimony. Have a good day. Next, we have James Reed.
Hello. So good afternoon, chairpersons and members of the Appropriations Committee. My name is James Reed. I'm a registered nurse who's been working with the chronic end-stage renal disease patients for 35 years in Connecticut. For the last 26 years, I've been working with the largest not-for-profit dialysis company in the U.S., Dialysis Clinics Incorporated. Dialysis provides life-saving treatment for people who no longer have fully functioning kidneys. The issue at hand is that Medicaid reimbursement rate for the in-center dialysis procedures has not increased since 2008. Medicaid pays $139 per treatment, while the cost of providing care is more than $310 per treatment. For Dialysis Clinic Incorporated alone, the deficit is more than $700,000 per year, and for the larger providers, Fresenius and DaVita, the deficit in reimbursement is more than $10 million each per year. The margin is so slim in caring for dialysis patients that clinics are not making enough to cover the costs for all patients due to the financial deficits created in part by Medicaid's low reimbursement. In some cases, this has led to clinic closures, ultimately limiting access to care. We're a not-for-profit company that started caring for patients in 1971 and have begun discussing the need to make choices that dialysis providers have not had to make since 1973. Before 1973, panels decided who could get dialysis, essentially, who would live and who would die. We've been discussing with our physicians whether it's appropriate to limit the number of Medicaid patients we can accept in our clinics. If dialysis facilities cannot accept patients, there will be a ripple effect across the healthcare system. Without life-sustaining treatment 3 times weekly, patients suffering with end-stage renal disease face emergent care in hospital emergency rooms, lengthy inpatient hospitalizations, or worse. A single missed dialysis treatment leads to an increased hospitalization risk of 40% in the following 30 days compared to those that do not miss their treatment. As an example, here's a real-life scenario that outlines the impact this may have on patients. We had a patient who was forced to receive dialysis in the hospital for 21 months. During the time, the patient received 116 treatments. However, she should have received 273. To receive dialysis, she had to endure long hours in the ER, which caused her to come less frequently and be chronically underdialyzed. If she had been an outpatient clinic patient, she would have been able to live a full life and receive quality dialysis. Instead, she met an untimely end and died at 23 years old. She cost the system approximately $158,000 compared to the $16,000 that would have been charged based on the Medicaid rates during this period. Dialysis facilities can no longer bear the financial strain of Medicaid underpayments. And when Medicaid dialysis patients could not be admitted to outpatient facilities, there will be a large increase in cost to the system as a whole and a decrease in patients' quality of life, coupled with a potential increase in mortality. I've been working across the industry with other dialysis providers for the last 2 years on this issue, and we agree dialysis clinics are in active crisis and looking for funding to remain viable. Surrounding and comparable states have outpaced Connecticut's Medicaid rates, and again, we have not had an increase since 2008. We respectfully request an increase in ESRD patient rates by 10%. This result is Medicaid rate becomes 56% of what the Medicaid rate is. We request to add the ESRD patient dialysis care rate increase to phase 1. By 2028, we request an increase in ESRD dialysis rates by 38%, resulting in Connecticut Medicaid rates becoming 70% of the Medicare rate. This increase will not make dialysis facilities whole. It will simply allow us to survive. I appreciate this opportunity to testify today about the impact that severely low Medicaid reimbursement is having on patients and clinics alike. Thank you for your time.
Thank you, sir, and thank you for your testimony, and have a good evening. Mary Lou Friatis? Mary Lou?
Yes, I knew you would call me as soon as I shut my camera off. Okay. Here we go. Can you hear me?
Yes, we can. Go right
Okay.
ahead.
Hello. So thank you for having me. I really appreciate this opportunity. I'm Mary Lou Freitas from Plainville, Connecticut. I wear many hats. I am an advisor for Proud Parents, Leadership and Encouragement for All Parents, which is for parents with intellectual disabilities. But to be honest with you today, I'm here mostly also as a parent myself and as a foster parent. I have, I'm a mom of 6. 2 of my adults have, between the 2 of them, intellectual disabilities, developmental disabilities, Angelman syndrome, autism, cerebral palsy, and mental health issues. So I don't think I can explain to you any better than anybody else did. I just listened to the whole 3 hours, and there were some names I remember: Marianne, Carol, Tom, and most recently Joseph. They already did an amazing job explaining, so I don't want to repeat what they already said. But as a parent, I just want to reiterate what a nightmare it would be for these cuts. It's just unthinkable. My son and daughter, especially my son, who is very challenged, he is nonverbal and medically complex. My only goals, my big goals, I should say, not my only goals, my big goals are, for him to be healthy, to be safe, to be happy, and to be loved. That's not going to happen in an institution. He has his community, he's included. I could go on and on. We've built this wonderful life with these supports, and I just can't imagine, like I said, what a nightmare it would be without the community supports, whether it's community first choice, independent living centers. They're just so needed and so appreciated. As far as being healthy and safe, if again, he's nonverbal, he does not have reliable communication at all. You have to be a detective, really, to figure out what's going on with him. And, I don't know that, nursing homes and hospitals are going to be able to do that. Unfortunately, They're already overworked. There's a lot of wonderful workers out there, which also brings up the PCA issue, paying them more. And earlier today, someone specifically talked about Connecticut Children's Hospital. So between my two and being a foster parent, CCMC has been nothing short of amazing, whether it's the regular care or the specialists. They deserve more funding from Husky C. My son and daughter, have seen the same dentist for 7 years, and they finally said, we can't do it anymore. We're not taking Husky anymore. And it's
Your
just,
3 minutes are up. If you could please
yeah.
summarize.
Oh, was it? Oh, that's what that noise meant all day. I could hear.
Sorry.
Oh, I
You
didn't
can
know.
know
Okay,
you.
that's all. Just we just depend on all the nonprofits and every other everything discussed here today. Let's not go backwards several decades. So thank you so much. I appreciate it.
Thank you. And when that music came on, I thought the sun was going to come on. See, your testimony moved everything.
There we go.
Thank you. Thank you. Have a good day. Thank you.
Thank you.
Next, Leona Villegas.
Yes, good evening, Chair and members of the Appropriation Committee. My name is Dr. Leonel Villegas, and I'm a pediatric nephrologist, so kidney specialist practicing in Hartford, Connecticut. I am also a member of the Connecticut American Academy of Pediatrics Chapter Advocacy Committee, representing over 600 pediatricians in Connecticut, as well as the advisor for the Healthcare Provider Subcommittee in the Husky for Immigrants Coalition. So I'd like to express our strong support for protecting eligibility for the state-funded Husky program for undocumented children under the age of 15 years old and pregnant individuals. It's critical for children and families, and we need to maintain the progress that we've had made in expanding care to all children in Connecticut, regardless of immigration status. As a pediatrician, I've witnessed firsthand the challenges faced by our vulnerable undocumented children, despite the current Medicaid coverage that we do have. These challenges include delayed diagnosis and care, delayed access to appropriate specialists, worse mental and physical health outcomes, as well as fear of seeking care due to concerns about ICE and the risk of deportation of themselves or family members. So these delays and gaps in care not only harm the children themselves, but also really contribute to a growing healthcare burden, resulting in more emergency room visits, greater strain on the resources, and long-term social impacts. Additionally, when care is delayed, children present to these healthcare settings sicker with higher risk of complications, leading to missed school days, as well as incorporating the family as well, having to take time off of work. So it really impacts the whole family system. And in the past year, I've noticed a big shift in the demeanor of my immigrant patients and families. They're asking more questions and expressing concerns about the future of their care. They worry that their current Medicaid coverage might be taken away, leaving them without access to me or their necessary medications, something that many of us don't have to consider when we're teenagers or young children. My older patients are often forced to make really painful decisions between paying for their annual kidney checkup or blood work and deciding whether or not they're going to have money to pay off their college housing. Yet, despite these financial pressures, they still do come to clinic if they're able to, understanding that kidney disease is a silent killer. And sadly, some don't seek care, and that's when we see them in the emergency room, in the ICU setting, when things have progressed, more complications are present, with worse prognosis. So every day, us pediatricians, we work tirelessly to support our patients and prevent harm rather than simply reacting to illness. Our healthcare system is currently not set up for prevention, but maintaining and trying to sustain access to care is a really crucial step. Let's ensure that all children, regardless of immigration status, are given the opportunity to succeed as healthy adults, because improving care for the next generation will build a healthier community in Connecticut. We want what's best for our patients, and we hope that you will take the next step with us toward making this vision a reality. Thank you for your time.
Thank you, and thank you for your testimony. Have a good evening. Next, we have Cara DeBenedicts.
Can you hear me?
Yes.
Hi. Okay. Thank you so much. Senator Austin, Representative Walker, and members of the Appropriations Committee, thank you for the opportunity to testify today and specifically share my concerns regarding Medicaid reimbursement rates. My name is Caroline D. Benedictus, and I'm a pediatric ophthalmologist and strabismus surgeon practicing in the state of Connecticut. I'm here today on behalf of myself, my patients, and as president of the Connecticut Society of Eye Physicians. I've been here before speaking with you on this very same issue, and I really do appreciate the opportunity to speak with you again. Each time I testify, it's clear that this committee does recognize how dire Medicaid reimbursement has become and what it means for patients across our state. And I want to acknowledge that your committee has repeatedly made sincere efforts through proposed legislation and budget changes to address this problem. Unfortunately, those efforts haven't been realized at later stages at the executive level. And each time I return to talk to you, the situation is worse. Since the last time we spoke, I've been forced to further restrict access. In my practice alone, the average wait time for a new Medicaid patient is now a minimum of 1 year. 1 year. That means a parent is told their child has a medical condition with their eyes requiring treatment and is then told they have to wait a year to be seen. Statewide, the situation is even more severe. Outside of 3 pediatric ophthalmologists at Yale along the I-95 corridor, I'm currently the only pediatric ophthalmologist in the state seeing new Medicaid patients. Outside of that corridor, I'm their only option, and I have a minimum 1 year wait. There's approximately 9 pediatric ophthalmologists in the state, and outside of the 4 of us, all other practices have been forced to stop accepting new Medicaid patients entirely due to the cost of running a practice. And you'll hear from one of those colleagues later today. Let's be clear about what that means. Pediatric ophthalmologists are trained to diagnose and treat complex medical and surgical eye conditions in children of all ages. Many general ophthalmologists and optometrists are not able, nor do they want to care for very young children due to the complexity of the conditions and specialized training needed. In fact, many don't see children under the age of 8, but for those conditions, the younger the child, the more effective treatment. So for those of you who are parents who are on this, consider what that means in the real world outside of this testimony. So when your child needs medical care, you expect that care to be provided by a physician trained in pediatric conditions, and you expect it to be available in a timely manner. A 1 year wait for medically necessary care is just not acceptable, and we all know that. Honestly, I don't know how we let it get to this point in our state and how this is happening currently. The current access issues, particularly with pediatric ophthalmology, I believe does not meet the federal Medicaid equal access requirement under Section 1902A30A of the Social Security Act. That requires that payment levels need to be sufficient to ensure that an adequate provider network and access to care comparable to the general population is in place, and we just don't meet that standard, especially in pediatric ophthalmology.
Your 3 minutes are up. If you could please summarize.
Okay, thank you for the opportunity to speak again. I look forward to solutions, and I thank you for your time and consideration.
Thank you, and thank you for your testimony. Next, Jean Mills Arana. Jean Mills says she's on remote, and I do not see her. She is? Okay. Jean, would you unmute yourself?
Sorry about that. Good afternoon, Senator Osteen, Representative Walker, and members of the Appropriations Committee. My name is Jean Mills Arana, and I'm an elder law attorney with Connecticut Legal Services. On behalf of all 3 of Connecticut's legal aid programs, Connecticut Legal Services, Greater Hartford Legal Aid, and New Haven Legal Assistance Association, and our low-income clients, I urge you to do 2 things, as well as many of the other really, really important things I've heard about this afternoon. But I'm here to talk about a state-funded food assistance program and reinstating funding for Connecticut First Choice. Connecticut really must establish a state-funded food assistance program in the face of federal SNAP reductions. Connecticut residents rely on SNAP. Last year, 12% of Connecticut households, 450,110 of our neighbors, used SNAP benefits. In July of last year, President Trump signed H.R. 1, which enacted extreme changes and cuts to SNAP. And if you read my testimony, you'll see it details specifically how that came about. But it comes to about 68,000 Connecticut residents who will probably lose SNAP benefits as a result of those provisions, and another 46,000 of Connecticut residents who will lose SNAP due to the loss of exemptions, which used to be available and have now been discontinued. It's absolutely clear that a lot of Connecticut residents in all parts of the state are going to be hungrier and less healthy as a result of these federal reductions in SNAP. They can't pay, they're on limited budgets, they can't pay less rent, they can't pay less for a gallon of gas, and food budgets are going to have to be reduced, resulting in people having both less food and also in all likelihood, lower quality food, as it can be bought in larger amounts for less money. Food banks are meant to provide for emergency food, and they cannot solve this problem, no matter how hard they work, which they do work very hard. Many food pantries or food banks are, in addition to not having enough food, they can't consistently provide food for those with specific dietary needs. And also, many food banks or pantries are located in inconvenient areas and for limited hours. This makes obtaining even this insufficient amount and type of food difficult, especially for people who are trying to meet the new work requirements. Our state needs a state-funded supplemental nutritional program like SNAP to replace the food dollars our fellow residents need. Without such a program, too many people in Connecticut will be hungry and without adequate nutritious food. This is unacceptable in a state of our resources. This basic need must be met, and a state-funded SNAP program is the way to do it. Please develop and implement a state-funded SNAP program as soon as possible. Don't let our families, children, and individuals go hungry. We also strongly oppose the elimination of community first choice in the governor's budget.
Your 3 minutes are up. If you can please summarize.
Okay, I'll just say the name says it all, community first choice. Given a choice, living in the community rather than an institution is everybody's first choice. And I will just refer you to my written testimony. These services generally cost less than nursing home care. The waivers can't support the number of people that come in, and I don't think the nursing homes can either. So Connecticut Community First Choice is an economical, popular, and successful program. It's what people want. It's cost effective for Connecticut taxpayers, and it should be reinstated in the Connecticut budget. Thank you very much for your time.
Thank you, and thank you for your testimony. Mario D'Aquila?
Yes, thank you. Can you hear me okay?
Yes, go right ahead.
Great. Good evening, members of the Appropriations Committee. Thank you for the opportunity to speak today. My name is Mario D'Aquila. I'm the Chief Operating Officer and co-owner of Assisted Living Services, Inc., Chairman of the DSS Medicaid Committee for HCAOA Connecticut, and a board member of the Connecticut Association for Healthcare at Home. Our company began providing non-medical home care since 1996 in Connecticut. Our mission began when my great-grandfather was diagnosed with Alzheimer's and needed care at home. For nearly 30 years, we've helped seniors live safely with dignity in their homes as long as possible. Today, we serve hundreds of Connecticut seniors through Medicaid waiver programs, including the Connecticut Home Care Program for Elders. These services are a lifeline for elderly residents and one of the most cost-effective ways for state to provide long-term care. However, Medicaid reimbursement rates have not kept pace with rising costs or other payer sources. Agency-based Medicaid PCA reimbursement in Connecticut averages roughly $25 per hour. By comparison, private pay and long-term care insurance cases often reimburse over $35 per hour, and VA-funded cases can exceed $43 per hour. Those higher rates allow agencies to offer meaningfully higher wages for the same caregiving work. As a result, caregivers understandably choose higher paying assignments, often traveling to neighboring states where Medicaid rates are higher, making it increasingly difficult for Connecticut providers to recruit and retain staff for Medicaid cases. This is no longer a provider issue. This is now an access issue. When Medicaid rates are $10 to $18 per hour lower than other payer sources, the workforce shifts away from Medicaid clients, and seniors who rely on Medicaid may wait longer for care or struggle to get services at home. At the same time, Connecticut's minimum wage has increased significantly in recent years, and providers have absorbed these costs without meaningful rate adjustments. We respectfully ask that home care not be overlooked again this year. We are requesting a 13% increase in Medicaid reimbursement for each of the next 2 fiscal years, with continued adjustments thereafter to keep pace with wage mandates and workforce costs. Without these adjustments, providers will be forced to limit or stop accepting new Medicaid waiver clients. This is not a matter of willingness to serve. It's a matter of financial sustainability and workforce reality. Investing in home care preserves access, stabilizes the workforce, and helps the state avoid far more costly institutional care. Thank you for your time and consideration.
Thank you, and thank you for your testimony, and have a good afternoon. Thank you, sir. Tamir Capehart? Were you falling asleep? Tamir, were you falling asleep?
I'm sorry.
Were you falling asleep?
Not at all.
Oh, okay. You said just in time. Go right ahead.
Good afternoon, Senator Austin, Representative Walker, and honorable members of the Appropriations Committee. My name is Tamir Capehart, and I am a member of SEIU 1199, and I'm a personal care attendant. I stand before you after standing outside DSS twice in the last 4 months, once to deliver a bucket filled with thousands of grievances, and a second time when the state office locked us out and refused to address our concerns. Both times we were there because hundreds of our members have been dealing with ongoing issues with their paychecks. It is time for the state of Connecticut to find the means to address and correct this problem. You are looking at dozens of hardworking caregivers standing here today, caregivers who provide life-sustaining care every single day. Many of them, like me, are parents with children who depend on them. I'm a single mother of 3 boys who are my entire world. I go to work every day with one goal, to come home and provide the best life possible for my children. Yet, week after week, so many of these dedicated caregivers are left facing the hardship of missing pay or no paycheck at all. Since GT Independence took over our payroll from Allied in April of 2024, we have filed more than 3,000 grievances, with over 1/3 of them filed since October 2025. Instead of improving our time, the situation has actually gotten worse. How is this acceptable? No working person should ever have to struggle without a paycheck. You put in the hours, you do the work, you should get paid. But GTI does not seem to care that bills go unpaid or that the late fees pile up when paychecks don't arrive. Instead, caregivers are forced to make impossible choices. Do we pay for heat, put food in the refrigerator, or put gas in the car so we can get to the job, the very job that isn't paying us, while we're still holding on to hope that things will change? I stand here and I say that I was lucky until I wasn't lucky. I also got hit with a payment issue in November. It took nearly a month to fix. But as a union delegate, I have also spoken to many members who are not so fortunate. 2 people I have worked closely with have gone through periods of not being paid for the hard work they do every day. This is not how caregivers in our state or anywhere should be treated. It feels like the recent changes to how approved hours was calculated were made in a sneaky way.
Your 3 minutes are up. If you could please summarize.
We were not notified. Our union was not notified. Instead, the information was buried in a letter sent to consumers. A letter only provided in English, not highlighted, and offering no explanation of why the change was made or how the calculation works. While we have been able to get the change temporarily revised, many of our members still have not been made whole. So I ask you, how is this appropriate treatment of caregivers in our state? Why are they not receiving the pay that they have rightfully earned when they expect it? It's time for DSS to address the root of this problem, and if that means investing more funding to ensure proper oversight in payroll company that actually works, then do it. Because our livelihoods are at stake, our lives are at stake, and those are not things that we should ever gamble with. Thank you.
Thank you, thank you, thank you. Sarah Egan? Oh, there you are, okay. Can I ask, how How many PCAs are there in the chess program? I'm sorry, how many PCAs in the first choice program?
Oh, the community first choice?
Yeah.
We have heard, OPM told us 3,500, but we've heard in the past, over 7,000. So I don't know what the accurate number is.
Okay, thank you.
At least half.
I'm going to get yelled at for asking a question, but go ahead. Thank you. Okay.
Good evening, everybody. Hi, I'm Sarah Egan. I'm the Executive Director of the Center for Children's Advocacy. It's good to be with you all tonight. I first just want to acknowledge all of the direct care providers that are in the room, coming out to speak up for yourselves and your families that you serve. As the director of a children's rights organization and a parent of a profoundly disabled child, you know, these are the folks who make life possible for people in our community, and one of the folks who testified earlier tonight said it very well, that vulnerable people are not other people. They're us, and we invest in the world that we want to build for ourselves and our community. So I just want to acknowledge what everybody here gives to that. But I am testifying in my professional capacity tonight with the Center for Children's Advocacy. We represent a lot of children dependent on the child welfare and behavioral health systems. And I know it's a short session, and I know everyone needs support and appropriation, but these are systems that are very much in crisis. Not because people aren't trying or working hard or showing up every day, but because the budgets and the service delivery systems are in crisis. Just at CCA, with the 5 or 6 dozen children that we represent, you know, in the child welfare system, we have multiple children on our caseloads who are living in the homes that they've been ordered removed from by the court for their own safety because there is no place for them to go. We have a 6-year-old child in foster care who's on his 6th placement. That includes a 2-week stint in an inpatient psychiatric unit. We have a new 15-year-old client removed from their home who is in a temporary placement that is not going to keep her, and to a point that Representative Walker made earlier today, with no money going to the foster parent yet to support the needs of an adolescent girl in her care. That's a systems problem that we must fix, that we hear about all the time. So against the backdrop of these individual cases that, yes, I do describe as a crisis, because we can't normalize, and I know no one here does, when a 6-year-old doesn't have a permanent home, when they get kicked out of their after-school program because there's no aid to be there with them that they need, we have a problem. Systemically, we continue to see 12 to 13,000 children on Medicaid alone going into hospital emergency departments every single year for behavioral health reasons exclusively. That's just Medicaid. That is a number that has not gone down meaningfully over the last 5 years. And just last year's data alone, more than 600 of those children spent more than 4 days in the emergency department post-recommendation for discharge. So that just can't be a number that we keep living with, right? So there are several, I think, investments we really need to look at. There's no one fix. We heard it earlier here today. We have to do something about foster care rates. We have some of the worst foster care rates of high median income states in the country. We have raised them $1.75-ish a day in the last 20 years. So that's something we can tackle immediately, making sure that these foster care providers have what they need.
Your 3 minutes are up. If you could please summarize.
Just very quickly, looking at therapeutic foster care and going back to a differentiated system that provides individualized need, and making sure that those kids and their foster care providers and their families have the wraparound services to meet those needs, and on and on and on. There's more. But I just wanted to come here tonight and say thank you and underscore and talk about what we're seeing in our cases every day. Thank you.
Thank you, Sarah. I guess it's pouring outside right now, huh?
It sure is.
After this hearing, it sure seems like it. Thank you. Suzanne, oh, I'll mess this one up. Suzanne from ARI of Connecticut, President and CEO. Suzanne? Remote? I don't see her online, no? Okay. Anthony Thomas? Anthony Thomas?
Good afternoon, Senator Austin, Representative Walker, an honorable member of the Appropriation Committee. My name is Anthony Thomas, and I have been a personal care attendant for the past 2 years, caring for my mother. I would do anything for my mother. I think most people would say the same thing. She took care of me, raised me, and I'm her only child. It is my duty to help her now in need of her needed time. During this time, we have built even a stronger relationship, even closer than possible that we thought. I cherish every moment of it. It is truly a blessing to be my mother's caregiver. But despite the joy, the job has not been easy. I had to deal with my mother's approved hours being cut without notice. At first, it was overwhelming, not knowing what to do or how to fix it. My mother's care was on the line. Eventually, I learned I was not the only PCA facing this problem. It was happening to many others. This is not an insulated issue. It was world spread. And that was not my only challenge. At one point, I even went without pay. It took months and countless times. Calling, I never received a call back. It took months to receive what I was owed. Thankfully, I eventually made whole, but I know I was fortunate. I had financial ability to support myself while I was waiting for the error to be corrected. Many fellow caregivers do not have that option. They live paycheck to paycheck. Not everyone has that safety net or backup plan. For many of us, one missing paycheck is a crisis. Caregivers should never have to face these kinds of issues, especially payment problems. A person's paycheck should always be accurate and on time. We need a better system than GTI independence. When the problem arises, even small ones, we are met with excuses, no real answers. You cannot reach anyone to help you fix the issue, even to explain what is going on. The basic customer service we should expect from a payroll company is simple. We need additional funding from the Department of Social Services, and one outgoing problem with GTI must be addressed, not someday, but now. Please provide DSS with resources and needs, and ensure that caregivers across the state are always paid in full and on time. Thank you. Anthony Thomas.
Thank you. Thank you, Anthony. Thank you for your testimony. Karen Healy. Karen Healy. Oh, is she on, she's online?
Hi, good evening. Hi, my name is Karen Healy, and I'm a consumer. I live in Hartford, Connecticut, and I vote. I'm here to testify about the bill about the Medicaid in Husky C and the May Connect. I'm a worker. I work at ShopRite in Crum. I've been there for over 2.5 years. I love my job. I'm considered working disabled under May Connect, and my Husky C is under all that. So if things have changed, I'll be affected big time. I'm in the room trying to I'm supposed to have a knee replaced, possibly another one in the summer and one in the spring. And the issue I'm standing up for is that if I have to lose my benefits, my Husky C, that covers my home care. It covers my nursing to come in once a week to do my MedPort, because a couple of years ago I left a job and I was on non-considered working disabled, and I had to have a medical spend down of $5,000. And also I had to pay $135 a week for the nurse to come in to do a weekly med pour. And I ran up a bill from October to the following February of $1,300 bill that I did not know how to pay. So we worked out payments through my mother when she was alive. So if I lose my Husky C and working disabled status at this point, and this happens, I will not be able to have my knee done. I will not be able for my nurse to come in from my nursing agency to help me out in my program, to do my MedPort. I would lose a lot of statuses, and I have a lot of physical and mental health issues. And for me to be able to have to do 80 hours as a normal person, that would be way too much on my body. Right now, I do 20 hours a week, at ShopRite, and it's a lot on my body. Some nights I go home and I cry myself to sleep because that's how bad my pain could be sometimes working at my ShopRite as a front end bagger. I love my job. I love my people in my community, and I love the people at the legislative building. But I really would like the people to hear that someone like me with a lot of mental health issues does need this to still continue in our lives. Because if we don't have this, I don't know what I would have. I don't want to be at a point where I have to not be considered working disabled. And that happens, I won't be able to afford a lot of things I want in my life for my care to be out in the community and be successful. I just want to end with that I'm a normal person who has issues. I don't consider myself, I was a CVH for a very long time. I spent 24 and a half years of my adult life in state hospitals between Poughkeepsie, New York and Connecticut, at Connecticut Valley Hospital, and a mission at Cedar Crest a couple of times in Newington when it was open. I'm a normal person. I have issues, but I might deal with them differently. I don't consider my diagnosis like I'm at CVH on a chart with a number on the side, and I don't consider myself a person that has issues. I might have issues that I deal with differently, but I'm as normal as human being as anybody else in society, and I shouldn't be judged any differently. I appreciate you guys for listening to my testimony today. It meant the world to me. Thank you.
Thank you, and thank you for your testimony. Next, Christian Demania? Okay, I didn't.
No worries, Representative. Good afternoon. My name is Christian Damiana, and I am the Public Policy Manager at Mental Health Connecticut, an organization that has provided essential mental health services across the state for over a century. I'm here today to urge you to invest in Medicaid behavioral health reimbursement rates and fully fund the nonprofit services that thousands of Connecticut residents rely on. We stand in full alignment with the Alliance's request for a $155 million increase in FY27, which would fully fund Medicaid rate increases for behavioral health services as recommended by the state's own study. And I want to stress this is the state's own data telling us that the current system is broken. That study found that 5 comparable states pay behavioral health rates that are 117% higher than what Connecticut pays. We're not asking to be made whole, we're asking to stop falling further behind. The governor's proposal of $45 million by the end of the biennium is a step, but it is a step toward a destination we needed to reach yesterday. And notably, the $15 million already appropriated in FY26 has yet to be deployed. We have money laying on the table while providers are closing their doors. That disconnect should concern every member of the committee. I also lead the Connecticut Parity Coalition, a group of 25 advocacy and clinician organizations working to secure equal behavioral health access. Parity is the principle that mental health should be on equal terms with medical and surgical care. But parity is more than just a rule for insurance companies. It's a principle about equal ability to access mental health care. It says that a person's mental health care is just as real, just as urgent, and just as deserving of treatment as a broken bone or a heart condition. And yet, our Medicaid program operates as though that principle doesn't apply to the people who can least afford to be told their care is worth less. OHS's 2024 payment report confirmed what providers already know. Medicaid reimburses behavioral health at rates far below commercial insurance. When we pay less for mental health care, we get less of it. Clinicians leave for settings that value their work. Waitlists grow, and the people on Medicaid, who often have the greatest need, end up last in line. If we believe parity is the right standard for our commercially insured residents, we should be ashamed to accept anything less for our most vulnerable. At Mental Health Connecticut, we run Robinson House, one of the only residential programs in the state for deaf or hard of hearing adults living with serious mental illness. That program depends on Medicaid funding. So does our targeted case management work. These aren't abstract line items, they are lifelines for people who have nowhere else to turn. Investing in behavioral health rates isn't charity, it's prevention. Every dollar we fail to spend here shows up later as an ER visit, a person who never enters recovery, or a life lost. Please support the $155 million increase and fully fund Medicaid behavioral health rates. Thank you.
Thank you, and thank you for your testimony. Richard, from the Center of Disability Rights. Richard? Huh?
Yes, I'm here.
Okay, go right ahead, sir.
Good evening, Appropriations Committee. My name is Rick Funiglietti. I'm a quadriplegic with a spinal cord injury. I am also the Programs Manager and Consumer Service Advocate at the Center for Disability Rights, one of 5 centers for independent living in Connecticut. I'm here today to ask for a $1 million increase for the Centers for Independent Living, and 2, to oppose the Governor Lamont's proposal to eliminate CFC, which is Connecticut's first choice for receiving and obtaining home community-based services in the community. I've been working for the Center for Independent Living for over 25 years. I was Money Follows the Person supervisor at our center for 17 of those years, and currently programs manager and consumer service advocate. As you know, Money Follows the Person is a program which transitions people with disabilities back into the community from nursing facilities. In most cases, the cost of their care and their housing are less than half the cost of a nursing facility. And yes, you're right. They are not nursing homes, they are facilities. I'm still doing nursing facility transition because not everybody in a nursing home is in there long enough to qualify for Money Follows the Person, but still needs the advocacy and the independent living skills training to navigate Connecticut's increasingly complicated Medicaid system. And ongoing supports for people who are newly transitioned in a capacity that MFP can't really sustain. You will hear my friend Sandy Roberts, an ex-coworker. She also used to work for the Center for Disability Rights. She will be testifying tonight from a nursing home regarding community first choice. I also need to add, because I forgot at the beginning, for some reason, Sandy Roberts did not receive the link to testify after registering for tonight. If somebody can please fix that or let us know how can she fix it, because she's listening right now. My 2 asks are simple and cost-effective and smart. Fund the independent living centers for an extra $1 million and do not eliminate community first choice. The legislators need to think what's right and humane and prevent the governor from continuing his discriminatory actions against people with disabilities. Apparently, he thinks we are worthless and cost too much. Now, I also want to touch on Husky C. I'm on MedConnect, and I'm 61 years old, and I'm looking to try to retire. Once I retire and come under MedConnect, guess what? That large income asset that I can have on the MedConnect goes away the very next day. The very next day, I'm going to lose all the supports I need that continue to keep me working. Well, guess what, Lamont? I need those same supports when I stop working. Also, I'm going to go on a rant regarding why is he giving a tax break or a tax refund to a single person who makes under $200,000 a year,
Your
a
3 minutes are
$200
up.
tax
If you
rebate.
could please summarize.
He's going to waste money on that? He's so out of touch. Thank you.
Thank you, sir, and thank you for your testimony. Did you submit a written testimony?
Yes, I did. Thank you.
Next, we have Christine Bianchi.
Yes, good evening.
Good evening.
Thank you for the opportunity to provide comments on the human services components of the governor's budget proposal. On behalf of Staywell Health Center, thank you for your continued commitment to hearing directly from Connecticut residents and providers on these important issues. Staywell provides comprehensive healthcare services across the greater Waterbury region, operating 6 sites in Waterbury and 1 in Naugatuck. And in 2025, nearly 25,000 patients received care, including 4,600 uninsured patients and approximately 15,000 Medicaid beneficiaries. We operate one of the largest FQHC dental programs in Connecticut, providing over 30,000 dental visits to 11,000 patients annually. We also provide integrated services, including allergy treatment, nutrition, nephrology, acupuncture, women's health, podiatry, and behavioral health care, just to name a few. So our mission is to ensure that access to care continues even when patients experience changes in their insurance coverage. And those coverage changes are happening more often and their impact is visible. our uninsured patient rate has increased from 13% in 2022 to 19% in 2025, increasing uncompensated care demands. But despite these pressures, Staywell remains deeply committed to quality care. And for 6 consecutive years, we have received national recognition as a health center quality leader, placing us among the top 10% high-performing health centers in the country and making Staywell the only Connecticut health center to receive this distinction in 2025. But to sustain this access and quality, we respectfully ask the committee to consider 3 priorities. First, support implementation of new Medicaid enrollment requirements by strengthening state capacity. So new federal requirements will increase the frequency and complexity of Medicaid eligibility reviews. Successful implementation will require both technology improvements and sufficient staffing to avoid enrollment delays and coverage losses. We support the governor's proposal to add staff and upgrade eligibility systems. However, technology alone is not enough. Experienced enrollment staff remain critical to helping individuals navigate policy changes and make difficult coverage decisions. During the most recent enrollment period, affordability, not access, has been the greatest barrier. Many individuals declined coverage or allowed their policies to lapse due to rising premiums and deductibles. Others have considered canceling appointments out of concern about costs. And although Staywell never denies care based on ability to pay, patients take their financial obligations seriously. Our outreach staff help patients enroll in coverage and complete sliding fee applications to reduce those financial barriers. But for families,
Your 3 minutes are up. If you could please summarize.
Okay. The second thing we ask that you support is the community health worker reimbursement and implement the funding for the legislation that was passed. And lastly, that you continue to support access to care for community health centers such as Staywell. Thank you for your ongoing support. And I have submitted written testimony.
Excuse me. Thank you, and thank you for your testimony. Have a good day. Joy Minervi? Yep.
Hi, yes, I'm a speaker for Joy Minervini.
Okay.
I'm going to read her letter for you. It says, to the members of the Appropriations Committee, I'm testifying about the opposition to the governor's proposal to end the CFC program. My name is Joy Minervini, and I would be personally and severely harmed if the elimination were to go through. It would cause involuntary institutionalization. I have a severe form of cerebral palsy, which involves uncontrolled movements. As I age, the movements have worsened and involve my face, neck, arm, legs, and entire body. I require total care for ADLs 24 hours a day, 7 days a week. I cannot speak, therefore I use a communication board with words and letters of the alphabet to help me communicate. I have a suprapubic catheter, but I also experience urinary incontinence several times during a 24-hour period. In addition, I also have many bowel movement accidents. Both incontinences require me to be cleaned and changed timely to prevent skin irritation, open wounds, and infections. I receive nutrients, fluids through a J tube because my facial, tongue, and teeth grinding movements have made it impossible for me to eat and drink using my mouth. Each day it takes me anywhere between 12 and 14 hours for the completion of my feeding and fluids. When the tube gets blocked, the machine will start to beep and my PCAs need to address the issue, prime it, and restart the feeding. My left hip is dislocated and it requires me to sleep on my right side. A pillow needs to be placed between my knees and another pillow behind my back so that I can stay on my right side. Throughout the night, my PCAs must reposition the pillow behind my back so when I cough or aspirate, I will not choke. I wake up several times throughout the night, mostly in the early morning hours, and I can't go back to sleep. My panic attacks are triggered and I'll end up biting my tongue. My PCAs get me up, put me in my wheelchair to help me calm down and clean me up. All of the above reasons are why I need the CFC program to continue my 24-hour care 7 days a week. Only CFC covers 24-hour care in the community. If CFC goes away, I will not have any choice but to go into a nursing home. And truthfully, I will not receive the one-on-one care that I receive now. The nursing home staff have way too many patients to care for, and quite frankly, I would not survive very long in a nursing home before I pass away. Please do not lock me up and rob me of my independence. Joy Minervini. Thank you.
That's a hard one to follow behind. Excuse me. You think this job's easy? Sorry. Next is John Paul Benoit.
Good evening, distinguished members of the Appropriations Committee. My name is JP Benoit. I am the board chair of Leading Age Connecticut in Rhode Island, representing not-for-profit providers across the continuum of aging services. I appreciate the opportunity to testify on the governor's midterm budget adjustments relating to aging services. I will be brief as we have submitted written testimony to the committee. First, we strongly support the development of a PACE program using federal rural health transformation grant funds. PACE provides comprehensive medical and social services for dually eligible older adults living in the community. Several of my colleagues and I have visited PACE programs in other states and have seen firsthand how this highly coordinated person-centered model offers a valuable and effective option for older adults who wish to remain in their homes and age safely in their communities. Secondly, we appreciate the investment that were made in the biannual budget for nursing homes, including scheduled Medicaid rate increases and funding pools to support staff wages and benefits. Workforce stabilization remains the most urgent challenge facing nursing homes, and these investments are of an important step. And we support the governor's midterm proposal to transition the Medicaid nursing home acuity-based payment to the patient-driven payment model, or PDPM, over 3 years. DSS will also be recalculating the base rates and phased transition with stop gain and stop loss protections is the right approach. We support the proposed rebasing or recalculation of the nursing home rates. Rebasing involves a recalculation of each nursing home's base Medicaid rate using the allowable costs reported on their annual cost reports submitted to the state. Regular rebasing and then paying those recalculated rates remains the integrity of the statutory cost-based rate system and ensures that providers who invest in staff, resident care, and infrastructure are appropriately reimbursed. The governor has calculated a savings associated with the rebasing, and we conceptually support this proposal for reinvesting a portion of the savings based on the sector, although we have not yet seen the detailed rebasing assumptions or facility level impact. We are pleased to see the savings used to fund the long-awaited quality performance program in year 3 of the rate phase-in. We do urge the committee to evaluate and address the impact of the case mix neutrality factor that was implemented in the rate system to control overall direct care expenditures. This factor has reduced calculated direct care reimbursement by roughly 11% over the last 5 quarters. Finally, we continue to support Connecticut's rebalancing towards home and community-based services and the principles that individuals should have meaningful choice in where and how they receive services. We look forward to working with the state and stakeholders on the next phase of system planning. Thank you for the opportunity to testify. We appreciate the governor's proposal and look forward to working with the General Assembly to ensure Connecticut's aging service system is strong, sustainable, and prepared for the future. Thank you.
Thank you, John Paul. Appreciate your testimony. Next, we have Ben Shaken.
Good evening, Madam Chair, members of the committee. Thank you for being here and listening to all of this testimony this evening. My name is Ben Shakin. I'm the Director of Public Policy and Advocacy at the Connecticut Community Nonprofit Alliance. We are the statewide association of community nonprofits who, as you all know, serve 500,000 people in the state and importantly employ about 7% of the state's workforce as well. I don't want to repeat things that other folks have said throughout the evening tonight, and so I just want to highlight a couple of items related to the two parts of the budget that you're talking about this evening. One has to do with Medicaid rates for behavioral health services. Christian, who came up a couple of people before me, laid out the case very, very clearly, and so again, I won't repeat what he said. I just want to make a couple points. One is that this is not news, so we know that the state's own data came out a couple of years ago showing that the Medicaid rates for outpatient behavioral health services were woefully low when compared to other states. But I'll say 11 years ago, providers did their own cost reporting data in 2015 that showed that the annual loss then in Connecticut's top 10 behavioral health billing codes was more than $27 million, and that number has only increased substantially and dramatically as inflation has gone up while rates have stayed the same. This is important, particularly to nonprofit providers, because they exist to serve the state's most needy residents, and many of them rely almost entirely on Medicaid to fund their outpatient programs. Many of them see approximately 70% or more of their patients using Medicaid versus commercial insurance, and some clinics are reporting that as high as 90% of their patients are Medicaid members. So unlike other healthcare providers in the healthcare system, nonprofit behavioral health clinics really can't make up the financial losses with other payers. And so the need to increase those rates to continue to have services available, particularly as private behavioral health services are becoming less and less available to Medicaid members, is really crucial. Second, I want to touch on the Department of Children and Families budget this evening. We appreciate that the underlying budget, the enacted budget for the second year of the biennium, includes some investments that were not made in the current fiscal year. This came up earlier in the commissioner's conversation with the committee, particularly funding to support urgent crisis centers and funding to support and maintain the 24/7 expansion of pediatric mobile crisis services. Neither of those things, both of those things had been funded through ARPA dollars prior to this budget. Neither of them were funded in the current fiscal year in an adequate way, and both of them are included and maintained in the second year of the budget. Demand for children's behavioral health services is higher than ever, and I know this has been a focus of the legislature for the last several years. As was brought up earlier, though, unfortunately, the investment from the legislature in dollars to support that focus has not kept pace with the need. And in fact, when you look at the department's budget, as Representative Walker did earlier today with the commissioner, you will note that it is lower today than it was several years ago. And so that's a major area of concern and something that I hope the committee will look at. I will close just by saying, as others have said, and others will say after me, the Alliance is asking for an additional $155 million appropriation to community nonprofit services in FY27 that includes fully funding those Medicaid rates, and it includes providing an increase to other Medicaid services that have not received cost of living adjustments over the years, and it also includes bringing the rest of the human services system to the same level of funding that the legislature provided to the Department of Developmental Disabilities in the budget that you passed last year. So thank you very much for your time and for listening to us tonight and the other nights during this budget hearing process.
Thank you, Mr. Shakin, for your continued advocacy. Next, we have Timothy Parks, who is remote. There he is.
Yes. I'm sorry, can you hear me?
Yes, we can hear you.
Okay.
Please go ahead. You have 3 minutes.
Okay, thank you. Good evening, Human Services Committee, Appropriations Committee. My name is Tim Parks. I am testifying today as an employee of one of the Connecticut Centers for Independent Living, CIL, specifically the Center for Disability Rights in West Haven, Connecticut. I am also a person with a disability. Funding for Center for Independent Living is imperative. Since their establishment in the 1990s, CILs have saved the state of Connecticut millions of dollars annually by helping individuals with disabilities live independently in their communities rather than in costly institutional settings. At CDR, our staff, including transitioning advocates, housing coordinators, information and referral specialists, and independent living advocates work tirelessly to ensure that the individuals with disabilities receive the services and supports they need to live productive, independent lives. We collaborate closely with our partner agencies such as Rehab Services, Area Agency on Aging, the Department of Social Services, and other CILs across the state to effectively meet the needs of our consumers. I respectfully urge you to support an increase of $1 million for the Connecticut's independent living centers. People living independent and productive lives in the community depend on these essential services. I would also like to address the governor's proposed cuts to the Department of Social Services, specifically the proposal to cut Community First Choice CFC program. Cutting Community First Choice in Connecticut would be devastating. It would force thousands of elderly and disabled residents out of their homes and into costly nursing facilities. The program currently supports more than 7,000 Medicaid recipients in Connecticut. Eliminating or reducing CFC would increase reliance on institutional care, further strain state resources, and remove autonomy from vulnerable individuals. CFC allows individuals who meet a nursing home level of care to remain safely in their homes with appropriate supports. Without in-home services, many elderly and disabled residents would likely rely heavily on hospital emergency departments, the most expensive and least efficient forms of care, forcing individuals into nursing facilities often against their wishes undermines their independence and quality of life. CFC is a self-directed program that gives participants control over hiring and managing their personal care assistants. Losing this program means losing control of daily life. While family members often help when they can, many simply cannot provide the level of care required without CFC supports. Additionally, CFC provides access to home modification funds that are critical for making homes accessible and adaptable. These modifications are essential for individuals with disabilities, mobility limitations, and aging residents to maintain independence safely and with dignity. Please carefully reconsider the consequence of cutting Community First Choice. This proposal would impact thousands of lives. It would also not save the state money in long term, but instead increase institutional costs and strain community resources that are not equipped to absorb the loss of services. Most importantly, it threatens the fundamental right of people with disabilities to live in their communities. Thank you for your time and consideration.
Thank you, Mr. Parks, for your testimony this evening. Next, we have Luna Rosado. I don't see her online, but I just wanted to double check with the clerk or the administrator.
Not here in person either.
Okay, great. Well, we'll move on. Let me know if she does come. Next, we have number 74, Kathy Ludlam. She's a remote.
And
Go
then
ahead, Kathy, when you have a chance.
click the word again. There we go. Thank you, members of the Appropriations Committee. Thank you for this opportunity to talk to you today. My name is Kathy Ludlam, and I have been living on my own with personal care support for 34 years. I am here to add my voice to all the others protesting the termination of Community First Choice. Others will speak to the reality that shifting CFC participants to waivers is unworkable for many reasons. Existing waivers already have long waiting lists, and new waivers are unlikely to happen or be adequate in this political climate. I want to echo what others have said and will say about the need to make sure personal assistants are paid properly and on time. But I'm mainly focusing on CFC and the need for that program. This morning, the commissioner of DSS said the average CFC care plan costs
a year. An institution is estimated to cost over $92,000 per year. I understand the need to rein in costs, but please also consider this. Some of us are too disabled to live in nursing homes, which under state regulations are required to provide only 3 hours a day of hands-on care. I am a taxpayer too, and I want public funds to be used wisely. But when you look at the growth of community first choice over the years, it represents an investment in the lives of people, empowering them to live, volunteer, and be part of their communities. Think about how much the cost of everything has gone up since 2018. The fact that numbers of people served has grown should not be surprising or alarming. It means more people are getting the help they need. These are investments in people and in a program that has been very successful in keeping people out of nursing homes and returning them to their communities. Let's not abandon Connecticut's long commitment to moving funding from institutions and into community support. Let's not abandon this commitment and move toward more restrictive and often more costly environments that will deny people the opportunity to live their lives, in many cases causing their conditions to deteriorate and many to die. Instead, let's be as efficient as we can with taxpayer dollars while maintaining our investment in the lives of people who need personal care, as well as the people who provide this essential support. Please reinstate Connecticut's first choice, community first choice. Thank you.
Thank you, Ms. Ludlam, for your testimony. It's very, very important that we hear from folks in the community how this will affect them every day. So thank you very much. Next, we have Narasley, also supposed to be number 75.
She will be joining a little bit later on.
Okay, great. Next, we have Ian Matthew Harrington. Please go ahead, sir.
Thank you. Esteemed Senator Austin, Representative Dathan, Representative Walker, Senator Lesser, Representative Gilchrist, and members of the Appropriations Committee. My name is Ian Matthew Harrington. I am a resident of Mansfield Center, Connecticut. And I serve as Director of Workforce Development and Training for the Health Education Center in Norwich, where we train and support community health workers, medical interpreters, and aspiring public health professionals across our region. I stand in strong support of HB 5032. In 2023, Connecticut made a smart decision. You passed legislation requiring Medicaid reimbursement for community health workers. And that decision recognized what evidence already shows. CHWs improve health outcomes, advance equity, and prevent costly crises. But passing a law without fully implementing it leaves the work unfinished. 30 states reimburse CHWs through Medicaid. Connecticut should not be lagging behind. CHWs are not optional add-ons in the health system. They are trusted frontline professionals who keep people connected to care. prevent avoidable hospitalizations, and address social barriers like housing, food insecurity, and transportation. When CHWs are present, people stabilize. When CHWs are absent, people deteriorate. That deterioration shows up in emergency rooms, in inpatient beds, and in bills that taxpayers ultimately absorb. When CHWs are not sustainably funded, the cost does not disappear, it escalates. Emergency-driven care is the most expensive care. Crisis care is the most disruptive care. And those costs are borne by Connecticut families through higher public spending, insurance premiums, and uncompensated care. The human toll compounds alongside the fiscal one. And when systems fail, suffering deepens, trust erodes, hope diminishes, and civic participation declines. An ounce of prevention is worth a pound of cure. In healthcare, that's not just wisdom, it's fiscal responsibility. We are already witnessing ballooning state and federal healthcare expenditures driven by reactive systems. We cannot afford to continue funding crisis while neglecting prevention. Fully implementing Medicaid reimbursement for CHWs is not an expansion, it's a completion. It is the logical next step in a policy you already endorsed. It strengthens workforce stability, reduces avoidable utilization, and aligns spending with prevention rather than emergency response. I urge you to fully fund the implementation of Medicaid reimbursement for community health workers. This is a prudent investment. It protects taxpayers, it strengthens our health system, and it reduces unnecessary suffering across Connecticut. Thank you for your time and consideration.
Thank you, Mr. Harrington, for your testimony this evening. Next, we have Monique Cobbs. I don't see her online.
Not
Okay.
in person either.
Okay. Number 78, we have Nick Lebron. I don't see him online either.
He's walking over now.
Oh, he's walking. Okay. Excuse me. Yeah. Thank you. Good evening, sir. Go ahead and start when you're ready. You have 3 minutes.
Thank you. Good evening, Chair, members of the Appropriations Committee, and my Representative Gonzalez from Hartford, and Senator Lesser. Good to see you. My name is Nick LeBron. I'm a community oral health champion with the Connecticut Oral Health Initiative, and I'm also a former city councilman in Hartford. I'm here today to urge you to remove periodontal treatment from the $1,000 annual Husky Health dental cap. Periodontal disease is not cosmetic. It is a chronic infection. It causes pain, tooth loss, and systemic inflation. It is directly connected to diabetes, which is prevalent in our community, and heart disease. Conditions like this disproportionately impact low-income residents and communities of color in cities like Hartford. Yet under the current Husky structure, once someone reaches 1,000 in dental services, they are often cut off, even if they are in the middle of treating active gum disease. That cap creates a barrier to care. When treatment stops, disease progresses. When disease progresses, costs rise. And when costs rise, they show up somewhere else, either in emergency rooms, hospitalizations, missed work, or unmanaged chronic illness. This is not prevention. It is postponement. And in our inner city communities, postponement always becomes a crisis. The issue is not theoretical for me. As a former city councilman, I've had residents call me in pain, not asking for charity, asking where they can go after hitting the Husky cap. I've sat with families who had to choose between paying rent and continuing gum disease treatment. I've had family members who relied on Husky coverage. I've seen what happens when someone is forced to stop periodontal treatment halfway through because the benefits ran out. The infection and pain doesn't pause because the coverage does. The pain doesn't stop because the calendar resets. What happens instead? Teeth are lost, diabetes becomes harder to control, the confidence erodes, employment becomes more difficult. and the emotional toll is real. In Hartford's neighborhoods, oral health is directly tied to dignity. When someone cannot smile, cannot eat comfortably, or lives in chronic pain, it affects their mental health, their work, and their family life. We often talk about health equity. This is what it looks like in practice. Removing periodontal treatment from the Husky Cap would recognize gum disease as the chronic medical condition it is. It would support prevention instead of crisis care. It would reduce long-term costs and improve overall health outcomes. More importantly, it would send a message to low-income residents that their health is not capped. We would never cap insulin for someone with diabetes.
Thank you. Thank you, Mr. LeBron. If you can just please summarize.
Sure. This is fiscally responsible, this is medically sound, and this is morally right. Thank you for your time and commitment to Connecticut's most vulnerable residents. Thank you.
Thank you so much, Mr. LeBron. Next, in person, we have Jamie Arbor. I believe
Madam Chair, we
he's in
received
person.
confirmation that he's not participating in the hearing today.
Okay, great. Thank you for letting me know. Next, we have Tanisha Signor. She looks like she's online. Hi, Tanisha. Go ahead. You have 3 minutes.
Hi, thank you for having me. My name is Tanisha Signor. I'm the policy director at She Leads Justice. We're a statewide nonprofit that uses a justice and equity lens to advocate for under-resourced and marginalized women and girls in Connecticut. We've been around for over 50 years. And I'm here today for a few different reasons. I'm here to urge the committee to protect Medicaid eligibility for undocumented children up to age 15, as well as pregnant and postpartum individuals. At She Leads Justice, we believe that all healthcare is a human right, regardless of an individual's race, gender, identity, sexuality, ability, zip code, economic standing, immigration status, or employment status. We also recognize that the systems of healthcare and immigration in the United States are rooted in racism and white supremacy, and addressing this reality means creating purposefully inclusive and anti-racist policies which center marginalized populations who have historically been ignored and taken advantage of. Preserving Husky for immigrants in its current form is the bare minimum of what our state can do for our immigrant populations this session. The healthcare provided by these policies is critical for the individuals who are receiving it and for the health of our state as a whole. We also must protect Connecticut residents who are at risk of losing their health coverage due to federal cuts, regardless of their immigration status. We urge the legislature to secure Husky coverage for these individuals by investing in existing infrastructure, including the state-funded Husky program. And I just want to talk a little bit about the immigrant populations in Connecticut. They are massive. They supply a massive contribution to our state's economy. We have information from Data Haven that says that undocumented individuals in Connecticut created $636 million in federal tax contributions and $371 million in state and local tax contributions annually. Those numbers don't even include the realities of the spending power that undocumented individuals provide to our state's economies. And these are our neighbors. They contribute enormously to our communities, and they deserve access to qualifying healthcare coverage. We would also like to enthusiastically give our support for implementing the Medicaid reimbursement for community health workers. They provide an essential care in our communities, and they're going to be needed more than ever as we attempt to navigate the new implementations that are going to come through from HR 1. And lastly, I would like to submit our support for increasing our funds.
Please summarize.
Yeah, sure. To increase funding for the Diaper Bank of Connecticut and their Diaper Connections program, because no family should have to worry about having access or being able to afford diapers
Thank you,
for their
Tanisha.
babies and toddlers.
Thank you very much for your testimony this evening. Next, we have Jose Flores. He looks like he's supposed to be remote, but I don't see him in the waiting room.
No, not here.
Okay, great. Next, we'll move on to number 82, Matt Barnett. And looks like you're in person this evening, Mr. Barnett. Thank you. You have 3 minutes when you're
Thank
get
you,
there.
Representative Dathan, and to the distinguished members of the Appropriations Committee. My name is Matt Barrett, and I'm President and CEO of the Connecticut Association of Healthcare Facilities and the Connecticut Center for Assisted Living. As the committee carefully evaluates the needs of all of our state's constituencies and communities in this state fiscal year 27 proposed budget adjustment, we once more ask you to also consider the needs of our skilled nursing facilities in your deliberations. I'd like to begin by acknowledging the critically important investment in nursing home workforce development, recruitment, and retention advanced by the leadership of the Appropriations Committee last session, further developed by Governor Lamont and adopted by the full Connecticut General Assembly, noting that the midterm budget adjustment proposed by the administration before the Appropriations Committee fully funds the second-year wage enhancement for nursing home workers and group home workers in the amount of $46.7 million. Next, though a long-awaited inflation adjustment for nursing homes didn't achieve final passage in Connecticut last session, it was enormously important to us that the Appropriations Committee, in its earlier version of the adopted budget, did in fact reverse the proposed elimination of statutory inflationary increases for nursing homes and funded an inflation adjustment, which it would have been the first since 2019. As I said, in the final version of the budget, we generally understand that the committee's inflation adjustment for nursing homes was eliminated or transferred to fund the enormously important wage enhancement that I previously mentioned. However, we feel the committee made an enormously important policy statement last session about the need to recognize inflation in the rates and ask that this matter be again considered in this year's budget adjustment. I also wanted to acknowledge that in anticipation of the administration's proposal to rebase nursing home rates effective July 1st, 2026, and to make federally prescribed revisions to the acuity payment component of the rates, State Social Services Commissioner Barton Reeves did initiate a collaborative nursing home and agency stakeholder input process that began in earnest last July in monthly meetings with the two nursing home associations, noting that there hasn't been a stakeholder meeting since November, and also noting that the department has pledged to resume these meetings now that the details of the governor's midterm budget announcement or adjustment have been announced. Our goal in the resurrecting of these collaboration meetings, for us at least, holds the possibility that we may be able to make recommended revisions to the proposal that is before the committee now, and we think several important revisions are needed, even as the governor's proposal does employ some measures to mitigate the potential for destabilizing and significant rate cuts in the proposed acuity
Your
reform.
3 minutes are
Thank
up.
you.
Please
Oh,
summarize.
I do want to say that there still are very significant cuts for some nursing homes in the rebasing proposal, some in the amount of as much as 5% reductions, which amounts to about a $480,000 reduction in their rates. And so we're looking forward to resuming those stakeholder meetings and anxious to report back to the Appropriations Committee in that regard. Thank you so much.
thank you so much, Mr. Barrett. Next, we have Ruth Vasquez.
Yes.
You have 3 minutes.
Okay. My name is Ruth. I'm a student of Danbury High School and a member organizer with Connecticut Students Project. Thank you for the opportunity to testify on the HBO 5032 and adjusting the state budget for the biennium ending June 30th, 2027, and as it relates to the Department of Social Services budget. I'm here in strong support of protecting and expanding Husky coverage for immigrant families. Connecticut has made meaningful progress by providing coverage to all income eligible children 50 years old and younger, as well as prenatal and postpartum coverage, regardless of immigration status. That process has changed lives. Still, not many of our neighbors still lack access to healthcare. At a time when federal policies are restricting coverage options for many immigrants' families, now more than ever, Connecticut has to step up to protect our residents. When my brother and I got sick, and we relied on over-the-counter medicine, preventive checkups like luxury we simply did not have. It was only recently that my mother learned my younger brother qualified for Husky for Immigrants. This brought enormous relief to our family. My mother is a single parent who has a minimum wage job and continues to deal with the rising cost of everything. Last year was especially difficult. Both my mother and my brother experienced healthcare problems, and the medical expenses create serious financial strain. Having Husky cover my brother's checkups made an enormous difference during a stressful time. It allowed him to receive consistent care without forcing my mother to choose between paying medical bills and paying rent or other basic needs. However, my brother could be at risk of losing this coverage and my other brothers, and I still remain unsure. Illness do not check documents before it affects a child. Healthcare needs to not disappear because eligibility changes. This is why I respectfully ask the committee to protect Husky eligible for all income eligible children, as well as prenatal and postpartum coverage regardless of immigration status. Fund coverage throughout the state-funded program for Connecticut residents at risk losing healthcare due to federal cuts. Increase medical reimbursement rates so providers can continue serving hospice patients. My family story is not unique. There are many families like mine across this state who are doing everything they can to build a stable future. Protecting Husky for immigrants means protecting children's health, parents' peace of mind, and well-being of communities. Thank you for your time and consideration.
Thank you, Ms. Vasquez, for your testimony. We appreciate it. Next, we have Darlene Dennis. It looks like you are in the waiting room. If you can just accept the promotion to be a panelist, you can give your testimony. Yes. Is Darlene?
She has not accepted our promotion
Okay.
panelist. Actually, we have a couple people when it just declines automatically, which usually means they need to log off and log back in, and then the accepting should work at that point.
Great. Thank you, Madam Administrator. If you can do that, you can speak, but we're going to go ahead and jump on to Rebecca Breen. She's online, and you have 3 minutes, Madam. Thank you. Go ahead, Rebecca, when you're ready.
Okay.
Rebecca, can you unmute yourself? Great. Go ahead.
Sorry about that.
No problem. Thank you.
You caught me off guard when the last person wasn't there. Thank you, Representative Dathan and members of the Appropriation Committee. My name is Rebecca Breen, and I'm the director of EastCom Birth to 3. I've worked in Connecticut's Birth to 3 system for 28 years as a provider, a mentor, and a leader. Thank you for the funding increases provided in last session and the additional funds proposed in the governor's budget. However, these increases are not enough to stabilize our system. The most critical period of brain development occurs in the first 3 years of life, when intervention can change a child's life trajectory, but we cannot deliver those services effectively under the current funding structure. When the fee-for-service model was implemented in 2017, rates were based on a best guess. Those rates have not been adjusted in 8 years. Meanwhile, costs have risen, workforce shortages have intensified, and demand has grown. Although providers are serving 40% more children each month than they were in 2019, the average number of hours provided to each child has decreased, partially due to the lack of staff based on frozen billing rates for the last 8 years. Specifically, children with autism diagnoses are experiencing a 62% reduction in their services, while children without an autism diagnosis are experiencing a 9% reduction in services. The same limited workforce is being spread thinner and thinner, directly impacting job satisfaction, retention, often leading to burnout and attrition. This data was pulled from the OEC report presented at the February 2026 ICC meeting. Currently, Bursa 3 utilizes a tiered reimbursement structure based on professional licensure, which we support. However, based on the published rate study of 2024 in January, the proposed new tier billing system creates a top tier that's not currently accessible by the entire Bursa 3 community. According to the most recent lead agency report, only 2 individuals statewide have completed the only training resulting in qualification for the highest billing rate. There are currently over 1,000 employees working in Bursa 3. More than 85% will remain at the projected entry-level tier, despite many having 10 to 30 years of experience. Under this new system, doctorate-level physical therapists and psychologists, as well as master's level speech pathologists, occupational therapists, licensed clinical social workers, and certified teachers would be reimbursed at one of the lowest tiers. The proposal does not consider the level of expertise or schooling and would significantly impede our ability to recruit and retain highly qualified professionals. Early intervention is one of the most cost-effective investments we can make. 42% of children receiving our services and Part C services do not require special education by kindergarten.
Ms. Breen, if you could please summarize, your 3 minutes are up.
Yes, Connecticut's youngest children deserve a system that's adequately funded, staffed, and stable. I respectfully urge you to take the necessary steps to ensure Bursa 3 is funded at a level that reflects the real cost of delivering high-quality early intervention services and reject the proposal of the tiered reimbursement model that would further undermine recruitment and retention. Connecticut's youngest children cannot wait. Thank you for your consideration.
Thank you so much for your testimony this evening.
Thank you.
Next, we have Deb Poland. I think she's in person.
Thank you,
Great.
Representative Dathan.
Thank you. You have 3 minutes.
Thank you. Good evening, everybody. My name is Deb Poland. I'm the Chief Strategy Officer, and this is Sean Frick, the CEO of the Community Health Center Association of Connecticut. And as many of you know, we work with the state's 17 community health centers who provide primary medical, behavioral health, and dental care to 452,000 people across our state every year. And I want to start off by thanking all of you in the legislature who made a strong commitment to health centers last year by supporting a phased-in rate increase that will really help the health centers to continue to provide the high-quality care that they do to all people, regardless of ability to pay. We did submit written testimony, so I just want to highlight a couple of items for your attention. The first, I want to add our comments to those who are supporting efforts to implement HR 1. We support funding for DSS, for staff, for improved technology, anything that can help the state implement the new requirements under HR 1, most notably the increased Medicaid enrollment twice a year instead of once a year, and the community engagement requirements. We also, as an association and for our community health centers, pledge to work with DSS and with all of you on any statutory changes that are needed to help streamline the eligibility and enrollment process as we implement this next January. Part of that is going to be making sure that we have community health workers out in the community to help people understand the changes that are coming their way, the very significant changes that are coming. You've already heard from several people who've talked about the need to fund community health workers, typically funded by grants. Grants end, and we really do need Medicaid funding. Appreciate the fact that the legislature passed and the governor signed 3 years ago a public act that would require reimbursement under Medicaid. Now we need this to actually get implemented, and that will require some funding in the state budget to get us started. There is a return on investment, so although we're asking for funding to be included, we expect that that will pay dividends fourfold. Finally, we do know that there will be some people who lose access to their typical care site, regardless of all the work that's put in because of some changes that are happening on the federal level and have happened over the last year. There needs to be some planning put into place to ensure that all people in our state are able to access primary and urgent care. And we ask for you to add some funding for planning for this infrastructure to be developed. Thank you very much.
Thank you, Ms. Pumlin, for your testimony this evening. Next, we have Christian Allen.
Good evening, Representative Dathan, distinguished members
Yes,
of the
thank
Appropriations
you. You have
Committee.
3 minutes.
Okay. Good evening, Representative Dathan, distinguished members of the Appropriations Committee. My name is Christian Allen, and I am here to strongly oppose the elimination of the Community First Choice program included in the governor's proposed budget, HB 5032. I help care for my 28-year-old brother who was born with spina bifida. His condition affects every part of his daily life. He lives with incontinence, livability, chronic pain and fatigue, daily headaches, cognitive challenges, and mental health issues. Because of this, he cannot live independently and requires consistent hands-on support to stay safe. For my brother, Community First Choice is not optional. It is the foundation that allows him to remain at home, receive proper care, and avoid unnecessary decline. Without it, he would lose the support that keeps him stable, healthy, and connected to the community. My parents are getting older, and the responsibility of caring for him will eventually fall to me. Without Community First Choice or another home-based program, I would be forced to make an impossible decision. I would have to choose between staying home full-time to care for him, leaving us without much income, or going to work and placing him in an institution like a nursing home. Without the support that Community First Choice provides, my brother's physical and mental health would deteriorate quickly. Community First Choice allows people like my brother to live with dignity, stability, and safety. Eliminating the program would remove the only lifeline that keeps him functioning. If Community First Choice is eliminated, what realistic alternative do families like mine have to keep medically complex loved ones safe at home? I urge you to protect Community First Choice or ensure that a home-based program remains available so that individuals with significant medical needs can continue to live safely in their communities, and families like mine are not pushed into crisis. Saving Community First Choice should be Connecticut's first choice. Thank you for your time.
Thank you, Mr. Allen, for your testimony this evening. It's appreciated.
Thank you.
Next, we have Dr. Janine Collage. I see her as an attendee. She can just accept the invitation to become a panelist. Here she is. Great. Thank you. Janine, I don't know if you can hear me. If you can just go ahead. You have 3 minutes.
Hi there. Thank you very much. Thank you to Senator Austin and Representative Walker and the members of the Appropriation Committee for allowing me to speak. I just want to share my concerns about Medicaid reimbursement as it relates to the state budget. My name is Janine Collins. I am a West Hartford resident. I'm an executive member of CSEP, the Connecticut Society of Eye Physicians, and I'm a practicing pediatric ophthalmologist. I provide medical and surgical eye care for Connecticut's children, which involves giving glasses to preventing blindness. I know you've already heard from one of my colleagues earlier today, but you must know that pediatric ophthalmology access is in a state of crisis. There's only 9 of us for the state, and only 4 of them are able to take Medicaid, yet there's roughly 300,000 children in Connecticut who are relying on Medicaid for their insurance. 3 of our doctors who can take Medicaid work for Yale and along the shoreline, and the other is in private practice in Waterbury. The rest of us just really can't afford to take Medicaid, and the reason is quite simple. The reimbursement rates make it impossible to sustain in private practice. I own my own practice in Rocky Hill, and I get to see where every dollar goes. I see the rent and supplies and equipment and staffing costs just keep going up, but our reimbursement rates as physicians just keep getting cut. I don't know if people don't really understand how we're able to pay for raising rates, but it's from payments from insurance companies and payments from patients. And if those keep getting cut, there's no funds out there to support us in private practice. This year, I had to make the challenging decision to stop taking new Medicaid patients. Between the visits that are often time intensive, the unreimbursed translation services costs, and the high no-show rates, I was losing money for every patient I saw, and it was just not sustainable for me to stay in practice. And now I get heartbreaking calls every day from parents in tears because the wait list to see a pediatric ophthalmologist for a child with Medicaid is nearly a year. And it's just awful to be in this situation when I think about the fact that these are the people that I really went into medicine to try and serve. We don't need any more studies to tell us what the problem is. When you haven't given your doctors a raise in almost 20 years and physicians are dropping Medicaid like it's a hot potato, the problem is pretty obvious. Connecticut's Medicaid access is at a crisis. It's beyond crisis, and it's at risk for violating federal equal access requirements under the Social Security Act, particularly as it concerns pediatric ophthalmology. We need to raise our rates to be at least with Medicare parity, with a plan to adjust them going forward for inflation. Our Connecticut's children really deserve to have access to this care. They can't learn, they can't grow, and they can't thrive if they have untreated vision loss because there's no doctors available to see them. Please help us so that we can help the future of our state. Thank you so much for your time and your attention.
Thank you so much. Perfect timing. Thank you, Doctor. Next, we have Krista Durand. There you are.
Good
You've got
evening.
3 minutes. Thank you.
Thank you, Rep. Dantham. And thank you to Senator Austin and Rep. Walker and the distinguished members of the Appropriations Committee. I'm Krista Duran. I'm the President and CEO of the Hospital for Special Care. And I appreciate the opportunity this evening to testify regarding critical funding issues that directly affect the patients served by the Hospital for Special Care in connection with HB 5032, an act adjusting the state budget for the biennium ending June 30th, 2027. The Hospital for Special Care provides highly specialized care to pediatric and adults living with complex, often catastrophic medical conditions. We are the state's primary provider for individuals who qualify for Medicaid and require long-term acute care hospital level of service, including many patients who are ventilator dependent and/or have critical airways. We also operate Connecticut's only inpatient and partial hospital treatment programs for children and adolescents with autism spectrum disorder, as well as the only long-term acute care hospital for pediatric patients with complex medical needs. We appreciate the committee's recognition in 3 essential principles. Our patients deserve the highest quality clinical care available. Our dedicated staff should not be expected to accept inferior rates for compensation because they serve Medicaid patients. And the Hospital for Special Care is truly the state's partner in caring for children and adults with the most complex medical needs. At the same time, expenses for labor, benefits, and medical supplies continue to rise, significantly challenging our ability to meet these needs. HFSC serves the highest percentage of Medicaid patients of any hospital in the state, with an average census of approximately 82% Medicaid. Our current level of service is not sustainable without funding. We recognize and appreciate Connecticut's investment in academic and workforce development programs to strengthen the workforce with meaningful long-term returns on those investments. We, in fact, have committed significant internal resources to support nurse residency programs to help early career nurses, as well as we have a unique program, a tuition-free CNA Academy, to expand the workforce pipeline. Despite our efforts, the situation remains critical. Without additional support, HFSC will be forced to make difficult decisions and prioritize patient safety within severe fiscal constraints. Before taking such steps, we believe it's critical to inform policymakers and advocate for the state resources necessary to avoid reduction in services. We serve a uniquely high acuity Medicaid population and continue to experience sustained financial pressure. We will end our fiscal year, which ends March 31st, 2026, with a $3 million loss. Our projections for our new fiscal year are upwards of a $9 million loss. The Hospital for Special Care plays an essential role in Connecticut's healthcare continuum by serving Medicaid beneficiaries with extraordinary medical and behavioral health needs. Without timely and targeted rate enhancements, our financial stability and our continued access to these critical services is at a significant risk. With your
Thank you.
partnership,
Thank you. If you could please summarize.
Sure. With your partnership, we've made meaningful progress towards strengthening our fiscal stability. I thank you for your time, your consideration, and your ongoing commitment to the patients we serve in the state of Connecticut. Thank you.
Thank you for serving our community. Next, we have number 90, Cynthia Johnson. Looks like she's in person. Great, thank you. Ms. Johnson, you have 3 minutes.
Good afternoon. For the Senator Austin, Representative Walker, and honorable members of the Appropriations Committee, my name is Cynthia Johnson. I am a personal care attendant as well as a delegate for my union. So here I stand. I'm here before you, not just as a healthcare worker, but as a mom that is constantly worried about the care of her sick child and providing that care for her. Let me describe that. My daughter started having grand mal seizures at the age of 6. In 2014, her seizures became more complex. She started having 6 different types of severe seizures, which led to vertigo and PTSD. And from traumatic falls, from drop seizures, she developed behavior difficulties. As a mom, that was heartbreaking because I couldn't stop her suffering. I couldn't stop the pain and suffering that she was going through. But I am determined to make sure my daughter knows that she is not alone. And as others, PCAs that are taking care of family members and taking care of those that they love, they are determined as well. Even though they are going through what they're going through, they are fighters, they are survivors. So we are determined to make sure that they are going through this not alone, but with us. I want to address one little thing. I heard some numbers that was kind of off. If you go with me with these numbers, you'll hear something that's amazing. We as caregivers, we make probably $44,000 a year with our pay right now. Nursing homes, for one person in a nursing home per year, with all the secret care, charges and everything, is $20,000 a month. That'll be $240,000 a year. And even with the budgets that we do have, my daughter's budget is only $69,000 a year. That's still how much money we are saving the state of Connecticut. Because if you put my salary and her budget together, that's still not $240,000 a year. And that's what it would cost if she was to go into a nursing home. With knowing that, we need to make sure that our fiduciary company and DSS work together so that we are not worried about when we're going to get paid. We're not worried about how much we get paid. We're not worried that we're going to get paid at all. That causes undue stress on the people that are taking care of those that they love, because then we have to worry about our own households. We have to worry about our bills, the utilities. And the thing about it, a lot of our caregivers are taking care of the people that we're taking care of in our homes. So if we become homeless, they become homeless. And that's not good for nobody. We want to take care of them. We want to make sure and give love. Help us to make sure and do that. Make sure
Thank you,
DSS,
Cynthia. If you can please summarize, that would be
yes,
great.
make sure DSS and the CFC program is funded for those that need the care. Thank you. Thank you for
Thank
hearing.
you. Next, we have Nick Karpasas, and apologies if I've not pronounced your name. It was a challenging one. You can tell us what it is, and you have 3 minutes, sir.
Not a problem. Thank you so much, Senator Austin, Representative Walker, Senator Summers, Representative Nuccio, and members of the committee for allowing me to speak. I appreciate it. My name is Dr. Nick Karapasas. I'm a chiropractic physician practicing in Manchester and also serve as president of the Connecticut Chiropractic Physicians Association. To start, I want to recognize that the committee's played a key role in restoring chiropractic fully to the Medicaid program in 2021. Without your work, that wouldn't have happened. Prior to that, we were permitted only to treat pediatric patients who were referred to us through the early periodic screening and diagnostic testing program. My personal mission ties into giving back to the community. I've tried to do that in a number of ways, including seeing Medicaid patients in private practice and through providing services in federally qualified health centers. We know at this point that you realize that reimbursements we receive for services in Medicaid are terribly low. One of my colleagues gave specific examples in written testimony, but I want to reinforce the core of them here. Most of the services we provide are not covered under statute currently. So a chiropractic physician treating a Medicaid patient for the one covered treatment service might submit codes to Medicare corresponding to treating 1 to 2 areas of the spine, for example, neck and low back, or 3 to 4 areas. The codes are reimbursed in Medicare at $23.14 and $35.60 respectively, while the Medicaid reimbursement currently is $15.12 for 1 and 2 and $20.72 for 3 and 4. It's virtually impossible to operate a practice that's dominated by patients that desperately need our services with this level of reimbursement. Ultimately, it hurts patient access. Chiropractic medicine is non-invasive, it's evidence-based, it helps avoid pharmaceutical and surgical interventions that aren't needed. We achieve excellent results with our patients. We help in preventing addiction in patients who are experiencing serious and chronic pain and who might otherwise default to opioid use. I do understand there are limited resources and many demands. You guys have always supported Medicaid, and I know you're going to continue to do so this year. You have lots of people coming to you with horrible needs. The 2027 budget contains 40 million for Medicaid provider fee increases. I hope that that 40 million stays in there for that purpose. And if possible, and you can see that there's a way to do it, that you add to it. Thank you so much for your time.
Thank you, Doctor, for your testimony this evening. Next, we have number 92, Carla Esquivel. I don't see her online. Okay, we'll move on. Number 93, Laura Jordan.
Yes, good evening. My name is Laura Jordan, and I'm the parent and the CFC PCA for my son. Firstly, I'd like to thank everyone on the Appropriations Committee for the opportunity to give testimony and comments to oppose the cuts to CFC. Chair Senator Austin and Representative Walker, thank you very much. And my Senator Jamie Foster has been most helpful, and Saad Anwar and Jeff Gordon for their concern and notes on this matter. So let me tell you about how CFC works for my family, and plead with you not to cut this entitlement and not move to a vague capped waiver or institutional care, which would be more costly and would be devastating for my family. My son Alexi is a 23-year-old, very beautiful and talented young man with multiple disabilities requiring around-the-clock care at the institutional level. I've been his primary caregiver since basically the beginning. And he's been in school, and then we had CFC, and we had very small number of hours, only 8. It's only a couple of years ago that we increased that 6-fold. So that was a big relief, but it was always under threat to be cut. And we just had a hearing, and thanks to Disability Rights Connecticut, we were actually able to keep our hours. So we have now a bunch of hours. It's still not, a lot of hours. I'm still working basically 100 hours or more a week. And, this has prevented me from working and stopping my career and so forth. And but now it's under threat again. And we only just got these hours last month. So confirmed last month. So now we're on this roller coaster of, being under threat, getting some hours, going back under threat. So we're really tired of being on this roller coaster, and it's very detrimental to my son and his care. So now that we have this packet of hours along with some DSS day hours, we are self-directing, and that has been a real game changer for him. He's really starting to progress. We can self-direct, hire people who really care about him and are concerned about him, we can train them. And this has been a little bit of relief for him and for me. And it's been great since we don't cut this. We finally just received it. So there is a budget surplus. We all are aware of this. And as Commissioner Reeves of DSS noted, enrollment is growing. Yeah, that's a fact. We could expect that. So, however, don't throw us under the budget bus. We're the most needy families and individuals with disabilities that need this. So I'll just sum up and say, as Comptroller Scanlon noted, we can plan a better budget with CFS included. And he said, don't be penny wise now to be pound foolish in the future, because we're not going away. We're here.
Thank you, Laura,
Thank you.
for your testimony this evening, coming out. It is appreciated. Next, we have number 92, Carla Esquivel. She's come back on. So Carla, you have 3 minutes, please.
Yes, thank you. Estimados miembros del Comité de Servicios Humanos, mi nombre es Carla Esquivel. Vivo en Stanford desde hace 15 años. Tengo familia con documentos y sin documentos. Soy líder de Nosotras CT, una organización que lucha por los derechos de las trabajadoras y de los trabajadores en sus alrededores. Estoy dando mi testimonio al proyecto de ley HB 5032 para ampliar el seguro médico de Husky para nuestras familias en Connecticut. Es muy importante que nuestra comunidad tenga un seguro médico. Muchos de nosotros dedicamos nuestra vida y alma a nuestro trabajo y es humano que se nos apoye con un seguro médico. Tengo 25 años acá. He sufrido en carne propia el no tener un seguro médico. Sufro de migraña severa y nunca he podido ir a un especialista por no tener dinero para costear mis gastos médicos. A raíz de mis largas horas de jornada de trabajo, he tenido problemas con venas varicosas y el problema se ha empeorado en los últimos 4 años. Tengo miedo de desarrollar cálculos sanguíneos, tengo diabetes que desarrollé emocionalmente y necesito estar en control, hacerme radiografías y no puedo hacer nada de esto por falta de oportunidad de tener un seguro médico. Vivo con miedo, siempre pensando en mis hijas y no quiero que nada malo me suceda, porque tengo 2 niñas que viven y dependen de mí. El dolor en mis piernas ha sido más fuerte cada día. Me dificulta estar parada todo el tiempo en mi trabajo y cosas tan comunes como manejar mi vehículo. A veces tengo que usar el pie contrario porque me dan calambres y siento que mi pierna va a explotar. Merecemos y pedimos por favor su apoyo ahora que hay recortes federales. Nosotros cuidamos de sus hijos, sus familias, hogares. Somos quienes preparamos sus alimentos en los restaurantes. Somos quienes cuidan a sus padres. Limpiamos sus oficinas y quien cuida de nosotras, nadie lo hace. Quisiera agregar que en estos momentos y por las situaciones actuales, muchas familias sufrirán por un seguro médico. La situación actual en Estados Unidos presenta un panorama incierto y desafiante para el seguro médico, marcado por la posibilidad de aumentos significativos en las primas, que podrían superar el 100% para algunas familias en el 2026, debido a la expiración de subsidios de ACA, se prevé que miles de personas podrían perder la cobertura médica. Pagamos nuestros impuestos y somos el impacto de trabajadores inmigrantes indocumentados en la economía de Estados Unidos. Agradezco y valoro su tiempo de escuchar nuestro testimonio. Gracias.
Gracias. Thank you very much. There's an interpreter online. If you could please summarize her comments.
Yes, of course.
Thank you.
Dear members of the Human Services Committee, my name is Carla Esquivel. I have been living in Stanford for 15 years. I have family with documents and without documents. I am the leader of Nosotras, an organization that fights for the rights of immigrant workers in Stanford and its surroundings. I am giving my testimony to HB 5032 to extend Husky medical insurance for our families in Connecticut. It is very important that our community has medical insurance. Many of us dedicate our lives and souls to our work, and it's human that they support us with medical insurance. I have been living here for 25 years. I have suffered in my own flesh of not having medical insurance. I suffer from severe migraine, and I've never been able to go to a specialist because I do not have the money to pay for my medical expenses. As a result of my long working hours, I have problems with varicose veins, and the problem has worsened in the last 4 years. I am afraid of developing blood clots. I have diabetes that develops emotionally, and I need to be in control of that. I need to be able to take x rays, and I can do all of this for the lack of opportunity to have medical insurance. I live with fear, always thinking about my daughters. I don't want anything bad happening to them. I have 2 girls to live for. They depend on me. The pain in my legs have been getting stronger every single day. It makes it difficult for me to stand all day at work. And things such as driving my vehicle, which is very common. Sometimes I have to use the opposite leg because I get cramps and I feel like my leg is going to explode. We deserve and we ask for your support now that there are federal cuts. We take care of their children, their families, homes. We are the ones who prepare the food in restaurants. We are the ones who take care of parents. We clean their offices. And who takes care of us? No one does it. I would like to add that at this time, and due to the current situation, many families will suffer for medical insurance. The current situation in the United States presents an uncertain and challenging outlook for health insurance, might the possibility of significant increases in premiums, which could exceed 100% of for some families in 2026 due to the expiration of ACA subsidies. It is expected that thousands of people could lose health coverage. We pay our taxes and we are impact of undocumented immigrant workers of the U.S. economy. Thank you. We value your time and we thank you for listening to our testimonies. Thank you.
Thank you for sharing that. And thank you, Carla, for your testimony this evening. Next, we have Kirsten Ferguson.
Yes. Hi, good evening, Representative Dathan and members of the committee. My name is Kirsten Ferguson. I'm a community oral health champion and with the Connecticut Oral Health Initiative. I'm also a mother of 4. 2 of my children are young adults with severe disabilities who depend on Husky for their medical care. My daughter Autumn is 23 and now lives in a group home because of her high level of need. My daughter Ava is 21 and remains at home with us. I also have 2 younger children who qualify for Husky based on our current income. Up until recently, my family had high quality private health insurance. We had broad access to providers and never worried about out-of-pocket costs. It is deeply ironic that now, during a period of financial instability, when medical needs are greater, we face more restrictions, fewer participating providers, and greater barriers to care. That perspective shapes why I'm here today. First, please remove periodontal treatment from the $1,000 annual Husky cap. Periodontal disease is a serious infection. Individuals with IDD are at higher risk for periodontal disease, due in part to limitations related to personal hygiene care and the challenges of some IDD individuals like my daughters to express pain or discomfort that should alert caregivers to potential health issues. Periodontal disease causes pain, tooth loss, and systemic inflammation, and it is closely linked to diabetes and heart disease. When patients reach the cap, many simply stop treatment because they cannot afford it. Disease progresses. What could have been managed early becomes an emergency that leads to higher costs. Emergency room visits, extractions, advanced procedures, all of which are far more expensive than preventative care. Removing periodontal treatment from the cap is both medically and physically responsible. Second, we must increase Medicaid reimbursement rates. Low reimbursement rates mean many providers cannot afford to accept Husky. Families like mine are left calling office after office only to be told that they are not taking Medicaid. Providers who do accept Husky often have wait lists of months or even years, as is the case for Autumn and Ava's access to basic preventative dental care. Coverage without access is not true coverage. When reimbursement is inadequate, participation drops, care is delayed, conditions worse, and the system ultimately pays more. If we want Husky to function as real health coverage, then reimbursement rates must reflect the actual cost of care. Finally, please protect and preserve the Community First Choice program. For my family, CFC was the bridge that allowed Autumn to live at home for as long as possible. It continues to support Ava at home today. These services preserve dignity, stability, and family unity. They allow caregivers access to employment, which would not be possible. When families lose access to these supports, the alternative is often institutional care, which is not only more disruptive, but far more expensive for the state. Community First Choice is not just compassionate policy, it is sound fiscal policy. I respectfully ask you to remove periodontal treatment from the Husky cap, to increase Medicaid reimbursement rates to ensure real access to care, and to protect and preserve Community First Choice. These decisions affect
Thank you.
families like mine every single day. Thank you for your time and consideration.
Thank you, Kirsten, for your testimony this evening. Next, we have two people kind of swapped out, and we have number 154 going in their place. Callie Moquette. You have 3 minutes, Ms. Moquette.
Good evening, Senators Austin, Lesser, Representatives Walker, Dathan, Gilchrist, and esteemed members of the Human Services Subcommittee of the Appropriations Committee. My name is Callie Moquette. Thank you for accepting this testimony regarding HB 5032 on behalf of Health Equity Solutions, a nonprofit, nonpartisan advocacy organization with a statewide focus on advancing health equity through anti-racist policies and practices. HES stands with Health Justice Now, a statewide coalition fighting for quality, affordable health care for everyone in Connecticut. Decisions reflected in this bill will determine whether Connecticut sustains and strengthens recent progress towards health equity or allows disparities to widen. Each year, HES engages in community conversations with Connecticut residents to inform our policy agenda. To date, we have engaged over 1,000 participants across the state. The ability to afford and access quality health care has consistently ranked among residents' top 3 concerns. These concerns are supported by statewide data. A recent survey of more than 1,400 Connecticut adults found that over 60% reported delaying or skipping needed medical care because of cost. This reality underscores that even insured residents are struggling to access care when premiums, deductibles, and out-of-pocket expenses remain high. Further, affordability challenges are quickly becoming a crisis as the federal government allows enhanced premium subsidies to expire, denied marketplace support to some lawfully present immigrants, causing over 5,000 Connecticut residents to lose coverage last month, and put in place regulations that will make it increasingly difficult to remain enrolled in Medicaid and increase the cost of marketplace plans. In the year ahead, work reporting requirements and increased eligibility checks will be introduced to Husky D, and refugees and asylees will be ineligible for Medicaid. Over 200,000 Connecticut residents are projected to lose their health insurance in response to these changes. This budget records losses of Medicaid coverage as state savings. These savings, which are really federal cuts, reflect many thousands of Connecticut residents who will have no meaningful access to health care and increases in uncompensated care. We strongly urge this committee to invest these savings in state policies that can offer long-term coverage solutions and improve the quality of care. This crisis is not inevitable. We respectfully offer the following recommendations regarding HB 5032, aimed at mitigating coverage losses and bridging the persistent gaps in affordability and access to quality health care. Invest in access to affordable and quality health care. Fund community health workers to comply with statute improve health outcomes, reduce Medicaid costs, and address health disparities. Address the benefits cliff. Reject changes to covered Connecticut. Explore long-term affordability strategies. First, community health workers are among the most effective tools available to the state to improve coverage retention, reduce Medicaid costs, and advance health equity. CHWs are frontline public health professionals who share the language, culture, and lived experience of the communities they serve. Research shows that for every dollar invested, Medicaid realized a return of $2.47. I'll summarize. Covered Connecticut has been transformative in expanding access. We urge the state to model a basic health program that'll help save the state a lot more money. We firmly believe that if you were to support modeling alternative state-administered coverage options for residents losing access due to federal changes, this could save a lot more for the state. And we urge you to consider this. Please review Health Equity Solutions' written testimony that has been submitted as well. Thank you for the opportunity to submit this testimony.
Thank you so much for your testimony this evening. Next, we have Karen Siegel. I don't see her in the waiting room. I'm not sure if she's there in person.
She will not be speaking. 154 took her place.
Apologies, got that mixed up. Next, we will have Paul Kidwell. Thank you, Mr. Kidwell. You have 3 minutes.
Thank you. Good evening, Representative Dathan and Representative Gonzalez. Paul Kidwell from the Connecticut Hospital Association. Appreciate the opportunity to testify on the budget adjustment bill. CHA opposes provisions of the proposed budget related to the hospital tax. This state fiscal year, hospitals will pay $820 million in taxes, and of that amount, the state retains a little more than $500 million for its own purposes and uses approximately $300 million to draw down federal matching dollars to support Medicaid payments to hospitals. Under the governor's budget proposal in state fiscal year 27, the state will increase by $100 million to $900. The tax will increase by $100 million to $920 million. Waterbury Hospital will become exempt from the tax, but will still be entitled to tax-funded Medicaid payments, and Connecticut Children's will be prohibited from participating in the tax program. If implemented, the state will be the largest beneficiary of the tax increase, enhancing its gain by an extra $53 million a year. This is in addition to the $500 million it already takes. Of the $40 million set aside to support hospitals from the revenue generated from the tax increase, $15 million is designated to Waterbury Hospital, which would no longer pay the tax, and the remaining $25 million would be divided among the 23 remaining tax-paying hospitals. And each year, Connecticut hospitals will continue to lose $1.5 billion providing care to Medicaid patients. We oppose the governor's proposal. The tax program should be used to support patient care at hospitals. The administration's proposal does not. The tax program should seek to maximize federal funding for Connecticut. The administration's proposal leaves money on the table. Hospitals that receive tax-funded payments should pay taxes. The governor's proposal does not require it. Hospitals that want to participate in the tax, like Connecticut Children's, should be able to. The administration's proposal prohibits it. There is a better approach to the hospital tax, and we look forward to working with the legislature to advance that approach. We believe that the hospital tax program should maximize federal revenue and ensure that 100% of any increase in the tax is used to improve hospital reimbursement for patient care and begin to address chronic Medicaid underpayment. We believe Connecticut Children's should participate in the program and that Waterbury Hospital should fully participate in the program as a tax-paying hospital, maintaining its current status. We appreciate the opportunity to testify this evening and look forward to working with you throughout this process. Thank you for the consideration of our position.
Thank you, Mr. Kidwell. Next, we have Barbara Bellevue. Looks like she's in person. Thank you. Barbara, you have 3 minutes. Thank you.
Good evening, chairpersons, members of the Appropriations Committee. My name is Barbara Bellevue. I live in East Hartford. Thank you for the opportunity to testify today. I'm here because of the governor's proposed budget. Excuse me, adjustments to DSS will directly affect me and I want to make this, excuse me, I want to make this committee here's the people like us that the decisions hit the hardest. It's outrageous and unfair that the federal government is pushing hardworking families who need health care. We know Connecticut can't wait until our families. I'm sorry, I'm losing some.
You're fine.
We can't wait for a problem when we need the money in our budget. These are. You need to plan for real dollars behind it, and you need it before the crisis hits. These are our neighborhoods, our coworkers, our families. A couple of years ago, I had brain surgery, and I would not be able to have afforded it without Medicaid. And I also, a few months ago, been diagnosed with mental illness. For these things, I am thankful I have Medicaid, but as of last year, in September, I lost my husky, and now my medical bills are at least $100 a month for my medication that I need. I'm just asking you, this committee, to invest in state-run transitional benefit system to protect people that are losing SNAP now and tomorrow, and that the state has a plan to help protect people that are on husky and at risk of losing it. We need a budget that protects working class people. Thank you very much for your time.
Thank you for your testimony this evening. Next, we have Francis Trisecki. Hello, sir. You've got 3 minutes.
Thank you. Good evening. My name is Fran Trisecki. I live in Canton, Connecticut. I'm the parent of an adult daughter who has a developmental disability, and speaking tonight on behalf of our many friends who depend on the CFC program and in opposition to the elimination of Community First Choice. For 11 years, this has been a highly successful program, now supporting 7,250 Connecticut residents with developmental disabilities and significant support needs. CFC has been instrumental in allowing many of these individuals to receive in-home support rather than institutionalized care, supporting their engagement in the community, including employment, recreation, while allowing their parents to maintain their own employment. We are told that this will save the state millions of dollars and that no one will lose any support, as everyone will be moved to one of the existing waiver programs or to a new waiver program yet to be designed. So a few questions. How is it possible to provide similar services to thousands of individuals currently using CFC through waiver programs while providing no additional staffing for those programs or funding for those programs? It isn't possible, of course. They will simply be added to a waiting list. The majority of DSS waiver programs have significant waiting lists already, with wait times as much as 4 to 10 years. For instance, the autism waiver currently serves approximately 301 people versus a waiting list of 2,515 people. How will services be provided to thousands of individuals moving to waiver programs with these current long waiting lists and no additional staffing? They won't be, of course. Many individuals making use of the CFC program will be forced to seek nursing home care. How does the state intend to pay for this costly high level of care? Nothing is mentioned in the bill. A significant number of those using CFC are not eligible for any existing waiver program. How will this group be supported? Creating a new waiver program for them will take years, new legislation, and new funding. Presumably, new people needing CFC will be shut out of support entirely. I urge you tonight to reject the governor's proposal to eliminate the CFC program. It's simply an attempt to save money on the backs of the developmentally disabled while reversing years of progress that we have made as a state toward inclusion and deinstitutionalization. Savings are claimed, promised support is an unfunded fallacy. Thank you for taking my testimony.
Thank you for your testimony this evening. It's very much appreciated. Number 99, Nora Duncan. I don't see her online. Is she there in person?
They will not be testifying.
Okay, thank you very much. Next, we have number 100, Teresa M. I think I see you online, so you have 3 minutes, madam.
They will be using an interpreter.
Okay, thank you.
Ok. Hola, mi nombre es Teresa. Soy puertorriqueña y tengo muchos años viviendo en Connecticut. Soy una persona muy activa en mi comunidad, en Make the Road, Connecticut y en mi iglesia. Apoyo este proyecto para que se puedan garantizar los fondos de Husky y la importancia de evitar más recortes en el acceso de salud. En nuestra comunidad hay muchas personas sufriendo de problemas crónicos y muchas otras situaciones de salud. Todo esto sin el debido tratamiento ni seguimiento, ya que actualmente no cualifican para seguro médico. Debido a esta razón, a muchos se les hace difícil el debido seguimiento y tratamiento a las enfermedades o emergencias de salud que sufren. Los costos del sistema de salud los privan de gozar de propia salud. Esto no solamente les hace sufrir problemas de salud físico, sino que también su salud emocional y mental se deteriora. Viven en un constante estrés tratando de resolver sus problemas de salud, aumentándose o pagando miles de dólares en facturas si la condición empeora y necesitan buscar emergencia. Nuestra comunidad lleva décadas sufriendo esta iniquidad. Nuestros hermanos, así como muchos otros grupos, van a este país buscando mejores condiciones de vida y seguridad, pero sobre todo aportando mucho en diferentes sectores del área laboral. Pagamos impuestos y ayudamos con el sudor de nuestra frente al crecimiento de este país. Es por eso que solicitamos se garantice nuestra salud a través de la expansión del seguro médico para todos. Estas son las experiencias de un adulto sin seguro médico y no queremos que nuestros niños sufran lo mismo que nosotros ya sufrimos. Apoyen este proyecto de ley y esperamos que recuerden que la salud no es un juego ni un lujo, es una necesidad básica del ser humano para una mejor productividad. Gracias y buenas noches.
Hello, my name is Teresa. I am Puerto Rican and I have been living in Connecticut for more than 40 years. I am a very active person in my community, in Make the Road CT, and in my church. I support this project so that Husky funds and the importance of avoiding further cuts in health access can be guaranteed. In our community, there are many people suffering from chronic problems and many other health situations. All of this without proper treatment or even follow up, since they currently do not qualify for health insurance. Due to this reason, many find it difficult to properly monitor and treat the diseases or health emergencies they suffer. The high cost of health system deprives them of enjoying their own health. This is not only causes them to suffer physical health problems, but also their emotional and mental health deteriorates. They live in constant stress, trying to solve their health problems, self medicating, or even paying thousands of dollars in bills if the condition worsens and they need to seek emergency help. Our community has been suffering from this inequality for decades. Our brothers, as well as many other groups, came to this country looking for better living and safety conditions. But above all, we contribute a lot in different sectors of the labor area. We pay taxes and help with the sweat of our foreheads to grow uh, to grow this country. This is why we ask that our health be guaranteed through the expansion of health insurance for all. These are the experiences of an adult without health insurance. We do not want our children to suffer the same as we already have suffered. I support this bill, and we hope that you remember that health is not a game or a luxury. It's a basic need of human being for better productivity. Thank you.
Thank you very much. Thank you, Teresa, for your testimony this evening.
Thank
Gracias. Next, we have Nazarley, and apologies if I've mispronounced your name. I know someone's reading your testimony for you.
Good evening. Thank you for letting me read my friend's testimony, Nazarelli. Estimados miembros de la Subcomisión de Servicios Humanos del Comité de Asignaciones, mi nombre es Nazarelli, tengo 32 años y vivo en Hartford. Soy miembro del colectivo de defensa de Hartford. Tengo 2 hijas, una de 10 años y otra de 7 años. Ambas tienen seguro médico Husky y realmente dependemos de ello. Debido a muchos traumas que pasamos en nuestro país, mis hijas tienen tratamiento psicológico para superarlo. Además, mi niña de 7 años sufre de alergias. Cuando empeora, su cuerpo se hincha y no puede respirar. En el hospital la tienen controlada con una dieta muy restringida y el pediatra la está refiriendo varios exámenes para determinar sus alergias. Yo no tengo seguro médico, aunque trabajo mucho porque es muy caro. Actualmente tengo una deuda de más de $80,000 por 2 operaciones de emergencia que me hicieron en el hospital de San Francisco. Yo me estaba revisando por unos dolores muy fuertes en mi vientre en el hospital de Hartford, en el cual me habían encontrado problemas con mis ovarios, por lo cual necesitaba una operación que no me hacían porque yo no podía hacer los papeles que me pedían para determinar el pago de la operación. Y además de eso, se demoraban en darme la cita. En mi trabajo no me podían hacer la carta que pedía el hospital. Por necesidad, ya que soy el único sustento de mis hijas, seguí trabajando en demolición, a pesar de todos mis problemas de salud. Y fue ahí donde me desmayé y me llevaron al hospital de San Francisco, donde me operaron de emergencia, porque me dijeron que se me había torcido los ovarios. Después de la cirugía, yo me atendí sola en mi casa porque al no tener seguro no podía seguir con la atención postoperatoria. Al pasar un mes recaí otra vez y de emergencia me volvieron a operar, esta vez de la vesícula, porque el esfuerzo del trabajo me había hecho daños internos. Yo gano $13 por hora, trabajando de lunes a domingos, de 7 a.m. a 7 p.m. para pagar mis facturas y la comida de mis hijas. Aunque yo no tengo seguro médico, yo sé que el programa Husky, financiado por el Estado, ha sido un salvavidas para muchos. Espero que el Estado extienda ese salvavidas a los muchos inmigrantes que cumplen con los requisitos de ingresos para Husky, pero están a riesgo de perder el acceso debido a su estatus migratorio. El seguro médico es una necesidad vital para mí y mis hijas, y estoy agradecida a Dios porque ellas sí tienen seguro Husky. Por favor, mantengan y fortalezcan este seguro, que es una necesidad humana y en mi caso es un asunto de vida o muerte. Gracias por su tiempo, Nazarelli.
Thank you. Is one of the translators going to translate for us this evening?
I believe so. The translator is still online,
Okay.
or actually they are not, unfortunately.
I was going to say, I don't see them,
Yeah.
sadly. Is there an interpreter in the room that could help?
We do not have one, unfortunately.
One moment.
One moment, I think. We have someone in the room who will be translating.
Perfect. Thank you so much, Madam.
Hello, members of the Appropriations Committee. My name is Nazarelli. I am 32 years old and I live in Hartford. I'm a member of the Defense Collective in Hartford. I have 2 daughters. One is 10 years old and one is 7 years old. They both have Husky health insurance and we really depend on that. Due to the many traumas that we have lived through in our countries, my daughters have received psychological treatment to live with that. Also, my 7-year-old daughter has allergies, which when they get worse, she suffers swelling and she can't breathe. And in the hospital, they have her under a very strict diet, and the pediatrician has referred her to various exams to determine the source of her allergies. I personally don't have health insurance, even though I work a lot because I can't afford it. Right now, because of some health issues that, or 2 surgeries, emergency surgeries that I had to receive at St. Francis Hospital, I am in debt
for $80,000. I was getting seen for some very deep pain in my womb area, and the Hartford Hospital said that they found issues in my ovaries and that I needed emergency surgery, but that they couldn't do it there, so because they couldn't determine how I would pay for the operation, and also they wouldn't put me on the schedule. They delayed getting a follow-up appointment. Because of need, because I am the only breadwinner of my family, I continued to work in construction, even though I had these issues with my health. And that's when things came to a hit, and I fainted. And I was taken to St. Francis Hospital, where I was given emergency surgery because of my condition in my ovaries. And then after the surgery, I had to take care of myself at home because not having insurance, they told me I was not eligible for post-surgery care. After a month, I had, the things got worse, and I had to go back to the emergency room. And that time they found that I needed another surgery because of strain due to my work, and that I had already created some long-term problems internally in my body. I currently make $13 an hour, working Monday through Sunday, 7 a.m. to 7 p.m. to work, to pay for my bills and to put food on the table for my daughters. Health insurance is a necessity that is vital to me and my daughters, and I am really grateful to God because they have Husky insurance. Please maintain this program and strengthen it, because insurance is a human necessity, and in my case, it's a matter of life or death to receive medical care. Thanks for your time.
Thank you so much for translating for us. Next, we have online Heather Poole LaFontaine. I see her online. There she is. You have 3 minutes, madam.
Thank you. Good evening, and thank you for the opportunity to speak today to the distinguished members of the Appropriations Committee. My name is Heather Poole LaFontaine. I'm the supervisor for the Community Health Worker Intern Academy at the YWCA of New Britain. I'm testifying today in regards to HB 5032. Our program trains high school and young adult interns to become certified community health workers while serving our local community. I want to share what CHW Medicaid reimbursement means in real human terms. Our Community Health Worker Intern Academy is especially important for youth because it creates a direct pathway to a meaningful healthcare career while allowing young people to serve the very communities that they come from. Many of our interns are first-generation college students or from families who have personally experienced barriers within the healthcare system. Through this program, they gain certification, paid field experience, mentorship, and real-world skills in care coordination, advocacy, and addressing social determinants of health. Medicaid reimbursement would provide sustainable funding to expand stipends, supervision, and training, ensuring the youth are not only prepared for long-term careers in healthcare, but also retained in community-based roles where they are deeply needed. Stable reimbursement strengthens the workforce pipeline, increases economic mobility for young people, and ensures that communities continue to have trusted, culturally connected CHWs, improving health outcomes. Community health workers support our community in many impactful ways, and I would like to highlight 2 effective and meaningful examples of how our intern academy is carrying out the mission of a CHW. Our community resource night is designed to meet immediate needs while building long-term stability. Community members are invited to access donated items such as clothing for all ages, hygiene products, school supplies, and household essentials, reducing the financial strain on families, but it goes beyond distribution. During the event, our community health workers connect individuals to local resources, including food pantries, healthcare providers, utility assistance programs, housing support, and workforce services. We take the time to explain how these services work, assist with applications, and help families understand eligibility requirements so that they can confidently navigate systems on their own. By combining tangible support with personalized guidance, Community Resource Night serves as both relief and empowerment for the families that we serve. During COVID and the flu vaccine clinics that we hosted in partnership with local providers, our CHWs were critical in building trust, especially with families who were hesitant or faced language barriers. Because our interns come from the community, They understand the cultural concerns and speak the language of the people that we serve. That trust increased vaccine participation and reduced preventable illnesses. Sustainable Medicaid reimbursement is not just about funding physicians. It is about preventing emergency room visits, reducing hospital readmissions, lowering provider burden, and improving outcomes by addressing social determinants of health before they become medical crises. Our CHW Intern Academy is building the next generation of this workforce. With sustainable reimbursement, we can continue training, retaining, and deploying CHWs who save lives and reduce costs every day. Thank you for the opportunity to testify in regards to HB 5032. I respectfully urge you to fully fund the implementation of Medicaid reimbursement for CHWs. This investment will strengthen our health system, support a stable workforce, and improve health outcomes across Connecticut. Thank you.
Thank you, Ms. Pula-Fountain, for your testimony this evening. Appreciate it. Next, we have number 102, Lori Pascolini.
Lori has not accepted our promotion to panelist. If you are having a difficult time accepting the promotion to panelist, please try logging off the Zoom and then logging back on. And for those of you in the queue, please make sure to accept your promotion to panelist.
Thank you. Lori, hopefully you can hear us. We will move on to the next one. We can come back to you, Lori. Next, we have number 103, Rachel Correll. Rachel, there you are. You have 3 minutes, madam.
Rachel, please unmute yourself.
Thank you.
Unmute. Okay. Hi, sorry. All right. Good evening, honorable members of the Appropriation Committee. My name is Rachel Carell, and I'm from Newington. I am a rehabilitation therapy supervisor at Solnit South. I'm here today to tell you that you need to increase funding for the Department of Children and Families. Last year, I wrote about water main break in our facility. This ended up being just the first in a series of issues with the facility's physical environment. The water main break lasted for 48 hours, excuse me. That is 2 days without the use of toilets, sinks, showers, or options for drinking water. Non-functional bathrooms aren't tenable for long, especially for kids. They told us they desperately had to use the facilities, and we had to let them pretty soon if the kids didn't want to eat or drink, because they knew that if they did, it meant that they would have to actually use the bathroom, which would end up getting disgusting because it was inhumane and full of, well, I won't even go into detail about that. But the fallout from the water main break could have been mitigated in multiple ways, but management elected to ignore the issues instead of addressing it. We could have called the families of those who go home for the weekends and advise them of the issue to see if they could go home sooner. We could have brought porta potties in and water in, but we didn't. A similar story played out more recently when the electricity went off. On a Friday morning, the electricity went off across the whole campus. Now, this is a hospital, a large-scale hospital that has psychiatric children, and the backup generator failed. The generator at the planned evacuation spot failed, and it took nearly the whole weekend to get a reliable power supply to the whole facility. Some of the girls were transported to Solnit North. Those were the girls that could. The rest of the hospital kids had to remain back in the hospital with basically the lights off. Only once it started to get dark, was when somebody purchased flashlights, and they used flashlights to check on kids in bedrooms for the 5-minute checks that they had to check on the kids. We've been told that administrators met to debrief the situation, but at no point did they ask those of us actually caring for the children for feedback, nor have they presented plans for how to ensure that staff and youth know what to expect if or when something like this happens again. On top of the utility outages, housekeeping is so understaffed that we're not able to have basic housekeeping or house cleaning. Bathrooms are not cleaned, garbage cans are overflowing in closets to the ceiling, and basic supplies like toilet paper are constantly in short supply. I just wanted to give am I done?
If you could please summarize, Rachel, that would be great. Thank you so much for your testimony. Just summarize if you would.
Okay, the bottom line is that we need to stop treating our children like second-class citizens. The other variable too is that the kids feel like they're in prison because they feel like we've had to board up windows and so forth, and the boarding up lasts for months. And the children really are treated as second-class citizens at this facility with lack of supplies and boarded up windows, and it feels like a prison to them when it's supposed to be a psychiatric hospital. So please, again, please provide more funding for DCO.
Thank you so much, Rachel.
Thank you very much. Okay.
For your testimony this evening. I understand that Lori is having a difficult time. Maybe Lori, if you can log off and try it one more time, that would be great. Next, we have Julie Hall, number 104. I don't think I saw her. No, I don't see her. Is she in person?
Yes.
Oh, thank you.
Good evening, distinguished members of the Appropriations Committee. My name is Julie Hall, and I'm the Deputy Program Officer at Lumability, responsible for Kid Steps Birth to 3 program, serving 51 towns across Connecticut. I'm here to speak about the DSS funding for the Birth to 3 system. Birth to 3 has been flat funded since rates were implemented in 2017. The governor has added funds to bring the DSS budget line to $4.5 million, tying the money to the proposed tiered rate structure described in the state-sanctioned Birth to 3 rate study report. I'd like you to know that there were actually 2 options that resulted from that rate study, one that had tiers and one that uses our current structure. The proposed $4.5 million added to the budget only covers the tiered option. These funds do not cover the cost of actually providing the services. You heard my colleague earlier share that only 2 out of the 1,000 or more therapists or special educators that are providing these services are eligible to bill at this top rate that's needed, and approximately 85% of that same workforce is classified as an entry-level professional only able to bill at the lowest rate, even if they're holding a master's or doctoral degree and have 10 to 30 years experience in early intervention specifically. In a nutshell, this is why the tiered option costs are less to implement to the state, but the problem is that there is limited access for providers to even access those funds, and they don't cover the cost of the services directly. So while the OAC has shared that they expect that this advanced credential that's needed for the top tier will support recruitment and retention, programs that are providing these services strongly disagree. In fact, we believe that this will have the opposite impact, tying our hands and destroying the system. So you should know that there are more and more children seeking Birth to 3 services in the recent years, and that last year we provided more than 24% more evaluations than we had in the year prior, and that last year we delivered only 69% of the hours of services to families that we did in 2019. When you're talking about a child who has an autism diagnosis, they're currently receiving 62% less hours of service as compared to 2019. And when you're looking at children across different disabilities and diagnoses in Connecticut, they're currently receiving 9% fewer hour services than they were in 2019. So fewer therapists, more children, and only having 24 hours in a day means that there are less hours of service to spread around, especially since there's no wait list permitted. So the situation's dire. 2 of the original 19 programs providing Birth to 3 services have stopped altogether, and there are 2 other agencies that have drastically reduced the number of children that they support and how they do that. The financial burdens can no longer be carried by the agencies providing these services. So please fully fund Birth to 3. Don't tie the rates to a tiered system. Procedures should guarantee quality. And thank you for your time and your leadership.
Thank you very much, Ms. Hall. We have somebody who's going to try to speak. Madam Clerk, did you get them on?
Yes, so Lori, if you can hear me, if you could please unmute, we will try hearing your testimony this way. Lori, go right ahead.
Can you hear me?
Yes, we can.
Hi, sorry about that.
No problem.
Thank you for allowing me to testify this evening in support of HB 5032. My name's Lori Pasqualini. I'm the Chief Financial Officer at Ability Beyond. And Ability Beyond provides services to people funded by a variety of sources, including the Department of Social Services, Department of Mental Health and Addiction Services, Department of Developmental Services, the Autism Waiver, the Acquired Brain Injury Waiver, as well as school systems. And tonight, I'm here to talk about the outpatient behavioral clinical services that are provided to the people that we serve. Ability Beyond does not provide those services, but we rely on other organizations that do. And what we're finding is that the people we serve are not able to access the services they need, which then creates additional burden for those people and for organizations like Ability Beyond that are trying to help people get better and live lives in their community. And I believe the reason that their services aren't available is because the funding is far too little. So for today, I'm not advocating on behalf of Ability Beyond for specific funding, but on behalf of the behavioral health providers and the FQHCs that provide services to the people we serve who aren't getting the services that they need. These are some of Connecticut's most vulnerable. You've heard about it all day so far. And we just are wanting to support those organizations because our organization can't do the job we need to do without the support of the FQHCs and the other Medicaid providers. So thank you for your time, and I hope that you will fund in excess of the amount that's in the governor's budget for the Medicaid services to be properly funded so that we have enough services throughout the state of Connecticut. Thank you for your time.
Thank you, Lori, for your testimony, and apologies for the technical issues. Appreciate you persevering. Next, we have Lori Savage. I think I saw her a minute ago, but I think she has fallen off. Madam Administrator, did she leave?
I don't see her.
Okay, we'll move on. Number 106, Sharon Heddle.
Good
There you
evening.
are. Good evening. Thank you for your patience.
No, thank you for hearing me tonight. Good evening, members of the Appropriations Committee. My name is Sharon Heddle, and I'm the Executive Director of Disabilities Network of Eastern Connecticut, one of Connecticut's 5 independent living centers. I'm here to ask you to support a $1 million increase in funding for the independent living centers in the upcoming budget. That equals $200,000 per center. Independent living centers serve people of all ages and all disability types in every region of our state. Our mission is simple and powerful. We help people with disabilities live independently, remain in their homes, and participate fully in their communities. We provide information and referral, peer support, independent living skills training, advocacy, and transition services for youth and individuals moving out of nursing facilities and other institutional settings. The need for our services continues to grow, but our funding has not kept pace. State funding for independent living centers has remained nearly flat for decades and is now more than 35% behind inflation. Today, each center receives just over $200,000 in state support. With that limited funding, centers across Connecticut are operating at or beyond capacity. Service areas have been reduced and waiting line lists are growing. At Disabilities Network of Eastern Connecticut, we are often the first call people make when they're overwhelmed and unsure of where to turn. Individuals contact us when they're at risk of losing housing, struggling to access health care, navigating complex benefit systems, or trying to transition out of institutional settings. Too often, we must tell them we will call them back next week or place them on a waiting list. The need is urgent, and the only barrier is staffing. An additional $1 million statewide would allow the independent living centers to hire and retain qualified advocates at a living wage, expand services into rural and underserved areas, and begin restoring capacity that is eroded over time. At a moment when federal funding is uncertain, stable and adequate state support is essential. Connecticut is in a strong fiscal position. This is a modest investment with a meaningful return. It protects vital services, strengthens communities, and ensures that people with disabilities can live with independence, dignity, and choice. Thank you for your time and your consideration of this request.
Thank you, Sharon, for your testimony this evening. Next, we have number 107, Kayla Ertel. I see you here. There you are. Please go ahead. You have 3 minutes, madam.
Okay. Good evening, Senator Osteen, Representative Walker, and members of the Appropriations Committee. My name is and I work at one of Connecticut's 5 non-residential independent living centers as an advocate for develop skills needed and essential equipment that allows the individuals served to remain safe and independent in their homes. In my time at the center, I've helped a 58-year-old woman secure a wheelchair ramp, a 77-year-old woman obtain a hearing aid, and a 64-year-old woman with COPD obtain a much-needed air conditioner. However, I'd like to share a story about one of my consumers, Bob. In May, our center was contacted by Bob, an 18-year-old student with bipolar and schizoaffective disorder. He was about to graduate high school and was unsure of the next steps to take, like so many other young people. Bob had big dreams. He wanted a hands-on job, ideally in auto repair. However, he faced significant barriers. He lives in a rural area without public transportation and doesn't have a driver's license nor a car.
Kayla, you're
Learning to
breaking in
drive
and
was
out.
one of his goals. He also wanted to move.
Kayla, you're kind of breaking up a little bit. You may want to just turn off your video so and just start like about a sentence before we just lost you for a second. So if you can turn off your video so you come in very much stronger on your audio, that would be great. Thank you so much. Go ahead.
Okay. Sorry. He also wanted to move into his own apartment. To do that, he needed to learn how to budget, maintain a household, and most important to him, cook for himself. This is where I stepped in. Together, we set clear goals and broke them into achievable steps. We began with what excited Bob the most, cooking. When we started, Bob could make scrambled eggs, though he often burned them. He wanted to learn more than just the basics. He loved ground beef and wanted to make cheeseburgers and meatballs from scratch. Each week, I visited Bob's home. One week, we would plan the meal, locate a recipe, and create a budget while writing the grocery list. During the week, he would go to the store with his family and purchase the needed items. The following week, we would cook together. We worked through every step, managing the stove and oven temperatures, following a recipe, safely preparing food, and cleaning up afterwards. He went from burning scrambled eggs to confidently preparing full meals like burgers, spaghetti and meatballs, tacos, and Alfredo pasta, all while proudly serving his family. Once he checked that goal off his list, he has checked that goal off of his list. He now knows that when he moves into his own apartment, he can plan, shop, cook, and maintain his kitchen. After building confidence in cooking, we moved on to organizing and maintaining his bedroom. sorting items, creating systems, and developing routines. This is what independent living looks like in practice: setting goals, building skills, gaining confidence step by step. I have shared a few small stories and one that I am most proud of. I am asking you to increase funding for Connecticut's independent living centers by $1 million. The services we provide often determine whether someone can remain in their home or enter a facility. This investment directly supports independence, dignity, and cost-effective community-based living. However, inadequate funding limits how we fully can meet the needs of the people that we rely on. Thank you for your consideration.
Thank you, Kayla. Appreciate your testimony and hanging in there with the issues with technology. Next, we have number 108, Margaret Lancaster.
Good
Good
evening.
evening, Margaret.
Good evening, and thank you, distinguished members of the Appropriations Committee, for your time. My name is Margaret Lancaster. I'm a Senior Health Program Coordinator at Ledgelight Health District in New London, Connecticut. In 2023, Connecticut passed the legislation requiring Medicaid reimbursement for community health workers. This was a critical decision that recognized the essential role that CHWs play in our improving health outcomes, advancing health equity, and preventing costly health crises, as well as the cost savings associated with CHW programs. However, the policy has not been fully implemented. 30 states already reimburse CHWs through Medicaid. Connecticut is a little behind, but we're working on it. CHWs are frontline trusted public health workers that help residents navigate healthcare access, benefit management, chronic conditions, and address social barriers such as housing, food, insecurity, transportation, just to name a few. CHWs meet people where they are at and provide support, keep individuals healthier and out of emergency rooms and hospitals. If I could give you a quick story about an individual, a gentleman who I've worked with, was from Florida, and he was here homeless about 10 years ago, and he came up from Florida, and he currently has lived in a rooming house because he can't afford an apartment based on what he receives for Social Security or the money he receives at this present time. His landlord called me with a concern about this gentleman, and it was that he was starting to walk into walls in the rooming house that he was staying in. Now, that being said, the landlord and the roommates were so concerned about the man, they had no one else to call because he had no family here. His family had all been deceased. He had no children. So they called the CHW from the health department to reach out to see what services he could be provided. I was the one who took on this individual's situation. We found out that while he was living in Florida at that one time, his insurance for Medicare had not been transferred to Connecticut. He didn't know how to go about it at all. He hadn't been to the doctor in almost 10 years. So we started the process by going and getting his Medicare and his insurance up to date. We also initiated the fact that he hadn't had an eye exam in over 20 years. So when we did eventually went to a doctor, we found out that he had cataracts that was so beyond what even the ophthalmologist could ever have worked on before, that it took us more than 6 visits to really get him to where he needed to get to a place where he needed to be able to be surgically remove the cataract itself. I have to say that we went through trauma with him based on what his mother went through. So as a CHW, you build a relationship with individuals and you find out more about their lives. He had trauma around this, and his blood pressure would go so sky high just going to the doctor's office that they would not want to see him, and they were asking to take him to the emergency room based on what was taking place. But he kept telling them it was his anxiety behind his mother's own trauma. When she went in for eye surgery, she came out not able to see. I knew that, but how else would anybody else have known that? He got through his surgeries, both of them. Now, the doctor himself, the ophthalmologist, said this was one of the toughest surgeries he has ever done. And he took a rock out of one of his eyes that he had never seen that large before. And this ophthalmologist in our community has been here for many years. But this gentleman can see today. We were able to look at the sky as I drove him home. And he was able to see and read signs that he wasn't able to see for months, based on the fact that a community health worker was able to build a relationship with him, understand his situation, walk him through the process, and get him to a doctor where now he's able to see again. That's the other things that CHWs do work on with individuals, and we call them our neighbors as well. Thank you for the opportunity to testify on HB 5032. I respectfully urge you to fully fund the implementation, Medicaid reimbursement for CHWs. The investment will strengthen our health system, support a stable workforce, and improve health outcomes and quality of life for our neighbors across Connecticut. Thank you again for your time.
Thank you, Margaret, for your testimony this evening. Next, we have Greg Shangold. Doctor, please go ahead. You have 3 minutes.
Hi, good evening, Senators and representatives of the Appropriations Committee. Thank you for the opportunity to speak today on behalf of the physicians of both the Connecticut State Medical Society and the Connecticut College of Emergency Physicians. Physicians, and specifically about the vital need to increase physician Medicaid rates. My name is Dr. Gregory Shangold. I'm a board-certified emergency physician practicing in Connecticut for 24 years. I lead a group of 90 emergency physicians and advanced practice providers staffing 7 emergency departments, caring for 600 patients daily. This is now the 4th year in a row we are debating increasing Medicaid rates for an amount established in 2007. At this point, there seems to be consensus that the current rates must be raised. For those that still require evidence, please refer to my submitted testimony. I cite significant sources that show Medicaid recipients will have better access to care with higher rates. Better access to care leads to less death and better healthcare outcomes. Overall costs will go down as private insurance cost shift lessens. Since we started this debate, other states have made progress, while Connecticut has done nothing to address the problem. According to the Kaiser Family Foundation, Connecticut now ranks 46 out of 50 for all services other than OB and primary care. Since we started this debate, more people are on Medicaid, now numbering over 1 million and including 30% of all children. Since we started this debate, people have less access to care and ED boarding has worsened. We must solve this problem now. The solution is to increase the rates to at least Medicare, and then each year the rate should be adjusted based on the Medicare Economic Index. Medicare alone rates do not adequately cover healthcare costs and should not be a statutory benchmark. Even though CT has frozen Medicaid rates for now 19 years and counting, the burdens on physicians have accumulated. Costs for running a medical practice have risen dramatically. Obtaining insurance mandated prior authorizations and other bureaucratic burdens adds unnecessary stressors on both patients and physicians. While facing more violence, these burdens accumulate into more burnout, where emergency physicians are the most affected. In a recent survey, 68% of emergency physicians report burnout. The consequences are severe. When patients lack access to primary and specialty care, they come to the emergency department with advanced disease, leading to worse outcomes and higher costs. Chronic conditions go unmanaged, leading to preventable complications and higher healthcare expenses. Connecticut's emergency departments are already stretched thin, and without action, access to timely emergency care is at risk. That is why the ED boarding task force created by this legislature recommended increasing Medicaid rates. This is the 4th consecutive year we've discussed this issue. While there is consensus that Medicaid rates are too low, no solution has passed. The medical community sincerely wonders why policymakers are content with being one of the worst states in the nation regarding Medicaid rates. The time for action is now. Strengthening Medicaid rates strengthens the entire healthcare system for all of Connecticut's residents. Thank you for your time and consideration on this matter.
Thank you, Doctor. I'm going to turn over to my colleague, Representative Jane Garibay, who's going to take over. And next we have Connet Schoenly, number 110. I don't see you online, Connor.
Yeah, we're going to move on to the next one. Thank you, Representative.
Madam Chair, we will clear the online panelists. So we have, up next we'll have Phoenix, followed by Chris, and then Susan, and then we will pause from the online speakers, and we will allow those who have been waiting patiently in person to testify.
Okay, thank you. So next is Phoenix Lightbringer.
Good evening, everyone. Committee members and people on this panel, thank you so much for being here today. I promise I will make this quick since we have listened to so many testimonies today. My name is Phoenix Lightbringer. I am from East Hartford, Connecticut. I am here today to talk about SNAP and the effects that the upcoming budget proposal changes are going to be affecting people, including myself, who benefit from it. I will preface this by saying that I am a master's degree holder in computer science. I am a high earner for the state of Connecticut, and I pay taxes, as everyone should. And I am struggling to make it work. I am on SNAP benefits for the first time this year, whereas last year I had none, and it has made a huge difference for me. Last year, when I had no SNAP benefits, I struggled to provide for my family. I struggled to get food on the table. I had to every week go to a pantry, a food pantry, just to try and find something. I subsisted off of expired meals that Aldi's and Trader Joe's were throwing away. I was subsisting on rotten fruit and peanut butter and jelly sandwiches, more peanut butter and jelly sandwiches than I had ever had in a year compared to the past decade. This year is much different. This year I have access to SNAP, and it has been a huge game changer for me. Not only do I know I will have food for my family, but additionally I can actually buy myself nice little treats every once in a while. A small bag of chips, a bar of ice cream. These things are so important for morale that I had not understood until I had lost them. I can't describe how much it made a difference when I realized I had not tasted ice cream for a whole year. And now I was able to, thanks to the SNAP program. So, finding out that the proposed changes to this budget are going to take SNAP benefits away from people, myself included, is monstrous. It is incredibly frustrating to hear. It is incredibly demoralizing to know that the governor does not seem to understand who actually benefits from this program. It shows how out of touch the people who are making this budget changes are with the people that are on the ground that are actually being affected. So today I am throwing my lot in and asking for this committee to look for our own state-funded benefits program to help make sure that the people who would be affected by these cuts don't be. We have so much money sitting here expressly for this purpose. And hearing that there are people that are representing us saying that they don't have a fiscal responsibility to take care of their constituents genuinely angers me, as it should anger most of you. Thank you for your time. I hope that you look at this budget and seriously think about the constituents that need it most. Thank you so much.
Thank you, Mr. Lightbringer, for sharing your story. Next up is Chris Pankratz.
Good evening, distinguished members of the Appropriations Committee. Thank you for the opportunity to speak this evening. My name is Chris Pankratz, and I'm the CEO and co-owner of Masters in Home Care. We're a licensed and skilled home health care agency servicing the state of Connecticut. And I'm also chair of the Government Relations Committee of the Connecticut Association for Healthcare at Home. I'm here tonight to address the structural underfunding and the ongoing rate erosion affecting Medicaid home and community-based skilled services. This issue is not new. It is not temporary. And without structural correction, rate erosion will continue year after year. When adjusted for inflation, Medicaid rates for home-based care are now more than 50% below 2007 levels. During that same time, labor costs, compliance requirements, documentation standards, and patient acuity have all increased. No healthcare provider can absorb sustained rate erosion of that magnitude without reducing access. Beyond the base rate stagnation, there are some structural flaws in the rate design as well. The 50% subsequent visit penalty punishes efficiency, even when the same skilled care is delivered. And medication administration rates are lower today than they were 10 years ago in 2016, despite higher labor costs and increasing behavioral health needs. Home-based care is not a cost driver in Medicaid. It is a cost containment strategy. When reimbursement instability forces providers to limit Medicaid participation, spending does not disappear. It shifts to higher cost institutional and hospital settings. We respectfully request a structured multi-year rate correction, elimination of the subsequent visit rate penalty, restoration of medication administration rates, automatic annual indexing, and reimbursement alignment when the state mandates wage increases. These are structural corrections, not expansions. If we don't address the sustained rate erosion, will not reduce spending. It'll shift spending to higher cost settings and increase long-term fiscal exposure for the state. Thank you for the opportunity to speak tonight.
Thank you so much for your testimony. Susan Flanagan is up next.
Good evening. Can you hear me?
Yes, we can.
Okay. Good evening, esteemed members of the Appropriations Committee. My name is Susan Flanagan, and I'm the director of CREC Birth to Three. CREC runs both a comprehensive birth to three as well as a support system for children who are deaf and hard of hearing. We appreciate the increase in funding given to birth to three in the 2025 legislation session and are pleased that the governor added funds to his proposed budget this year. But unfortunately, it is not enough to stabilize our programs. We have three asks. I urge you to support increased funding for birth to three to be able to provide the hourly rate of $167 that reflects the true cost of service delivery as outlined by the 2024 rate study, to maintain the general administrative payment of $200 per child and reject a tiered system of reimbursement. These steps will help stabilize the workforce and restore service intensity to appropriate levels. As you know, birth to three supports infants and toddlers during the most critical windows of brain development, a period when timely intervention can change the entire trajectory of a child's life. Yet despite rising needs, the system has been flat funded since 2017, and the consequences are now impossible to ignore. The general administrative payment covers essential service coordination and administrative work that are not reimbursed through fee-for-service funding. Over the past 10 years, as referrals have increased and demands on programs have increased, those administrative unfunded tasks have continued to grow, demanding more staff time and effort. The general administrative payment is the only way to fund those efforts. It should be increased, not decreased. Under IDEA Part C, Connecticut cannot maintain wait lists and must ensure timely services, but the current funding structure makes this increasingly unmanageable. Service intensity is dropping. In year 25, birth to three delivered only 62% of the service intensity provided in FY19 to children on the autism spectrum and 9% less to children without autism diagnosis. Connecticut faces a shrinking pool of early intervention therapists and special educators. With the increase of referrals and lack of wait lists, the remaining workforce is stretched thin, leading to burnout and further attrition. Since the start of the current contract period, 19 programs have been reduced to 17, with 2 withdrawing entirely and 2 reducing services due to financial strain. This is not sustainable. There are only 3 deaf and hard of hearing programs that cover the entire state. These clinicians spend hours in their car driving from home to home. The current schedule doesn't even cover their time spent in the car and mileage reimbursement. Birth to Three presently has a tiered level of reimbursement based on professional licensure. The new tier system divides the professional rate into 3 tiers, with the lowest being paid at $142, middle $152, and highest at $167. That rate is the the rate that the 2024 rate study said would sustain birth to 3. The highest rate relies on OEC training, which is presently inaccessible for the highest level for the majority of birth to 3 programs. At this time, based on the last lead agency report, only 2 early interventionists have achieved this level. You know that birth to 3 is the most cost-effective investment in a
That
state
would be
can make.
appreciated. Thank you.
Thank you for your attention.
Thank you so much for your testimony. Next is Tiffany Williams.
Good evening to the committee. Can y'all hear me? Okay. My name is Tiffany Williams, and I am from Hartford. I have been a personal care attendant for my brother for the last 6 years until his passing this past month. My brother was my right-hand guy, my motivation, and my ride or die. He was born scientifically premature, weighed just 3 pounds, and was facing a severe uphill battle. It was a battle that the doctors told my mother he would never win, that he would not make it past his first birthday. But my brother was a fighter. He overcame all and lived 39 beautiful years on this earth. He never gave up, and I never gave up on him. Yet somehow, for some reason, last year GTI Independence cut off my brother's budget without any advance notice or warning, just saying his funding had lapsed. A person who is 100% unable to care for himself was told he did not qualify for care. How is that even acceptable? Despite all the stress and confusions it's caused me, I still showed up and cared for my brother, for him every single day because he's my brother. But I was stressed beyond belief. I had finally found a way to purchase my first car last year. We know the cost of vehicle gas and other maintenance is not cheap. So to have my paycheck just a complete cutoff left me struggling to figure out what's next. How was I supposed to attend? How was I supposed to take care of my son? How was I supposed to go grocery store? How was I supposed to pay my bills? How was I going to survive? It's time for the Department of Social Services in the state of Connecticut to look at how they are treating PCAs. We are healthcare providers. Would you treat a nurse this way? We are providing care for thousands in our state that would elsewise be in the bed of our hospitals, nurses' homes, and other facilities, perhaps even your own loved ones. I love my job. I am looking for a new consumer so I can stay in this field and remain a member of the union. But it is important to help preserve the field that we must make sure these vital caregivers are being paid on time properly for their hours and without issues, because otherwise we'll lose these key caregivers that help keep our healthcare system in Connecticut running. Thank you.
Thank you, Ms. Williams, for being brave and sharing your story. Thank you. Joe Goldsmith.
Distinguished members of the committee, thank you for the opportunity for myself and everyone else here to testify this evening. For the record, my name is Joe Goldsmith and I represent Youth Villages, a national nonprofit working across 29 states and Washington, D.C. We partner with states to improve outcomes for children, families, and young adults involved in the child welfare system, in part by training local organizations to deliver evidence-based models we've built on decades of experience. Today, I want to thank you for supporting one of these models, the Transitional Support for Emerging Adults Program, or TSEA. TSEA, funded by DCF, is an intensive, trauma-informed, community-based program that helps young people in foster care transition successfully to adulthood. It takes a holistic and youth-centered approach that supports young people across multiple life domains, including mental and behavioral health needs. I ask that you maintain and even consider expanding funding so all young people in Connecticut's foster care system have access to this proven model. Since launching in 2019, the program has served over 400 young people. Upon exit, 84% are stably housed, 96% are in school or employed, and 93% have avoided legal involvement. Beyond these outcomes, TSCA adapts to whatever young adults identify as most important to them, such as managing physical or mental health needs, navigating complicated public systems and resources, strengthening complex family relationships, developing financial literacy, or parenting if applicable. Earlier today, you heard from 3 program participants, Ariana, Rosie, and Logan, about their experiences participating in the program. I applaud them for sharing. It takes a lot of courage to speak publicly about personal challenges and successes. Their stories highlight the individualized nature of the program. No 2 young people need the same thing. Each of them came into services with different circumstances, goals, and strengths, and the support they received reflected that. Currently, TSCA is delivered by Community Health Resources and Wheeler Health, 2 strong local providers implementing the model with fidelity across about 2/3 of the state. But young people in the remaining regions, including the Fairfield County area, do not have access to this level of support. Expanding the program statewide would give every young person in foster care the same opportunity to thrive. In closing, I do want to highlight that Youth Village's collaboration with states, all with different policy and practice environments, gives us a unique opportunity to learn what drives successful outcomes as we help partner states solve complex challenges and adopt proven approaches, which ultimately lower state spending. We greatly value our current partnership with DCF through TSCA, and we would welcome the chance to explore, with you and with the department, how our broad national experience could contribute even more to Connecticut's goals. I invite you to pull directly from what we have already learned about what works, what doesn't, and what leads to better outcomes for youth and families. Thank you for your time and consideration.
Thank you, Mr. Goldsmith. Next is Latia Maldonado.
Good evening, honorable members of the Appropriation Committee. My name is Latia Maldonado, and I live in Newington. I'm a direct support professional at an intermediate care facility, or ICF, for individuals with intellectual disabilities. I'm here today to urge you to support the governor's proposal for additional funding to our state ICF programs. These programs provide a vital resource for one of the most marginalized communities in our state, and the level of funding they currently receive is dangerously low. For the last 4 years, I've worked at Oak Hill, the state's largest private provider of disability services. I've been in this field for over a decade, but I didn't always do this work. I spent most of my adult life as a chemist. I made good money and had a stable life. I switched careers because I felt a higher calling. I wanted to do something more meaningful and to help people who can't help themselves. I quickly found out that the system Connecticut has built to care for individuals with intellectual disabilities is close to the breaking point. Almost two decades of stagnant funding, starting with the Great Recession, has left us with a care system that's been held together by duct tape and the sheer perseverance of caregivers who love their individuals so much that they're willing to do this work under some of the worst conditions in this state. Underfunding human services has real consequences. When I worked as a chemist, I was able to have just one job and pay all my bills. Now I work 3 jobs, correction, that's 4. I work 4 now. I spend my days at a classroom for the intellectually disabled children, and my evenings at my ICF home. On the weekends, I'm a personal care attendant for a disabled child that formerly was in my classroom. I work 7 days a week. I do not get a break, and even doing that, I'm teetering on the edge I've been homeless. I've lived in my car with my daughter while working full-time. I don't always know how I'm going to pay my bills, and years of doing this has left me exhausted and burned out. The consequences are just as real for the individuals we take care of. Decades ago, they got top-notch care, healthy, home-cooked meals, regular outings into the community, vacations out of state. Staff would stay for years and develop a real bond with them. Now the food is mostly processed. Individuals spend more time in front of a screen than in the community. Vacations are practically unheard of, and we churn through staff at a rate you would not believe. None of this is an accident. It is the result of deliberate choices that have been made by our state over the last 2 decades. Our government has chosen to keep me and my coworkers in poverty. It has chosen to erode the quality of care that the intellectually disabled citizens of our state receive. In this session, you can choose to take a step in the other direction and begin to repair these years of damages. I urge you to support the governor's proposal to increase ICF funding, and thank you for your time.
Thank you, Ms. Maldonado, for sharing your story. Next is Laureen Rubino.
Thank you for having me testify at the Appropriations Committee. I appreciate your time. I am a board-certified general surgeon, the chief of general surgery at Manchester Hospital, and now taken over by Hartford Hospital. I am also in solo practice. I do take Medicaid patients, and I would say 20 to 30% of my practice is taking care of the Medicaid population. Here is where I struggle with the Medicaid rates. At this time, I can only take 20 to 30% of my panel with Medicaid patients because I cannot afford to continue having my staff, which is 8 people, 3 full-time and 5 part-time people. I could not survive in an office without them, and I spend a lot of my time in the operating room, obviously. So I have a hard time maintaining them if I go over that 30% in my office. I would like to offer more accessibility, but I cannot do it because I cannot afford it. I have to pay a payroll. I am in solo practice, so there's no one else to pick up the bills when they come. I feel terrible for the people that come to my office and I can't take care of them. If you look at the rates, which I had my office manager look at today, the Medicaid rates are about a half of what Medicare rates would be, and they are a third of what a commercial insurance company would be. If you bring the Medicaid rates up to the Medicare level, I think we would all be able to see more people and take care of the population in Connecticut. I think that that's pretty much all I can really attest to at this point, but if there's ever anything else that I can give you information about, I would love to provide that. Thank you.
Thank you for your testimony and for what you do. Next is Santina Raganis, and I'm sorry if I mispronounced.
Good evening, members of the Appropriation Committee. My name is Santina Raganis, and I'm a resident of Old Saybrook, Connecticut. I'm here today to testify in opposition to the cut to the Community First Choice program under HB 5032, as the program's elimination is a direct threat to my son's life, his independence, and his future. I'm a mother of a 15-year-old son named Gabriel who has Williams syndrome, a rare genetic disorder, as well as an autism diagnosis. When my son was born, we were given at best a year for survival. He's 15 and he is the sun in my universe. He's doing beautifully today. Every day I have him is a gift. With that being said, his life literally depends on a team of over 18 specialists across 4 hospitals. One of his medications alone exceeds $17,000 a month. Medication alone does not sustain him. Every single day, he relies on Community First Choice to live safely at home, in his own bed, in his own community, surrounded by the family who knows and loves him best. This has been a godsend for us. In 2019, I stood before this body to advocate for my son in opposition to hospital cuts because it was important to us. Today I stand before you again, not as a policy expert or as a budget analyst, but as a mother, advocating for her son, a young man whose stability, health, and dignity depends on these services. This is Gabriel. This is why I fight every day, and I will continue to until I take my last breath. Imagine your child, your whole world relying on a program to safely live at home. Now imagine that program is suddenly gone. As a parent, it is devastating. Community First Choice is not a luxury. It is a difference between independence and institutionalization. It is a lifeline for our family and for many of the families here that you've heard this evening. It is critical to my son's success. It allows Gabriel to receive assistance with daily activities, to participate in school and community life, and to live with dignity. Without it, families like mine have no choice but nursing homes or other institutional settings, not because they are better, but because there are no other options. As a single parent, I carry full responsibility for Gabriel's care and financial stability. His father battled cancer, and since then, I have been solely responsible for ensuring Gabriel is supported both emotionally and financially. Community First Choice makes it possible for me to work full-time, knowing my son is safe and cared for by people I trust and I can hire. If this program is eliminated, our needs for care do not disappear. Cutting it does not reduce need. It will force medically fragile individuals out of their homes and into far more expensive institutional settings. That is unacceptable, not just for my own son, but for countless other families in Connecticut. In summary, I just respectfully request that you please do not balance the budget on the back of people with disabilities. These are the people we should be protecting, not abandoning. Protect Community First Choice. Protect Gabriel, and please protect the ability of families like mine and those that you've heard from today to keep our children at home, safe, supported, and surrounded by love. Thank you for your time and consideration.
Thank you, Ms. Ragonis. Next is Jill Kleiber.
Uh, 131 Jill Kleiber.
I don't see her, so we're going to move on to John Satterfield, please. Are you here, John? Yes, yep, there you are.
Good evening, distinguished members of the Appropriation Committee. My name is John Satterfield. I'm the past president of the Connecticut State Society of Anesthesiologists, and I've been working as an anesthesiologist in Connecticut since 1991. I applaud your efforts to address Connecticut Medicaid rates. The last Medicaid rate increase Connecticut anesthesiologists experienced was in 2006. Because Medicaid rates are determined in association with Medicare rates, it is imperative to understand the long-standing issue anesthesiologists face with Medicare payments. In the process of updating the Medicare payment methodology in 1992, a tragic calculation error was made in regards to our reimbursement. It is now well recognized that anesthesia services are woefully underpaid by Medicare. This Medicare underpayment to anesthesiologists is only compounded by Connecticut Medicaid reimbursement, which is significantly lower than Medicare rates. The Federal Government Accounting Office, the GAO, has confirmed the massive underpayment to anesthesiologists as shown here. physician specialties typically experience Medicare payment rates that are 80% of average commercial rates, 80%. The GAO found that anesthesia payment rates to anesthesiologists from Medicare in 2020 were only 27% of average commercial rates, 27%. This huge underpayment by Medicare to anesthesia departments nationwide does not begin to cover the cost of providing care. In this diagram, you can see the effect of inflation over the last 20 years. There is a Medicare inflation adjustment for hospitals and skilled nursing facilities, but not for physicians. And finally, over the last 10 years, most physician specialties have experienced a 5 to 6% increase in Medicare payments, while anesthesia providers have experienced an 8.5% decrease. In light of all these facts, tying Medicaid reimbursement for Connecticut anesthesiologists to Medicare is flawed. Every Medicaid patient that comes to a hospital in Connecticut and requires surgery receives the care of an anesthesiologist. It is time to address the massive Medicaid underpayment to Connecticut anesthesiologists that the Connecticut anesthesiologists experience. Thank you very much, and I certainly appreciate the fact that both of you are here tonight to hear me in person. Thank you.
It was well worth coming.
Thank you.
So thank you, Dr. Satterfield. Next is Fernando Morales.
Good evening, esteemed members of the Appropriations Committee. My name is Fernando Morales. I'm the Executive Director of Southwestern Area Health Education Center. I'm not really here to talk about my agency. I'm just here to talk about as a community health worker and really the work that I've been involved in for over 20 years. To start off, I am a resident of Manchester, Connecticut, and I am testifying in regards to the HB 5032 bill. As you know, in 2023, Connecticut passed legislation requiring Medicaid reimbursement for CHWs. Obviously, right now, nothing has been done about it yet, but definitely it's something that we hope that we're going to be in line like the other 30 states. As a community health worker for over 20 years, I really understand firsthand the power of being a trusted member of the community. Our work goes beyond referrals. We stabilize lives at critical moments. And if I just may share a small story here, I once assisted a 70-year-old woman diagnosed with HIV who had recently lost her husband to AIDS complications. She was homeless. She was living under a bridge during our Connecticut winters here. The only thing that kept her going, she told me, were her 3 dogs. Shelters would not accept pets, and traditional systems could not meet her complex needs. I secured temporary housing that allowed her dogs, coordinated food support, connected her to medical care, and helped her access benefits. That intervention was not just about housing. It was about survival. Without that support, I firmly believe she really would not be here with us today. This is the role of CHWs. We address the social drivers of health. We prevent crisis and improve health outcomes by building trust and removing barriers. Medicaid reimbursement for CHWs, I think, is not an added cost. It is a strategic investment in prevention, stabilization, and long-term savings. I respectfully urge you to fully fund the implementation of Medicaid reimbursement for our CHWs. This investment will strengthen our health system, support a stable workforce, and improve health outcomes across Connecticut. Thank you so much for your time.
Thank you for sharing, Mr. Morales. Next, we have Lynette Dockery.
She was swapped for Leticia Council.
She's gone.
Lynette went earlier. Leticia's here.
In her place, we have number 23, Leticia Council.
Oh, well, good evening now. Good evening, Senator, Representative, and honorable members of the AC Committee. My name is Leticia Council, and I've been a personal care attendant for 2 decades. In all my years of providing care, I have never felt as forgotten as I do now. The first time I went unpaid, I broke down crying. I was immediately panicked. How was I going to pay my bills, keep my lights? Would I need to borrow money? The last thing I ever wanted was to owe someone, but I feared I would become desperate. My options were quickly limited because it didn't just happen once, it happened multiple times, and it affected many of us. We already live paycheck to paycheck. Our hours are limited to what Medicaid approves, which sometimes mean losing expected hours with little notice. On top of that, not getting paid at all is devastating. You're left constantly wondering what will happen next. Will it happen again? And yet every day I still show up. One of my clients is bedbound and the other one is blind. Without me, they could be left in dangerous situation. My compassion, my heart would not let me stay away. If I don't show up, they may not get out of bed, they may not eat, they might not get their medication. I care too much about them to let my fear of not being paid from doing my job. But the fear is sometimes I live with every day because of how Department of Social Service have handled this crisis. There was zero compassion, zero urgency, and zero real effort to fix the problem when it began. We had filed thousands of grievances. We had to show up at their headquarters twice, and still hundreds of members have not been paid and are still suffering. It's not an old issue. A friend and fellow PCA was just unpaid a few weeks ago, desperate being told over and over that the issue would be fixed. It's not. We are still not getting paid on time. So enough with the lies. Stop saying it will be fixed and actually fix it. It is time for DSS and the state of Connecticut to start valuing healthcare workers. Every single one of us, PCAs are a critical part of healthcare system in the state, yet we are frequently overlooked. We are treated as if we do not matter. The constant feeling of being unvaluable is deeply painful. So today, I don't just urge you, I strongly call on you to increase funding for DSS and make sure the funding is used to address the ongoing payroll failures affecting thousands of people across our state. Our consistent, the very people who voted for you. We are the ones. Thank you.
Thank you for
your time.
testifying and for caring.
Thank you.
Thank you. Next is Denise Davia.
Pretty close.
You can correct me because I'd like to know the correct way.
Dayview.
Dayview.
Yeah, thank you.
Thank
you for being here. Good evening, members of the Appropriations Committee. My name is Denise Dayview. I am the CEO of Lumability, the largest nonprofit birth-to-3 provider in Connecticut, serving approximately 2,000 children across 5 counties. I testified before this committee yesterday and appreciate the opportunity to return this evening as the DSS budget does include funding to increase birth-to-3 rates. It is a welcome progress that after nearly 10 years, there is a rate increase in the FY27 budget. However, the benefit of that increase is offset by 2 proposed changes, a reduction to the General Administrative Payment, or the GAP, and the introduction of a new tiered rate structure. I have spent time in the field with our Birth to 3 staff, including accompanying a therapist for an entire day, more than 10 hours on the road and in family homes. Their office is their car. Their desk is a collection of tote bags and backpacks. Their workday is mapped out around travel routes, brief moments to prepare between visits, quick lunches, and strategically planned bathroom breaks. Over the course of a single day, staff may work with families in vastly different circumstances, from a multi-generational household in a cozy apartment where English is not the primary language, to a family in a large home on the shoreline. Regardless of setting, the approach is similar with respect to the unique culture every family unit has. Shoes come off at the door, and within minutes, staff are on the floor engaging directly with the child and the family. They build trust while remaining attentive to stressors that can affect development, including food and housing insecurity, immigration concerns, or family conflict. When those challenges arise, our staff connect families with critical supports beyond Birth to 3. In some cases, our staff are also drawn into highly sensitive situations, including subpoenas related to custody battles or abuse investigations. These realities are often an unseen part of the job our staff do. There are many moments of joy, weeks of preparation that allow a child who struggles with transitions to succeed on a family vacation. First words, first steps, and the pride of mastering a spoon. There are also moments of deep difficulty, such as telling a parent that their child has autism. That conversation changes the course of a family's life. Birth to 3 staff are not only there in that moment, but in the months and years that follow, helping families navigating an unexpected journey. This work is demanding emotionally and physically. It is not work that everyone can do, and we routinely lose staff to school and clinical settings that offer more predictable schedules, higher pay, and no living out of your car. If we are serious about stabilizing and strengthening Birth to 3, we must support the workforce we already have while making the field attractive to new professionals. The proposed tiered rates work against that goal. It ties payment to a complex, intense, multi-year credentialing process that is unattainable for many and misaligned with the realities of the workforce. Instead of strengthening the system, it introduces new barriers. Equally important, any reduction to the gap directly undermines provider stability. GAP supports the substantial non-billable costs inherent in Birth to 3, documentation, training, travel, and service coordination. Reducing GAP means fewer resources to invest in our staff and ultimately fewer services available to children and families. All the details and data regarding this are in my written submitted testimony. I urge you to preserve the gap at $200 per eligible child and to reject the proposed tiered rate structure. Doing so will ensure that the intended rate increase truly sanctions the Birth to 3 system, which is unraveling, supports the workforce, and protects services for Connecticut's youngest children. I thank you for your time and your service. We really appreciate it.
Thank you for testifying and for the snapshot of what a day looks like.
It
was
is
very
one heck of a day.
helpful.
Thank you.
Thank you. Next is Deidre, and again, I'm with these names, Murch.
So I already went, but Kara is gonna go in my place. I swapped with her.
Oh, okay.
In place for 187, we have number 13, Kara O'Dwyer.
Good evening, honorable members of the Appropriations Committee. My name is Kara O'Dwyer. I have been a personal care attendant for the last 11 years, and I'm here today to ask you to find additional funding for the Department of Social Services because we need to address the crisis happening within DSS, especially when it comes to PCAs being paid properly and on time. You've heard us speak all day about how we've been holding press conferences and protests and screaming from the rooftops that we're not being paid properly. Issues over time that came to a head in October with the changes that DSS decided to make in the CFC program, changed our budgets from an annual budget to a monthly budget. Our consumers lost funding, which means that we lost pay. I'm still missing 5 hours of pay from October. This is unacceptable. People who work should be paid for the time that they've worked. And in any other profession, this would not be acceptable. The Department of Labor would have handled this ages ago. We've been dealing with the same issues for the whole time I've been doing this work. And I love this work. I enjoy helping people who need it. I just 3 weeks ago lost my consumer employer, and that's the legalese name, but really I lost my best friend, a brother. He would be here today testifying as well, because Community First Choice cannot be closed. So many thousands of people depend on that program for their care, and we depend on it for our jobs. I have been homeless as well since October, partly due to payroll issues, because if you're already not paid enough, you don't work enough hours, and you're barely making it by, and then your check is short, things like this happen. So thankfully, I have some loved ones that make it possible for me to usually find a warm place to sleep at night. But if I don't have that, then I sleep in my car. And that's unacceptable for somebody who goes to work every day and gives their best and makes it so that somebody who's vulnerable gets to live an independent, dignified life. The state doesn't seem to care, because I'm not the first one to go through this, and I also won't be the last, unfortunately. And us not being paid properly just shows that we're not meaningful to the state. They tell us that we were over hours. The system shows that there's a green bar and there's plenty of time left and money in the budget. We call, nobody answers. We leave messages, we don't get calls back. We don't get responses to emails. GTI is handling things terribly and DSS isn't able to help. Hopefully more funding would make it so that they can provide the services that are needed. And we already got rid of our last fiscal intermediary, Allied, for the same problems, and we're still just going through it over and over again. And we don't deserve it, and the people we care for don't deserve it either. So we need to stop being treated like third-class citizens in the first-class world. And our state needs to recognize that healthcare workers are essential and fix the system that it has allowed to fail, so that our healthcare system won't continue to collapse around us. Thank you for your time.
First, let me thank you for sharing, and I'm sorry for your loss. Senator Lesser.
No, thank you, Madam Chair. I just wanted to also express my sadness for your loss, and just also my shame for how you've been treated. And it's a lot of heartfelt stories we've heard this afternoon, this evening. We have to do something about it. Thank you very much.
Thank you.
Next is Sana Shah.
Good evening, Representative Garibay, Senator Lesser, and honorable members of the Appropriations Committee. Thank you for the opportunity to testify. My name is Sana Shah. I'm the Director of Policy and Advocacy at the Connecticut Project Action Fund, and I'm here to testify on the governor's proposed budget adjustments for human services with a particular focus on SNAP and Husky. Because of recent federal policy changes, 38,000 people in Connecticut are losing SNAP and 65,000 are at risk of losing Husky coverage. These losses are largely the result of new work reporting requirements, administrative complexity, and paperwork barriers that are disrupting access to benefits. The impact on communities has been devastating. That is why more than 10,000 residents have reached out to the governor, urging him to secure emergency funding to address this crisis, and why hundreds have shown up at the Capitol demanding action. I'm asking this committee to respond to the voices of residents and invest in the creation of a state-run SNAP Transitional Benefit Fund to help bridge these federally created gaps. A SNAP Transitional Benefit Fund would provide temporary state-funded nutrition assistance to people who have lost SNAP or at imminent risk of losing it due to federal work requirement disruptions. This is not a permanent expansion of benefits. It is a time-limited stabilization tool that keeps families fed while eligibility issues are resolved and people are reconnected to federal SNAP. Right now, DSS is being asked to rapidly educate beneficiaries, verify work hours and exemptions, resolve documentation problems, and manage growing churn all at once. When benefits are lost due to delays or paperwork rather than true ineligibility, families experience hunger, and Connecticut loses millions in federal nutrition dollars. A transitional fund gives DSS breathing room. It gives families continuity, and it prevents unnecessary strain on emergency food systems. Under this proposal, benefits would be modest, roughly the average SNAP benefit, about $194 per person per month, and temporary up to 12 months. Eligibility would be limited to people actively working, seeking work, qualifying for exemptions, or awaiting verification. Administration would run through existing DSS systems using EBT, minimizing costs and complexity. We estimate the cost to be $22 to $44 million, and we recommend an initial appropriation of $25 to $35 million, a modest investment compared to the federal dollars preserved and the harm avoided. Additionally, research shows that every dollar invested in SNAP generates about $1.50 in economic activity because SNAP benefits flow quickly through existing systems and are spent in local communities. Connecticut already administers state-funded nutrition assistance when federal policy creates gaps. This proposal builds on that precedent. The SNAP Transitional Benefit Fund is targeted, fiscally responsible, and urgent. It protects food security, maximizes federal dollars, and ensures that families are not pushed into hunger because of red tape. I urge this committee to include a SNAP Transitional Benefit Fund in the budget and to develop a clear plan to protect those at risk of losing HUSI coverage as well. Thank you for your time and consideration.
Thank you, Ms. Shaw. Her first name is Sana, but her last name is Shah.
Oh, please say Miss Shaw.
No, I said Miss Shaw.
We're all good.
Thank you, Mr. Lesser, Rep. Lesser. Next up is Heather Gates.
Good evening. How are you? Let's see which one of these is on. Thank you for being here in person. I appreciate it. I'm Heather Gates, and I'm the president and CEO of Community Health Resources. We're one of Connecticut's largest freestanding providers of mental health and substance use services for all ages. Our mission is to inspire hope for individual and community well-being, and our vision is every life will get better. But we need your help to do that. I want to thank you, first of all, for the appropriation in the budget for the last year, this year, and then next year. We do appreciate that and want to express that, but it is not enough. We need additional help from the Medicaid budget for rate increases for behavioral health, which from our perspective consistently get ignored and discriminated against. I've already included numbers in my testimony that I submitted, but I just want to talk to you a little bit about the reality we experience every day. Access to outpatient services, which is the backbone of the treatment system, remains really problematic. We have 140 to 150 individuals presenting for service at our clinics every week. They come for help with anxiety, depression, thought disorders, substance use, and suicidal thoughts. And they are often in need of services immediately, and if we cannot provide it, they have nowhere to turn. Every week we're able to see about 80 to 85% of those individuals. That means those who cannot be seen have nowhere to go. We're really facing unprecedented uncertainty about federal funding for critical programs right now. Low reimbursement rates compound these efforts and impact our ability to hire and retain qualified clinical staff. We recently experienced the turmoil of all the cancellations from the federal government under SAMHSA that you've heard about. And what it pointed out to me was that these were critical services that the state of Connecticut really should be paying for. In that particular case, one of the contracts that we had canceled was trauma treatment for children in schools. At that point in time, we were serving 400 kids who've experienced trauma. Over the course of the grant, we had served over 1,600. But we shouldn't have to rely on the federal government for really fundamental services that Connecticut can afford and should fund. We're anticipating loss of revenue as HB 1 gets implemented on the federal level. Individuals will lose health insurance. The redetermination process will inevitably result in people losing Medicaid, and that will mean that we lose revenue, individuals lose health care, and can't get access to services. So on top of inadequate Medicaid rates, which contribute to significant financial losses for us, it will be highly problematic. And our outpatient clinics simply can't sustain those losses of that magnitude. So we ask for your help. Again, we need the Medicaid rates to be addressed, and to address them based on the rate study that DSS commissioned. You've heard the data, you've heard us talk about it for the last 2 sessions, and we hope this is the year that that gap can finally be closed. I appreciate your attention and really thank you for the work that you do every day for the state of Connecticut. Thank you.
Thank you. I have one question. What is the trauma treatment? What kind of a program was that you say you lost?
We have clinicians in 30 schools, and those clinicians see children who've been identified as having experienced trauma, and the clinical treatment is evidence-based treatment that we are providing to those kids, and then often their parents as well.
Okay, thank you, and thank you for all that you and CHR do.
Thank you.
Thank you.
Madam Chair, we have our last in-person speaker, number 181, Douglas Kerr.
Thank you.
Good evening, honorable members of the Appropriation Committee. My name is Doug Kerr. I live in Torrington, Connecticut. Thank you for the opportunity to speak on an issue that is still deeply personal to me. I have previously spoken before you February of 2017. I am here once again to testify in support of more monies for children's mental health because nothing has changed. Back then, I asked you to imagine with me. Imagine your son has been diagnosed with schizoaffective disorder and told you that he could not deal with the voices in his head. When he tries to resist the voices, his head begins to hurt, and the more he resists, the greater the pain. He begs, "Dad, God can make these voices go away. Why doesn't he?" Imagine having to tell your son who is pleading for your help, this illness is a condition you will have to cope with all your life. Now imagine your son telling his cellmate, "If God won't make it go away, then I will." Then your worst fears come to light, and you're told your son has attempted to commit suicide. His medication isn't enough, and he tries once more to commit suicide. He fails, but in desperation, he gives in to the voices, and it leads to the authorities having to remove him from human connection for safety reasons. I told you, I don't have to imagine it. I lived it. Mental illness brings about its own destructive results in the lives of loved ones. In 2017, I was anticipating the upcoming release of my son when I last testified before you. However, 10 short months later, in December, I was standing by my son's bedside with my hands on his chest until his heart gave its last beat, because the third time was a successful time. Due to insufficient funds and inept service, my son was failed by the system. I am here again asking the Appropriation Committee, will you fund mental health services for children and teens so that other parents and myself will not have to give the same testimony 9 years from now because funding never came? Please fund mental health services for children and teens. Thank you for your time and consideration.
Thank you, Mr. Kerr, for bringing your voice. And now I'm going to hand over to Representative Jillian Gilchrist, who will take over managing the meeting. Thank you.
Thank you, Representative Garibay. I'm here on Zoom. I am next going to go to number 203, Kevin Alexander.
Madam Chair, he will be arriving shortly. If you would like to pick up the list at number 119, and I will alert you when he comes in.
You got it. All right, so we're going to go to 119, which is Ursula Mooreshead.
Yep. Hi.
Hi, go right ahead.
Okay, thank you. So good evening, honorable members of the Appropriations Committee. My name is Ursula Mooreshead, and I live in Waterford. I'm an advanced clinical social worker with DCF in Norwich. I'm also an elected member of the representative town meeting for District 1 in Waterford and a delegate for 1199. I'm here today to urge you to increase the funding you provide to DCF in the budget. I've been here before. I gave testimony for the last 2 years about our issues, and not one thing has changed. We work with community and in-home programs that are meant to keep children safe in their homes. However, these programs have a 4 to 6 month wait list, increasing the risk of harm as they wait. We work with parents who cannot or will not take their children home from inpatient psychiatric hospitals because they do not have the services that are being recommended upon discharge. As a result, the children are stuck sitting in hospitals beyond what is clinically appropriate. Our foster care system is failing. The level of denial within the system regarding where some children are laying their heads at night is beyond my understanding. Children need structure, nurturing, and they need to feel safe. Instead, they are left without hope and are feeling forgotten. Caseloads for clinicians are unmanageable, and there is no limit to the number of cases that we can be assigned. Typically, we are assigned to no less than 80 cases. We stay assigned to these cases throughout the life of it, which can sometimes be for years. There are not enough clinicians to handle that demand. We've asked the state multiple times for more clinicians to be hired, and we're told there is no evidence to support this need. We then ask if our weekly work hours could be extended from 37.5 to 40 so we can appropriately handle the growing workloads. This request has been repeatedly denied by the state. By not having enough clinical coverage, we are providing a disservice to these children and their families. I urge you to approve the necessary funding for DCF in your budget to either hire the additional staff or increase our work hours so that we can better help the children and families of Connecticut. Thank you.
Thank you, Ursula, for your testimony and for your work.
Thank you.
Next, we will go to number 120, Cecilia Livingston.
Good evening, Chairs Austin, Walker, and ranking members. My name is Cecilia Livingston, and I'm the Senior Director of Operations here at A&B Home Care Solutions. We are a motive care service. I'd like to thank you and members of the committee for taking the time to hear testimony all day today. And I want to focus on the critical need for sustainable funding in Connecticut's home care programs. Home care is also referred to as personal care services and plays a vital role in the healthcare continuum. It allows individuals who need help with daily activities to live safely and independently at home while preventing avoidable hospital and nursing facility admissions. Our A and B caregivers work with your constituents every day to ensure that they're able to successfully live independently, helping families to observe changes that may identify potential health issues before they become acute, improving the quality of their lives, and helping to avoid costly facility-based care. Over the past year, I've had the opportunity to speak to several of you and your colleagues about the importance of this particular service in Husky Health Program. As the state navigates its ongoing funding challenges, I want to reiterate the message that I've shared in the past. Non-medical personal care services represent a patient-centered, cost-effective approach to keep people healthy and supported at home, avoid unnecessary use of emergency departments, and prevent the need for more costly facility-based care settings, such as long-term acute care hospitals and nursing facilities. Public data shows that homemaker services in an individual's home average less than $6,500 a month, compared to the more than $15,000 per month for nursing home care. That's a difference of over $100,000 per year per individual. The demand for personal care services has clearly outpaced our ability to meet the need. Despite recent rate increases tied to minimum wage adjustments, reimbursement has nowhere near kept pace with the need for competitive wages and increasing administrative costs. As a result, we're losing caregivers to private industry for less grueling work, other healthcare settings, and neighboring states that reimburse at higher rates. One caregiver commuted from New Haven to New York City to work at a higher wage, covering her own travel costs. All of Connecticut's neighboring states are reimbursing these services at a higher rate, and we are losing caregivers, not just A and B home care, but all personal care providers in the state. The need for sustainable home care funding is critically urgent. We had to release an individual who suffered from ALS because we could not hire and maintain the caregivers required to meet their care needs. Without increased reimbursement, we will see continued workforce loss, reduced access to cost-effective home care, and increased institutional care costs for the state. I thank you so much for your time this evening.
Thank you, Cecilia, for your time and for your testimony. We're now going to go back to number 203, who has arrived. Kevin Alexander, go right ahead.
I'm sorry, please push the button.
Thank you. Hello. My name is Kevin Alexander. I am a PCA from West Hartford, Connecticut. Good evening. I was drawn to providing care for people after seeing how often society fails people with disabilities, something that became painfully clear to me after the killing of Jordan Neely on a New York City subway. This was not the career I originally imagined for myself, but when a friend of my mother asked if I could help care for her son, it felt like a meaningful way to give back to our community and provide support for the people who need it most. The challenge is that we do not have adequate health care, transportation costs, or retirement. Even making this work sustainable has been difficult, especially when I've gone unpaid for certain hours that I've already worked. GTI fails to notify us when we are not paid for hours that we worked and implemented, even if there's an error. They won't let us know. They will just bypass it and move on. It's up to us then to spend our time fixing the problem. It's work that's unpaid. What is the point of having a payroll company that cannot alert you when there is a problem or respond when you ask for help? Not being paid also makes it harder for us to provide care for our consumers. I provide transportation to the store for errands, to social activities, which is extremely important. I work with a client who has autism, and keeping him active in the community really helps his socialization and his maturity levels get a lot better from that. I've seen him grow a ton since I've been working with him the last 2 years. He also wants to give back to the community, so he has set up a food bank pickup that we do every Tuesday morning, where we go to the grocery store, the post office, community center in East Granby, and pick up food that people have left in our boxes there and delivering them to the food bank in the church. So we would like transportation costs to be provided by the state. We're covering the state's cost by providing this transportation to doctor's appointments. When caregivers are not paid properly, it just harms them. It just harms the workers. It also harms the people who rely on us every day. It is time for the state of Connecticut Department of Social Services to reevaluate how caregivers are treated, especially when it comes to our pay. We need a payroll company that can actually manage the needs of the PCA workforce and communicate with workers in a timely and reliable way. The state should also seriously consider mileage reimbursement for PCAs. We transport our consumers to medical appointments, essential errands, and community activities, saving the state the cost of transportation services, yet we pay those costs out of our own pockets. This is not sustainable for our workforce. It is time for personal care attendants to be paid in full and valued for the essential work we do, and look to move away from using GT independence and pay for it and provide the payroll from our state. Thank you for your time.
Thank you. Thank you for your testimony and your time tonight. Next, we are going to go to number 122, Elaine Balsley.
Hi, thank you. Good evening, Representative Gilchrist and members of the Appropriation Committee. My name is Elaine Balsley, and I'm the Director of Reach Out, a Birth to 3 agency based in Hamden. I am on the Birth to 3 Interagency Coordinating Council, assisting and advising our lead agency in how changes made to Birth to 3 will affect our ability to continue to provide quality services to families. I am testifying in support of HB 5032. We do appreciate the increase in funding given to Birth to 3 in the 2025 legislative session, and are pleased that the governor added additional monies. I would like to thank you for your time over these last 2 days and for listening to all of us. One of the data points that the ICC has been tracking is the amount of services provided to children. You've heard my colleagues tonight a few times about the reduction in services, so I will not repeat that. But it is a direct result of workforce limitations, specifically the lack of ability to retain and recruit because of our inability to offer competitive rates and benefits. If, as a Birth to 3 employer, I cannot find a physical therapist or speech language pathologist that will accept my less than ideal offer, then I don't have those services to give the family. There is consensus within all of the 17 Birth to 3 program that the tiered rate of reimbursement should be rejected. We currently have a tiered rate that's based on level of education and licensure, as well as tiered rates that adjust the rate based on the time in the home. The proposed credential is not the issue. Tying it to rates is the issue. With all due respect to OEC and Birth to 3, providers on the ground are the ones searching for and interviewing potential employees. We are keenly aware of what is needed to support retention and hiring, and the consensus is amongst providers that the tiered structure is not that. The governor's budget would add a little over 10 million in FY27. Although it is definitely appreciated and needed, it's much less than what was determined needed based on a data from 2 years ago. 2 years ago, the recommended amount was between 21 and 41 million across FY24 and 25. Appropriating more money is the right thing to do for families. But as you know, Birth to 3 has a direct financial impact on every town in this state. National studies show 42% of children who receive Birth to 3 services do not need special education services by kindergarten. And with this committee's knowledge of special education costs, It's clear that the investment up front will save town and state dollars now, as well as for years to come. Again, thank you so much for all of your time over these last couple of days.
Thank you so much. Thank you for being here and for your testimony and the work you do. Next, we're going to hear from number 123, Carrie Lick.
Hello. Good evening, senators, representatives, and members of the Appropriations Committee. My name is Carrie Lickey. I am a licensed clinical social worker and program manager of outpatient services at Child and Family Agency of Southeastern Connecticut, which includes the Pawcatuck Mental Health Clinic. I'm here today to respectfully ask that you restore the $250,000 fiscal year 27 funding dollars for our Pawcatuck Clinic. Funding that was included in the governor's original 2-year proposal and later removed prior to final budget adoption. We are deeply grateful that fiscal year 26 funding was restored through the advocacy and community partners and legislators, specifically Representative Baumgardner, Representative Howard, and Senator Sumbers, for their unfailing support of the mental health care for their constituents and who understand how essential these services are. That action allowed us to continue serving the vulnerable children and families within that community without disruption. However, the pattern of proposing funding, eliminating it without notice, and requiring providers and communities to fight for restoration creates instability in a system that depends on consistency and trust. Mental health treatment cannot operate in uncertainty. Children experiencing trauma, depression, anxiety, and behavioral health crises cannot put their needs on hold while budget decisions shift. Additionally, the uncertainty impacts the ability to sustain qualified, evidence-based clinicians. Since opening in January 2023, the Pawcatuck Clinic has delivered over 9,757 therapy and psychiatric sessions to children, adolescents, and adults. In the Pawcatuck region, few providers within a 25 to 30-minute drive offer the comprehensive services we provide, which include evidence-based treatment for children as young as 3, psychiatric evaluation and medication management, individual, family, and group therapy, evening appointments for working families, acceptance of Husky and major insurance plans, and no wait list. When access to care disappears, families do not simply find another option. They face long wait lists, travel significant distances, or seek help in emergency rooms. Symptoms escalate, schools and caregivers absorb the impact. Over time, the human and financial costs to the state grow substantially. We are not asking for new funding. We are asking you to restore the second year of funding that was already identified as necessary in the original biannual proposal. Please consider this not as a line item, but as a lifeline. Behind each of those individuals we have served is a child struggling with anxiety, a teenager battling depression, a parent trying to stabilize their family, real people whose progress depends on continued access to care. We respectfully urge you to restore the $250,000 fiscal year 27 funding and provide the stability that Connecticut's children and families deserve. Thank you for your time, your leadership, and continued commitment to our state's mental health system. Thank you.
Thank you so much. Thank you for being here and for your testimony. Next, we will hear from 126, Sonia Hernandez.
Hi, good afternoon, Representative Gilchrist and members of the Appropriation Committee. My name is Sonia. I am a mother of 3 wonderful kids. I am a friend, neighbor in Bridgeport, Connecticut. I am also a community organizer at Make the Road, Connecticut. I stand with HB 5032. Health Justice Now. and also I am testifying on the governor proposal adjusted budget for 2027. I want our governor and our legislators to invest in the health cover options for all state residents, like losing their health insurance because the federal changes, with affecting all our community. I am here today to ensure our community are covered and protected from the costs that are increasing. Our community cannot afford to pay or prevent medical debt. As a community organizer, I met daily with parents concerned about their health, medical bills, worry about bringing their kids to the doctor or getting sick. I heard many stories and saw stress and heartbreaking. Some families got health covered, others don't have, and some will be losing what they have. As a group organization, we work with undocumented Black, Brown, and working class community. Our community is always looking for help and support. Our community health workers around Connecticut are a trusted messenger who help residents as a first mental health support. They are listening to all their issues, what they're going through. Their help navigating health systems, crossing benefits, sharing resources, and many other needs. As a mother and wife, we have private insurance, but the monthly rate based on the program is too high, and the basic programs doesn't cover all what we need for our families. The copays, primary care, emergency medication do not reduce stress and they not cover all the access that we need. The cost of living has been higher, so our families are struggling to keep what they need to have in daily life. And increasing the rates of cost of healthcare is we cannot afford. I want our governors and our legislators to push on our shoes. Think about your kids, grandkids, parents, or your families. One of them gets sick. You don't have insurance. You cannot afford to pay. Will you do an emergency? Yes, you can take it to the emergency at the hospital. But what about if they get diagnosed with any chronic conditions or other issues? You can get out from the emergency room. But what is next? You cannot afford to continue with the health care that you need to treat what you have and losing your work, not going to work, you will lose your work, you will lose your home, and not going to be able to pay for food for you can recovery. You will end on the street. Think about that. Just thinking of what or imagine what can happen, erase your heart. You feel frustrated, you feel fear, you feel your heart breaking. So this is what we're feeling all our residents in Connecticut now for all the crises that happen on health. Our state is wealthy. We have money to care health crisis. It is inevitable and it's urgent that we take action to use the state funding program to cover and protect our residents covered. We can increase Medicaid reimbursement rates. We need funding to community health workers. We want you to ensure all Connecticut residents have access to quality, affordable health care. Thank you and God bless you.
Thank you so much. Thanks for being here and for your testimony.
Thank you.
Next, we will hear from 127, Eileen Healy.
Good evening, esteemed appropriation members. My name is Eileen Healy, and I live in Woodbury. I'm the Executive Director of Independence Northwest in Naugatuck, one of Connecticut's independent living centers. I urge you to increase funding for the centers by $1 million, which is an increase of $200,000 per center annually. Independent living centers are frequently confused with assisted living or some other type of congregate housing. We are disability resource and advocacy centers. We are non-residential and we serve people with all types of disabilities and of all ages. Our only eligibility criteria is having a disability. We promote and teach self-advocacy and self-reliance. We employ qualified people with disabilities who share our experiences and our paths to independence, offering practical guidance because we have lived it. Every year for the last 37 years, I've come before this committee to advocate for funding for the centers. And despite some small increases, we are still 35% behind inflation, The previous year's cuts have never been fully restored, and our costs keep increasing. We are working at more than capacity. We cut back on the towns we serve and created waiting lists. People in rural areas don't have the same access to independent living services. Without additional funds for the centers, people with disabilities, including elders, will be at risk of costly nursing facility placement, and many won't achieve their goals for independence and community living. Centers provide state-funded services, and if Connecticut continues to value us, as Commissioner Porter stated this morning, the state also needs to adequately fund us. Finally, we strongly oppose eliminating CFC. Many speakers have testified about their experiences on CFC and that it's saving the state money because, in general, CFC costs are far less, than institutional care. But this isn't just about money. It's about people with disabilities having the option to live in our homes, in our communities, where we can control when and how we receive the services we need. We are parents, employers, employees, neighbors, friends, coworkers, and taxpayers. We are the people we all know and care about. Very few of us want to spend our days and potentially the end of our lives in nursing facilities. By eliminating CFC, the state is sending the message that people with disabilities aren't valued community members and aren't entitled to live independently in the community. Connecticut's fiscal health is strong. Please support an increase of $1 million or more for the centers so we have the capacity to meet the ever-increasing demand. And please do not eliminate CFC. Thank you all for your attention and consideration.
Thank you so much for your testimony. Thank you for being here. Next, we'll go to 128, Janet Stolfi-Alfano.
Good evening, Representative Gilchrist and members of the Appropriations Committee. I'm Janet Stolfi-Alfano, Chief Executive Officer of the Diaper Bank of Connecticut. I appreciate the opportunity to testify before you in order to increase support for and access to diapers for infants and toddlers. We're asking for an increase of $1 million to support Diaper Connections, which is a one-of-a-kind collaboration with the Connecticut Hospital Association and Connecticut's acute care hospitals to increase access for diapers for families with young children. Diaper Connections screens for diaper need in hospitals and leverages those local community partnerships to distribute diapers in settings like labor and delivery units, maternity and pediatric clinics, emergency departments, and primary care sites. Beyond providing diapers, Diaper Connections is advancing coordinated statewide action to improve maternal and child health. We've been doing this work at the Diaper Bank of Connecticut for over the past 20 years, having distributed over 56 million diapers to Connecticut children since we started. And while we're a well-established leader and one of the largest diaper banks in the country, we're only meeting a fraction of the true need in our state, serving about 6,000 children, infants and toddlers each month. But the need is closer to almost 70,000 infants and toddlers under age 3. The affordability crisis is a lived reality for so many families in Connecticut, especially for those with young children. And we heard today from so many people, the very people who are dedicating their lives to caring for us, who serve us, service staff, childcare professionals, caregivers, who are increasingly struggling to make ends meet. They're the essential workers who compassion connects families to services, including needed medical care, but when they return home, they face the quiet, relentless pressure of budgeting for basic necessities. For those with infants and toddlers, one of those most critical and least supported necessities is diapers. That's why Diaper Connections is so important. It's not just a charitable initiative, it's really this point of critical support in our community's infrastructure. And in collaboration with the Hospital Association and the hospitals, we're directly addressing the economic strain on Connecticut families, including its essential workers and the families that they serve. By connecting those most in need, again, including those caregivers, many of whom we heard from today, with a supply of diapers, this program acknowledges a profound truth that we cannot expect our frontline heroes, our workers, to care for our community if we are not supporting them and their families. Supporting Diaper Connections is an investment in the health of our state and the stability of our essential workforce and the futures of Connecticut and its youngest residents. Thank you so much for your time and your attention and your support over the years of our efforts.
Thank you. Thank you, Janet. Good to see you, and thank you for your testimony and the work.
Thank you.
Next, we'll go to number 129, Benil St. Jean.
Good evening, Representative Gilchrist, members of the Appropriation Committee. My name is Benil St. Jean. I am a registered nurse and a community nurse coordinator with the Department of Social Services. I'm here to urge you to increase funding for DSS to address our growing service backlog. As community nurse coordinators, we oversee 10 waiver programs and CFC. Our mission is to ensure state and federal compliance, determine appropriate level of care, and most importantly, help individuals remain safely in their homes. However, we are currently operating with only 9 nurses to serve approximately 45,000 clients. The demand simply exceeds our capacity. In my role, I oversee the personal care attendant waiver program. The waiting list for a slot to be allotted is now 3 years long. While that is an improvement from 5 years, it is still unacceptable for individuals who needs essential life-sustaining care. I am currently the only nurse actively managing and reducing pending and wait-listed cases, while also operating a hotline that requires callback within 48 hours, often fielding up to 20 calls a day. At the same time, our staffing levels have declined due to retirements and resignations, and those positions have not been replaced. Plain and simple, we do not have enough nurses to meet the need. Qualified individuals are waiting months, years for care, and during that time, their health declines, preventable crises occur. Without increased funding to recruit and retain staff, this backlog will continue to grow and vulnerable residents will continue to suffer. Thank you for your time and consideration.
Thank you so much. Thank you for your testimony and for being here this evening. Next, we'll go to 131, Jill Kleiber.
Hi, good evening, Representative Gilchrist, representatives, senators, and everyone here on the Appropriations Committee. Thank you so much for allowing me this opportunity. I'm Dr. Jill Kleiber. I'm a licensed acupuncturist and a doctor of acupuncture who has practiced in the state of Connecticut since 2008. I am the owner of West Hartford and Avon Acupuncture. I sit on the board of the Connecticut Society of Acupuncturists as the treasurer. I'm also the founder of Access Acupuncture, a nonprofit 501c3 to provide affordable care to uninsured and underinsured residents. I'm here today respectfully to support a sustained increase in Medicaid reimbursement rates, like so many fellow testifiers that I heard this evening. Specifically, I'd like to ask that licensed acupuncturists be included in those adjustments. As we've heard a lot about tonight, Connecticut ranks near the bottom nationally in Medicaid reimbursement compared to Medicare rates for non-primary care services. Meanwhile, my operating costs as a business owner have risen significantly, especially in the last 5 years. Payroll, rent, supplies, utilities, insurance, and reimbursement, we know, we're hearing, has not kept pace. At my clinic, approximately 30% of our daily patients are Husky members. I'm very fiercely committed to serving them, and so is everyone that I work with. It's just becoming a lot harder to afford running a business that can hire people and administrators to support this community with these rates. And it's becoming more difficult to attract providers and to sustain ourselves. The value of acupuncture is measurable. We treat chronic pain, we treat mobility limitations, stress-related conditions. I've seen Husky patients arrive with walkers and in a couple months be going upstairs. The second floor of my office is not accessible in West Hartford, but I've seen some really amazing breakthroughs for people, and that's what brings us joy, and that's why we do what we do. Oregon's Medicaid program also includes acupuncture, and they did a study and found that roughly 50% of participants stopped using opioids after 18 months of acupuncture and other services. So our services decrease opioid use. They also decrease the need for surgeries, injections, and labs and imaging at times. Investing in fair reimbursement for acupuncture is not about supporting just our profession at all. It's about finding cost-effective, evidence-based care that reduces reliance on more expensive interventions like long-term medication and surgery, as I mentioned. And I'd just like to respectfully ask that the committee include licensed acupuncturists in this year's Medicaid rate adjustments. Thank you so much for your time. I know you're all tired. Thank you for what you do. Have a good evening.
Thank you so much, and thank you for what you do and for your testimony. Next, we'll hear from 132, Gabriel Gambardella.
Good evening, Representative Gilchrist and members of the Appropriations Committee. My name is Gabe Gambardella. I'm a podiatrist and foot and ankle surgeon in Connecticut. I currently practice in the Hartford area. I serve as the legislative chair for the Connecticut Podiatric Medical Association. I'd like to offer some brief comments regarding House Bill 5032 and the issue with Medicaid reimbursements. Low reimbursements currently discourage provider participation and make it difficult for patients to receive care. I believe it's 80 to 90 cents that are reimbursed to a doctor for each $1 of care that's provided or spent on providing that care. Phasing in increased payments so they at least equal the cost of providing care is a reasonable first step. For example, Medicaid reimburses $32.39 for a patient visit, while Medicare reimburses $114.32, which is an enormous disparity. This impacts patients significantly. Many of my patients have, for example, diabetes, and many of them will have or will eventually have an issue as it relates to their foot, such as a diabetic foot ulcer. This can ultimately lead to infection and need for continued care or surgery and potentially an amputation. Based on the diabetes.org website, there are almost 300,000 patients with diabetes in Connecticut and 16,000 new diagnoses of diabetes each year in Connecticut. Direct medical expenses is about $3.5 billion and indirect costs is about $1.1 billion from lost production. Based on the American Diabetes Association website, 40% of patients with diabetic foot ulcers will require an amputation, and following a foot amputation, the 5-year survival rate is about 40%. A study by the American Limb Preservation Society looked at diabetic foot wounds from 2010 to 2019, and it was concluded that insurance has a profound impact on health outcomes. When patients transition from Medicaid to a private insurance, there is a 27% lower risk of major amputation compared to those who are not on Medicaid. Based on the ct.gov website, the number of patients with diabetes who have Medicaid is significantly higher than their counterparts with other insurances. And the result is that vulnerable patients have limited access to care, and because of this, many of them are receiving either no care or delayed care, and this puts them at risk for limb loss. I'm currently in a small practice in Bloomfield, and while I don't turn away any patients because they have Medicaid or based on any insurances, I assure you that there are many private medical practices in Connecticut who will not see patients with Medicaid because it's simply not sustainable due to low reimbursements. It's becoming more and more expensive to run a practice and provide care, and we unfortunately simply cannot fill our days with patients who have Medicaid for obvious financial reasons and the costs that come along with running a practice. I know your committee has been a steadfast supporter of updating Medicaid reimbursements, and I hope that you continue to devote new funds to do so in the fiscal year 2027-2026 budget. Thank you for your time and considering the views of the Connecticut Podiatric Medical Association.
Thank you. Thank you so much, Gabriel, for being here tonight and for your advocacy.
Thank you.
I see next 135. I don't think I'm missing anyone, so I'm going to go to 135, Catherine Strout.
Hi, can you hear me?
Yes, go right ahead.
Good evening, esteemed members of the Appropriations Committee. My name is Catherine Stroud and I live in Ledyard, Connecticut. I am a member of the Connecticut Council on Developmental Disabilities, but I am here today as a parent of an adult son with a developmental disability who utilizes Community First Choice. I am testifying in opposition to the elimination of Community First Choice. My son is eligible for the autism waiver, but has been on the waiting list since 2018. They are currently servicing people from 2014. It is estimated that his name won't be called until approximately 2036, 10 more years. We are on CFC because we are in need of personal care assistance for adaptive life skills, social skills, and emotional regulation. He is not independent. This home and community-based program has allowed our family to provide scaffolding for my son to inch forward on all these skills, and he currently is able to attend college and is working toward a bachelor's degree, something that would not have been possible without CFC. With this scaffolding, we are confident that he will be able to become a productive member of society, obtaining employment and getting off Medicaid, which would be a benefit for the state. Without CFC, he would need a residential home institution should my husband and I pass away suddenly. We don't have family to support him. It is estimated that almost half of the individuals getting serviced by CFC are already on a DDS Medicaid waiver. Instead of throwing the baby out with the bathwater, why wouldn't it make sense to only serve people who either don't qualify for any other waiver or they do, but the waiting list makes it so it will be a decade before getting serviced? DDS only services individuals with intellectual disabilities. Those services are all encompassing, from day programs to equine therapy. Everyone else gets nothing. How about we start there? How about hire a professional team of individuals who fix programs like this full time and save this very vital program instead of eliminating it? I don't see how it can be true that people won't lose their benefits. My son is on an extensive waiting list. He won't get serviced. Are you committing to funding all waiting lists? If not, are you suggesting that someone like my son will jump the waiting list line? What about those people who have been waiting? The budget mentions perhaps creating a new waiver. How long will that take? And what happens to people who are thrown off their services in the meantime? What about the people in dire need of services that don't fit a waiver or are on a huge waiting list? These future people, what about those people? They get nothing while you create a new waiver sometime in the future? CFC has been a very successful program that provides a unique service for our population. The fact that you can't find a way to fix this very vital program is beyond concerning. I respectfully request that you create an oversight committee to figure out what went wrong here. This is not acceptable. Thank you for allowing me to testify.
Thank you, Catherine. Thank you for your testimony and for being here this evening.
Thank you.
Again, I don't think I'm jumping anyone. The next I see is 140, Sarah Parker McKiernan.
I think we have 139 first.
Oh, I'm so sorry. I'm a little late. Sorry, Sarah. Give me 1 second. Let's go to 139. My apologies. I do see you. Zandali Rodriguez.
Hello. I got it written down. Give me 1 second. I'm nervous.
Take your time. You've got this.
Good afternoon, chairpersons, ranking members, and members of the Appropriation Committee. My name is Zandali Rodriguez, and I live in Meriden, Connecticut. I'm a mother, and everything I do is to make sure my children are fed healthy and safe. Like many working families, I do my best every single day to provide stability to my kids. Well, for my kids. But programs like SNAP and Husky are what help fill the gaps when life gets hard. I'm here because the governor's proposed budget adjustments to DSS will directly affect me and my family. And I want to make sure this committee hears from the people these decisions impact the most. SNAP and Husky are about respecting our families and protecting our health. Nobody should have to choose between feeding their children and keeping them healthy. I'm asking this committee to ensure that the 38,000 people losing SNAP and the 65,000 people at risk for losing Husky are protected from federal benefit cuts with the state's investments that bridge the gap. Without SNAP, I would struggle to keep groceries in my home consistently. Without Husky, I would worry about how to afford doctor visits, prescriptions, and emergencies. These programs give family like mine stability and peace of mind. while we work toward a better future. I'm asking this committee to invest in a state-fund traditional benefit system to protect people who are losing SNAP now and tomorrow, and for the state to make a plan to protect people who are at risk for losing Huskies. We need a budget that protects working class families. Thank you for your time.
Thank you, and you did fantastic. Thank you for your testimony.
Thank you. You're welcome.
Now we will go to 140. Sorry about that. Sarah, go right ahead.
Thank you. Good evening, distinguished members of the Appropriations Committee. Thank you for the opportunity to testify regarding the governor's proposed budget adjustments. This testimony addresses the absence of a viable long-term state response for those experiencing food insecurity due to the federal H.R. 1 cuts to SNAP. My name is Sarah Parker McKernan, and I am a legislative policy advocate for Connecticut's legal services programs, which include New Haven Legal Assistance, Greater Hartford Legal Aid, and Connecticut Legal Services. The legal services programs provide free legal services to low-income individuals in civil matters throughout the state. We are asking you to establish a state-funded food assistance program for those no longer eligible for SNAP because of the changes in H.R. 1. The SNAP program provides valuable economic support for Connecticut residents trying to feed their families. 1 in 7 Connecticut residents are food insecure. SNAP participants receive an average of $191 a month. 36,000 Connecticut residents are now at risk of losing SNAP because of the changes in federal H.R. 1. H.R. 1 limits eligibility and imposes strict work requirements on SNAP recipients, limiting them to 3 months of benefits in a 3-year period if unable to comply. These changes are particularly harsh for the following individuals who were previously eligible for work exemptions, and that includes those between the ages of 55 and 64, caretakers of children between the ages of 14 to 18, veterans, homeless individuals, foster children between the ages of 18 to 24 who are aging out of care, approximately 43,000 Connecticut residents in 68 towns who live in areas of high unemployment and were previously eligible for exemptions, refugees, asylum seekers, victims of human trafficking or domestic violence, Afghani or Iraqi special immigrants. All of them will lose their SNAP eligibility. Connecticut should not be relying on emergency food to address the H.R. 1 cuts. Connecticut can bridge the gap imposed by H.R. 1 by creating the state-funded program. That program should mirror SNAP eligibility requirements that were there prior to H.R. 1. Emergency food, which is our system of food banks and pantries, is intended for emergencies, not consistent daily access to food. It does not account for those with limited physical or transportation access to those services, limited access to the hours they are open, or the lack of choice they offer, particularly for those with special dietary needs. Thanks for the opportunity to talk to you tonight. And I have actually submitted testimony, and along with the testimony, I've also submitted a fact sheet that has all of this information on it as well. Thank you, and thanks for your attention to this matter.
Thank you. Thank you, Sarah, so much for your testimony and for being here.
Sure.
Next, we're going to hear from 146, Tracy Wodach.
Thank you very much, Representative Gilchrist. Distinguished members of the Appropriations Committee, my name is Tracy Wodach, President and CEO of the Connecticut Association for Healthcare at Home. I'm also a registered nurse with over 40 years of experience. Our association represents Connecticut's licensed home health and hospice agencies, as well as Homemaker Companion. Collectively, our members provide critical care and support services that allow Connecticut residents to remain safely at home, the setting they overwhelmingly prefer and the setting that is far more cost-effective for the state. Connecticut's Medicaid reimbursement rates for home and community-based services are no longer sustainable. As you've heard from so many before me, not just community providers, Medicaid rates have not kept pace with inflation or the real cost of delivering care. In fact, when adjusted for inflation, Medicaid rates for home health are now 51% below the 2011 levels. Yet, other than ARPA funding and minimum wage adjustments for low-wage workers, we have only received a 1% increase way back in 2014. The impact is already being felt across the state. Providers are struggling to recruit and retain caregivers. Agencies are turning away Medicaid referrals, and access to services is shrinking. This situation has been made even worse by the wage increases for personal care assistants in the self-directed sector, which raised wages to $23 an hour this January. Homemaker companion agencies want to compete, but the Medicaid reimbursement rates simply do not allow them to pay comparable wages and still cover the cost of operating safely and legally. And those PCAs in self-directed deserve the rates that they're being paid. At the same time, agencies are being burdened with costly unfunded mandates. The result is predictable: fewer caregivers, fewer Medicaid clients served, and growing instability in the provider network. And when people cannot get care at home, they end up in nursing homes or hospitals at significantly greater cost to the state. We're asking you to take meaningful steps this session to stabilize home and community-based care by increasing Medicaid rates for both home health and homemaker companion services. Our specific requests are well outlined in my written testimony that I did submit. These are not enhancements. They are long overdue corrections. I also want to raise serious concern about the governor's proposal to sunset Community First Choice, CFC, and transition participants to waiver programs. Our agencies are committed to serving these individuals, but without rate reform, the provider system does not have the staffing capacity to absorb that transition. And the existing waiver waitlist is already evidence of unmet need, as well as far too long waitlists. In closing, Medicaid-funded home care services keep people safe and well cared for at home. They reduce hospitalizations, delay nursing facility placement, and save taxpayer dollars. But without adequate reimbursement, agencies will be forced to scale back further or close, and access to state-funded care will collapse. We urge the Appropriations Committee to invest in Medicaid home and community-based services now, before the crisis becomes irreversible. Thank you very much.
Thank you, Tracy. Thank you so much for your testimony and for your continued advocacy.
Thank you.
Next, we're going back to 144, Todd Johnston.
Good evening, Appropriation Committee. My name is Todd Johnston. I'm a T4 paraplegic who uses a power wheelchair. I am single and I own a home in Portland, Connecticut. When leaving a hospital stay, my discharge nurse signed me up for the PCA waiver and Community First Choice. I was contacted by the PCA waiver program about a week later and was told there was a 4-year wait list. I was contacted by Community First Choice about a month after leaving the hospital. It took 6 months to coordinate to get on CFC and then have my current PCA set up to work with me. I've been on Community First Choice for about 3 years now. Through Community First Choice, I've been able to have my home modified to have a sure hand ceiling lift installed. The lift provides me safe transferring between my power wheelchair and my hospital bed and my shower wheelchair. Community First Choice also provides me with a personal emergency response system. Over the past 3 years, I've had to use this system a few times. A couple of times while walking my dog and my wheelchair failed, and one time when I got stuck in my bathroom in my shower wheelchair. With CFC, I have had a PCA assist me with dressing, shopping, grooming, health maintenance, laundry, housework, errands, meal preparation, and attending doctor's appointments. CFC has provided me with what I need to be able to work part-time for the North Central Area Agency on Aging as a choices counselor. Today, I'm happy to say I do not have any medical problems due to the assistance of my PCA. My PCA has helped me in the past with tending to bed sores and a scrape on my foot from getting seriously infected. I believe the support I received through the CFC program and my PCA has made it so I can be as independent as possible and contribute to the community in whole. If the average cost of CFC is $64,000, how does that compare to a year in a nursing home? I'm very concerned also that if other waiver programs have to absorb CFC consumers, what will happen to all those waiver programs' wait lists? Thank you very much.
Thank you so much. Thank you for being here and for your testimony.
You're
Now we will go to, oh, did 147, nope, there you are, 147, Kathleen on Satalino. Go right ahead.
Catalina, thank you so much, Representative Gilchrist. Good evening, members of the Appropriations Committee. Thank you all for listening to our testimony and holding down the fort on this late night. We really appreciate you hearing us. My name is Kathleen Satalino. I am a proud mother of a birth to 3 graduate and also a director at Creative Interventions, which is a birth to 3 agency that provides services to over 600 families in Connecticut. I'd like to thank, we are appreciative of the recent increase for birth to 3. But I'm here to say that it's really insufficient, and the program continues to need more funding. I've submitted written testimony, and you can see that. So I'd like to put some of my testimony into context and share a little bit about my personal experience with birth to 3. Our twin children were born at 5 weeks premature and placed in the NICU for 2 weeks, and were pretty fragile. My daughter was about 4 pounds. My son was about 5 pounds. That's pretty small. Shortly after birth, my daughter was diagnosed with torticollis, which is a tightening in the neck muscle, and that made things really hard for her to nurse and feed and gain weight. We tried every bottle on the market. We were up late nights feeding her in front of a wide open fridge to help her feed and thrive. But everything that we did, it was really, really challenging. So, and please remember too, she also had a twin brother that we were caring for at the same time. With the help of our Birth to 3 team, we were able to learn different techniques, stretches, ways to help her be able to feed, and she avoided a diagnosis of failure to thrive, which was our goal. We did not want to have to put her back on a tube, and we were able to avoid that procedure. We are a success story, and we were able to discharge from birth to 3. We did not need any additional intervention, no therapeutic intervention, no outpatient services. We were able to manage this condition and treat it with the help of our Birth to 3 team. And she now gets to go to daycare and she has a successful life. She even eats better than most toddlers. She eats all of her greens first. It's pretty great. But again, this program, the Birth to 3 program, is imperative. I'm one family, right? And our agency provides services to 600 families. That's just a drop in the bucket, my story. So as a provider, I want to continue to advocate for Birth to 3 and the funding for Birth to 3. The budget, as it's written right now, includes added tiers, which were not part of the cost study. And that's really difficult for agencies like mine to continue with financially. As part of the staff development team, I have seen growing increases in training requirements. None of those are reimbursed by the state. And what's very important to me and our agency and all agencies in Connecticut is that we're able to provide very quality services and retain and recruit quality providers with limitations in funding, where that is becoming harder and harder. So I really fear that, that could be a risk, and there's a risk in losing services for families. So again, I really support that we continue to hold the gap payment, eliminate the reduction in the gap payment, and reconsider the new tiered reimbursement structure. Thank you, everyone, for your time and for listening.
Thank you so much. Thank you so much for your testimony, for being here tonight. Next, I am going to go to 151, I believe. Julia Rosenberg, go right ahead.
Thank you so much, Representative Gilchrist, and good evening, chairs and members of the Appropriations Committee. My name is Dr. Julia Rosenberg. I'm a pediatrician practicing in New Haven, a member of the Connecticut American Academy of Pediatrics, and a lifelong Connecticut resident. I am co-director of a refugee and immigrant clinic, where I have the honor to care for all who walk through our doors. Thank you for the opportunity to testify in support of maintaining and preserving Husky coverage, including for all children and pregnant individuals, regardless of documentation status, as well as Connecticut's support for SNAP and community health workers as part of HB 5032. We are in the midst of crises that are testing our values, but I am proud to be practicing pediatrician in a city, community, and state that often shines brightly in dark times. Connecticut legislators and leaders have made great, brave strides to center access to essential human rights, including health care and nutrition. It is because of Connecticut's leadership that I now have the opportunity to care for children who otherwise would not have stepped foot in our office. Like a 10-year-old boy whose severe asthma is finally under control so he can stay in school and out of the hospital. All of these opportunities to support children are only made possible because of Connecticut's brave steps forward. We need you now more than ever to uphold these strides in health. First, preserve Husky for all income-eligible children 15 and under and pregnant individuals. Second, while the federal government has proposed to essentially strip documentation status for more neighbors by eliminating Husky and SNAP for people with protected statuses like refugee or asylees, Connecticut must ensure state infrastructure keeps our documented neighbors from losing their health care and nutrition. Finally, we have the ability to preserve this infrastructure while also increasing Medicaid reimbursement rates and supplying funding to community health workers. Over the past few years, there have been over 2,000 testimonies submitted in support of Husky for all, regardless of documentation status, and many more this session. As a pediatrician, I can reiterate the evidence that thousands of our neighbors understand. Health suffers without insurance coverage. Compared with uninsured peers, insured children avoid risky behaviors, do better in school, and have better health as adults, with fewer costly and painful chronic conditions. As a pediatrician, I worry and care for families I see, but I worry even more about the ones that I do not see. The relationship built from consistent, reliable care can reduce unnecessary and expensive emergency room visits, hospitalizations, and preventable illnesses. Preserving healthcare coverage makes sense for individual health, financial health, public health, but most importantly, healthcare is a human right. Keep us proud in Connecticut. Protect Husky eligibility for all income-eligible kids with prenatal and postpartum coverage. Create a plan to protect all Connecticut residents at risk of losing their healthcare coverage and nutrition support, and increase Medicaid reimbursement. Thank you so much for your time and your leadership.
Thank you, Julia. Thank you for being here and for your testimony. Next, we will go to 159, Bree Senka.
Good evening, members of the Appropriation Committee. My name is Bree Senka, and I am the Vice President of Behavioral Health at Alara Caring. I'm an RN with over 24 years experience, most of which have been in home health in the state of Connecticut. Alara Caring is the largest provider of behavioral home health services in Connecticut, serving over 4,000 Medicaid-funded individuals in their homes, all of whom suffer from severe and persistent mental illness. We serve most of Connecticut, but have a large concentration of patients in New Haven, Hartford, Bridgeport, and Waterbury. Although billed as medication administration, the Medicaid service our nurses provide at Alara Caring is a highly specialized behavioral health care delivered by experienced psychiatric nurses to patients with severe high acuity diagnoses. Despite ongoing state investments in behavioral health, this critical service has largely been excluded from meaningful rate increases, receiving only a 0.5% adjustment, far below what's needed to remain sustainable. This rate was cut by 15% in 2016 and has never been restored. We respectfully urge the state to reinstate the 2016 rate so we can consider serving some of Connecticut's most vulnerable residents safely and effectively. Equally concerning is the continued use of the subsequent visit rate penalty, which actively discourages clinically appropriate necessary care. This policy is counterproductive, short-sighted, and directly undermines patient outcomes and should be eliminated. To illustrate the real-life consequences of the subsequent visit rate, one of our behavioral health nurses recently cared for 2 Medicaid patients with serious mental illness who lived in the same home, both requiring skilled medication administration and close monitoring to remain stable. During a scheduled visit, the nurse cared for and administered medications to the first patient, assessed them, provided equally complex necessary care to the second, including assessing mental status, identifying early signs of decompensation, and intervening before symptoms escalated to a psychiatric crisis. That second encounter required the same level of clinical time, judgment, and risk as the first, yet Medicaid reimburses it as a reduced subsequent visit rate, solely because the patient shared the same living space. This policy ignores clinical reality, devalues skilled nursing judgment, and penalizes providers for delivering efficient, coordinated care, even though these visits prevent emergency department use, psychiatric hospitalizations, and far more costly institutional placement. Broadly, recent federal budget and policy changes have only further exposed what home health providers have known for years. Connecticut's Medicaid home care system is critically underfunded and no longer sustainable at the current rates. Without decisive action to adequately fund Medicaid home care, essential in-home services for high acuity mentally ill individuals is at risk. The result is entirely predictable. Avoidable hospitalizations, unnecessary nursing facility placements, increased strains on emergency rooms, and significantly higher costs to the state, all outcomes that run counter to both fiscal responsibility and patient preference. We urge you to support funding in the budget to restore the medication administration to 2016 levels and eliminate the subsequent visit rate for behavioral health services at home. Thank you so much. Appreciate it.
Thank you so much. Thank you for your testimony and for being here tonight. Next, we'll hear from 160, Sheldon Tubman.
Good evening, Representative Gilchrist, other members of the committee. My name is Sheldon Taubman. I'm an attorney with Disability Rights Connecticut. We're the protection and advocacy system for Connecticut, serving individuals with a full range of disabilities. I'm here to testify about the impact on people with disabilities of one of the cuts in the governor's proposed budget, as well as the impact of the failure of his budget to address ongoing eligibility discrimination, specifically against individuals with severe disabilities in our Medicaid program. First, the big cut is to Community First Choice, which we've already heard a lot about. I think it's important to recognize you can't be on the program unless DSS itself determines you would otherwise be in a nursing home at state expense. In a 2020 report, DSS, it's cited in my written testimony, explained that venerable services like the Connecticut Home Care Program for Elders, Medicaid waiver programs, and Community First Choice have made a huge difference in the lives of older adults and younger adults with disabilities. The state long-term care plan that's currently operative identifies CFC as a critical component in the effort to rebalance away from nursing homes. But to justify the about face and eliminate the program entirely, state officials have made claims that they will somehow take care of everyone on the program by transferring them to one of the waivers, so they won't lose anything. This is just not credible. You already know about the very long waiting list for the waivers. But even if we came up with the money for these people, what about the people already waiting on the waiting list for years? And what about the fact that there are many people on CFC who are not eligible for any of the waivers? And that the waivers are capped at the cost of nursing home care, or maybe 125% of that. That's what the commissioner said this morning when she mentioned that with waivers, we could control costs. That means we can cap people, which means many people will lose services and they will no longer be able to be in the community. We heard from Joy Minervini today, who's getting 24-hour care. She will have to go into a nursing home. And finally, when they explain that they'll take care of people, they say only the current people. What about all the future people? somebody who's a brain injury away, a car accident away. Those people will not have the choice. They will not be able to get a waiver or CFC, and it will cost more on average. Yes, this morning the commissioner said it's $64,000 is the average cost of these care plans under CFC. According to DSS, the average cost of nursing home care for the state is $92,676. So this is an unwise policy just from a fiscal point of view. I think that we should be honest that part of this, it seems to be motivated by the problems with GTI, but rather than fixing those things, which needs to be addressed, we heard all the testimony for people not getting paid in a timely way. You don't throw the baby out with the bathwater, you fix the basic problem. Don't throw out the program. Now, the last thing I wanted to mention is the discrimination against people with disabilities in Husky C, who have a much lower income limit. It's indefensible. It's $1,397 a month. All other adults have income limits of $1,800 a month, and they have no asset limits. Only Husky C has an asset limit. So it's time to address this. We've actually brought a lawsuit about it, but we don't need to wait years for the litigation to resolve itself. We should do the right thing. The governor hasn't, but this committee can, and finally treat people with disabilities the same as all other adults. Thank you very much for staying so late. Appreciate it.
Thank you, Sheldon. Thank you for your testimony and for your continued advocacy. Next, we will go on, I believe, to number 163. Just move. There you are. Judy Sherman, go right ahead.
Hello, everyone. My name's Judy Sherman, and I'm the Consumer Services Advocate with Disabilities Network of Eastern Connecticut. We are one of 5 independent living centers in Connecticut. DNEC serves individuals in Windham and New London counties, as well as part of Tallinn County. In my role, I work with people of all ages who live with a wide range of disabilities, supporting them in maintaining their independence and full participation within their communities. Sorry. This year, we're respectfully asking or requesting a $1 million increase to our overall budget. While this figure may initially seem substantial, it reflects the very real impact of rising living costs and the continued reduction of programs that are vital to individuals with disabilities. In comparison to the growing and urgent needs of our community members, this request is both reasonable and necessary. Over the past year, we've experienced a significant rise in calls from individuals who are struggling to afford basic necessities such as rent, utilities, and essential vehicle repairs. Many of the people we serve live on fixed incomes. When an unexpected expense arises, they are often forced to make a heartbreaking choice between paying for medication or food and keeping their housing secure, maintaining utilities, or obtaining critical accessibility equipment such as ramps and stair lifts. During these moments of crisis, they turn to their local center for independent living. One of our core responsibilities is to assist individuals in securing funding and resources that allow them to remain safely in their homes and communities. However, without additional funding, our capacity to respond effectively to these urgent needs remains limited. The individuals we serve represent some of our most vulnerable residents. They deserve stability, dignity, and reassurance that support is available when unforeseen challenges arise. Adequate funding ensures that people with disabilities can avoid unnecessary institutionalization and instead continue living independently, surrounded by their families, neighbors, and support systems. Thank you for your time and for your continued commitment to the disability community.
Thank you so much, Judy. Thank you for your continued commitment. Really appreciate it. Next, we will go to 165, Andrea Swenson.
Can you hear me?
Yes, we can. Go right ahead.
Good evening, representatives, senators, and members of the Appropriations Committee. My name is Andrea Swenson, and I'm the Senior Director of Behavioral Health for Catholic Charities, Archdiocese of Hartford. Catholic Charities is a nonprofit human services agency which employs nearly 400 professionals and provides services to over 11,500 individuals and families each year without regard to race, religion, or economic circumstances. I would like to thank you for the Medicaid rate increases effective January 1st, 2026, and to request that you increase funding for vital nonprofit programs in fiscal year 27. Catholic Charities maintains 4 behavioral health clinics located in Hartford, New Haven, Waterbury, and Torrington, which provide behavioral health care to over 3,000 adults and children annually. Approximately 90% of the people we care for are on Medicaid. I want to describe what underfunding looks like in practice. When Medicaid reimbursement does not reflect the true cost of care, nonprofit agencies are forced to build budgets around billable time and productivity targets. Clinicians carry larger than ideal caseloads. Clients are seen less frequently than is clinically recommended. Positions go unfilled because the budget cannot sustain competitive salaries. Graduate students train in our clinics, then leave for private practice or hospital systems where reimbursement allows for financial stability. Turnover becomes structural, not occasional. And unfortunately, this structure creates predictable outcomes. Consider this scenario. Client A reaches out reporting depression and passive suicidal ideation. The agency has a 4 to 6 week wait list because funding does not support enough clinician positions. Before the intake appointment arrives, that client is hospitalized following a suicide attempt. We pay for crisis because we did not fund access. Or think of client B, who requires significant case management alongside therapy. Under current reimbursement rates, agencies struggle to sustain dedicated case management roles. The clinician attempts to manage therapy, care coordination, documentation, and crisis response while meeting elevated productivity requirements. Sessions shorten, burnout rises, appointments are canceled. Care becomes fragmented, not because of indifference, but because the appropriate funding is not in place. Client C begins to stabilize in recovery from substance use disorder with the support of a peer recovery specialist. That role, difficult to sustain under current Medicaid rates, is eliminated. Without that consistent connection, relapse follows. These are not isolated stories. They are the inevitable outcomes of underfunded reimbursement rates. Increasing Medicaid reimbursement is not about expanding services beyond reason. It is about stabilizing what already exists. When outpatient care is accessible and consistent, hospitalizations decrease. When clinicians are retained, outcomes improve. When peer and case management roles are funded, relapse and crisis are prevented. I urge you to consider increasing funding for nonprofit programs by $155 million in fiscal year 27, which includes fully funding Medicaid rate increases for behavioral health services as recommended by the state's rate study. Thank you for your time and consideration.
Thank you so much. Thank you for your testimony and for being here tonight. Truly appreciate it. Next, we'll go to 166, Julie Booth.
Thank you. To the members of the Appropriations Committee, thank you for the opportunity to speak with you tonight. My name is Julie Booth, and I'm a physical therapist and serve as the director of the Center for Interprofessional Healthcare Education at Quinnipiac University in Hamden. I'm here tonight to ask you for your support on a vital initiative, the design, development, and piloting of an AI-based soft skills training application specifically for dementia care. This project is intended to directly enhance the quality of life for Connecticut residents living with dementia and provide essential support to their caregivers, both professional and those who are home-based. Quinnipiac University, in partnership with East Hartford-based VRSIM Inc., is requesting $250,000 in state appropriations for 2027. As leaders in healthcare education, we at Quinnipiac recognize the profound challenges faced by families and professional caregivers supporting those living with dementia. This is not simply a matter of medical knowledge, it's a crisis of emotional and communication strain. Caregivers are often faced with intense stress leading to burnout, which compromises their own well-being and the consistency of care. Our current caregiver education system excels at teaching procedural and medical tasks, but falls short in providing realistic, safe environments to practice crucial soft skills such as empathy, patience, and compassionate de-escalation techniques. These techniques are so critically important because dementia fundamentally alters how individuals process language and emotion. These deficits directly contribute to the lower quality of care and diminish the dignity and comfort of individuals living with the disease. We are proposing to close this critical gap through development of an AI-powered simulation application. This program will leverage VR-Sim's nearly 25 years of experience in immersive learning technology, Quinnipiac's deep expertise in holistic patient care in all the health professions, including nursing and medicine, and support Connecticut's broader initiatives of practical AI applications. The simulation will allow caregivers to engage in lifelike, guided conversations with virtual patients, exhibiting a wide range of dementia-related behaviors. This application will provide immersive practice, analyze and assess users' performance, and deliver personalized coaching for improving communication skills. The experience will be designed to give caregivers, be they family members or professionals, emotional resilience, insight to behavioral triggers, and master evidence-based communication techniques that foster true compassion and understanding. If successful, we intend to position this initiative for widespread adaptation across Connecticut in community centers, healthcare training facilities, and family caregiver networks. Quinnipiac University and VR-Sim are ready to launch this partnership and create a compassionate, informed, and resilient caregiver community through the power of AI-driven learning. Again, thank you to the members of the Appropriations Committee for your time and allowing for me to speak tonight.
Thank you, Julie. Truly appreciate you being here and your testimony.
Thank you.
Next, we are going to go to 169, I believe, Eleni Kaloidis.
Yes, hello. I'm a graduate student, graduate social work student at Harvard University and a consumer of personal care assistant services through the Community First Choice program. As a 29-year-old woman who is completely paralyzed from the neck down, uses a ventilator, relies on a feeding tube to eat, and requires round-the-clock complex medical care, the Community First Choice program is my lifeline. I have a motor neuron disease that paralyzes all voluntary muscles throughout the body. This program is the sole reason I can engage in life. My condition renders me unable to complete any physical tasks such as moving, eating, and effectively breathing, but I live independently through round-the-clock nursing-level care provided through a special exemption that only Community First Choice can provide. House Bill number 5032 will have a devastating impact by placing lives at risk. A person like me requires medical care that standard PCA rates do not compensate for. Community First Choice is the only program that allows requesting a budget exemption above the nursing home cost limit, approving an individualized budget to hire nurses as PCAs. It lets me hire skilled professionals, including licensed nurses. This has been life-changing. Home care agencies do not provide an equivalent service. They only offer nurses on a per diem basis, making care completely inconsistent. Legislation for home care nursing restricts you to being homebound. Nurses cannot drive the individual in their vehicle, require family members to stay home consistently, revoke services if you leave home too much, and prohibit nurses from providing personal care like showering or brushing your hair or teeth, or daily living activities like cooking. Private nursing agencies cannot fill the serious threat for individuals with high-level medical needs who also need to live independently. I spent many years severely understaffed and abused by these agencies. As soon as I was approved for Community First Choice and granted a special exemption to offer higher rates and measure it with a registered nurse, my life completely changed. I can now hire skilled candidates, attend Columbia University, and work as a crisis counselor on a suicide hotline. Without this program, I can no longer work, live a meaningful life, or even get out of bed. Because no other program allows you to hire nurses directly, and home care agencies cannot provide a single worker who can perform both personal and medical care. There is an unrecognized gap in services, and the waiver program that I will be transitioned to will eliminate my ability to maintain this budget exemption and keep my team of skilled PCAs. And as Sheldon said before, none of the waivers cover 24-hour care, so I will have no option to remain in the community. As the DSS commissioner testified, the average cost of CFC plan for an average participant is $64,000 per year, which is substantially less than the average nursing home cost, which, according to DSS, is $92,676 per year, resulting in a savings of $28,676 per participant if you keep the Community First Choice program. I urge you to oppose House Bill number 5032 and save the Community First Choice program. Thank you.
Thank you. Thank you so much for being here and for your testimony. Truly very helpful. Thank you. Next, we will hear from, number 170, Andrew Bate. Go right ahead.
Thank you all for the opportunity to provide testimony on the governor's budget adjustments for human services agencies in fiscal year 2027. I'm here in order to speak about Community First Choice. Earlier this morning, I heard Andrea Barton-Reeves, the SS Commissioner, indicate that the average care plan under Community First Choice costs an average of $64,000 to the state. According to data from Connecticut Legal Services, the average cost for a nursing home was about $92,000 per resident in 2024. The governor appears to make no provision for new individuals needing CFC services. These individuals and those for whom there is not a slot on an existing waiver or on the governor's rather vague new waiver will most certainly end up in nursing homes. I say this both as a person with a disability and former social worker. There was a time when people like me were told that the only way that they could live on their own was in a nursing home. Make no mistake, if the governor sunsets CSC, we're headed right back to the time when people with disabilities will be given this message again at higher cost to the state. I can, as a former nursing home resident, albeit for rehabilitation, say that when one is in a nursing home, your life comes to a complete stop and your quality of life goes down drastically. Even in the best of nursing facilities, your life is not your own. When or what you eat, or even when you get out of bed, it's all dictated by institutional policies and routine. With the aid of CFC and similar programs, choices are mine to make. So CFC is cheaper, and people get and people get to live the life they choose. CFC seems like the right and cheaper choice to me. Thank you.
Thank you, Andrew. Thank you for being here and for your testimony. Truly appreciate it.
Sure.
Next is 171, Michael Lung.
Good evening. I'm Michael Lung out of Southbury, and I'm the Vice President of Operations for both Companions and Homemakers out of Farmington and Companions Forever out of Newington. I've been an employee of Companions and Homemakers for over 15 years. My two companies currently provide non-medical home care for a total of 840 older adults throughout all of Connecticut. The care provided to 99% of these individuals is paid for by Medicaid waiver programs. Our business focuses on those who are most in need of assistance with daily living and who depend on these programs. While many of our competitors have been forced to limit assisting federal and state funded programs due to inadequate reimbursement rates, we have taken the opposite approach up until this point. The truth is that we are now forced to consider cutting back on Medicaid funded services due to increased operating costs and the ever increasing difficulties in recruiting quality caregivers. Outside of working in this industry, I also witness my own loved ones and employees feeling the impact of Connecticut's Medicaid rates. One of my schedulers speaks daily of her struggles with caring for her mother, who now lives with her. The scheduler has repeatedly requested live-in care for her mother, Christine, who, due to her advancing dementia and continual hospitalizations. Her requests always receive the same response: the much-needed services are not in the budget. She is often in tears as she is forced to decide between coming to work and handling her mother's needs. Connecticut is actively forcing providers to withdraw from participation in the Medicaid waiver programs against their own wishes. This must stop. Past increases in Medicaid reimbursement rates have been reactive and for the bare minimum. What we need is a sufficient, systematic approach that providers and caregivers can depend on annually. The specific rate increases requested are fully detailed in my written testimony. The alternative is companies such as mine closing their doors and thousands of clients going without the care they depend on. The success of home-based services has been proven time and again. It is time for the state's Medicaid rates to accurately reflect the importance of this service and match the quality of care we are expected to provide. Thank you for your time and support.
Thank you so much. Thanks for the work you do and for being here tonight. All right. Next, we're going to hear, I believe, oh, no, we do have 172, Reverend Josh Pollock. Go right ahead.
Hi, good evening, everyone, and thank you for the opportunity to testify tonight. I'm Josh Pollock. I live in Glastonbury. I serve as the minister of the Unitarian Universalist Society East in Manchester. I'm a leader with the Greater Hartford Interfaith Action Alliance and with the Connecticut for All Coalition. I've been a supporter of the Husky for Immigrants campaign since its inception. So like so many people, I'm talking about HB 5032 and focusing specifically on Department of Social Services, which administers Husky. And I want to begin just by naming the widespread and excruciating uncertainty and anxiety in communities across the state in relation to Medicaid funding. I think you've been hearing it all day long. The cuts specified in the federal government's H.R. 1 have already begun. On January 1st, approximately 5,000 legal permanent residents lost access to premium tax credits on the exchange, making them ineligible for covered Connecticut program. And more cuts are looming. Asylees, refugees, parolees, victims of domestic violence and human trafficking, and certain Afghan and Iraqi immigrants are slated to lose Medicaid eligibility on October 1st. And as many as 200,000 Husky D members may lose coverage due to new work reporting requirements. As a pastor, my heart breaks for people and families who are facing these times without access to quality, affordable health care. These losses destabilize families, they destabilize communities, schools, and workplaces. And as a prophet who believes firmly that healthcare is a human right, I find the HR1 healthcare cuts to be not only capricious and cruel, not only economically short-sighted given the long-term cost they will impose on all of us, but grossly immoral and unjust. So I am saddened about that. I am angry, and I'm here tonight because I sincerely hope Connecticut can stand in this widening healthcare breach. So I know you all have been getting praise all day long for the ways you've already started to address these issues, and I want to add my voice to that praise. And then I have three very simple requests. First, in the very least, let's continue to fund Husky for children under 15 and pregnant people regardless of immigration status. That program is a remarkable success, and it would be wrong to back away from the commitments we've made. Second, let's leverage that Husky infrastructure to secure coverage for qualifying Connecticut residents at risk of losing their coverage due to HR1 cuts. And finally, I urge you to increase Medicaid reimbursement rates and fund community healthcare workers precisely so that all Husky recipients can have better access to care. I offer these requests as ways to respond to the anxiety and uncertainty that is out there, as well as to the short-sightedness and cruelty of the HR1 cuts. We have the resources and the capacity to stand in the healthcare breach. Let's shore up our current safety net programs, sustain the achievements of recent years, and ensure that all Connecticut residents continue to have access to quality, affordable healthcare. Thank you so much.
Thank you so much. Thanks for all your advocacy and for being here tonight. Next, we'll go to number 173, Christina Gillooly. Did I say that right?
Okay. Good evening, distinguished members of the Appropriations Committee. My name is Christina Gihuli, and I am a birth-to-three provider with Limmobility. Limmobility is the largest nonprofit birth-to-three provider in the state. Thank you for the opportunity to testify today. I am here to speak to the urgent need for increased funding to support Connecticut's birth-to-three program. The governor's recommendation to increase birth-to-three funding by $6.2 million for FY27, along with $4.5 million for DSS, represents meaningful progress towards addressing longstanding funding gaps. However, these steps alone are not sufficient to ensure the long-term sustainability of the program. I have witnessed firsthand the significant turnover and difficulty with recruitment among finding providers, often driven by the pursuit of better opportunities, which typically means more consistent and higher compensation. Recruitment remains difficult when programs are unable to offer salaries that reflect market value. Experienced and well-trained providers may be discouraged from entering or remaining in the birth-to-three system when reimbursement rates are tied to a tiered structure in which even the highest tiers fall below the levels identified in the state-sanctioned rate study, which is years old and not adjusted for inflation for today's market. Without a meaningful and sustained investment in reimbursement rates, the workforce shortage will persist and families will continue to face barriers to accessing these services that their children need during the most critical developmental window. The birth-to-three system cannot hold a wait list and must accept referrals and eligible children even if programs are closing, which they have, and providers are hard to find. IDEA requires that these children be served timely and programs are held to these standards. As a result, access to critical early intervention services become limited. We know that timely access to these services leads to stronger outcomes for children and families, and the ripple effects of delayed and inconsistent care are far-reaching. By fully funding birth-to-three, there are better outcomes for children and families. According to a longitudinal study, 42% of children receiving Part C did not need special education services by kindergarten. This shows improved early development, better long-term health, and less severe disabilities in adulthood. This equates to lower education costs and healthcare costs, and many potential other widespread savings can be possible too. I strongly recommend that this investment not be tied to the newly proposed tiered reimbursement structure. As designed, the tiered model will not support workforce recruitment or program stability, and it risks further undermining provider capacity. Failure to act will have a cascading impact on families and on our workforce and the broader economy and on Connecticut's long-term well-being. Thank you for your time tonight.
Thank you. Thank you so much for your testimony and for being here. Next, we will go to 176, Sandra Ferreira Molina.
Good evening, Representative Gilchrist and members of the Appropriations Committee. My name is Sandra Ferreira Molina, and I represent the Connecticut Oral Health Initiative. I'm here today because oral health is foundational to our ability to function as human beings. We often take it for granted, but a healthy mouth and teeth are what allow every one of us in this hearing to speak. Our voice is how we advocate for ourselves, how we interview for a job, and how we connect with our families. When we neglect oral health, we aren't just neglecting teeth, we are silencing our neighbors. I'm here to ask that you fix the periodontal trap. Right now, the $1,000 Husky annual cap forces patients into a lose-lose choice. Periodontal disease is a serious infection linked to heart disease and diabetes, to name a few. When a patient seeks the treatment needed to save their teeth, they often exhaust their entire limit in a single visit, leaving them with no coverage for emergency later in the year. Removing periodontal care from this cap prevents a manageable infection today from becoming a taxpayer-funded emergency room visit tomorrow. Access to care also requires a trusted bridge. This is why community health workers are essential. They are the primary point of contact for people who would otherwise never seek care. They personally refer patients to obtain care, ensuring that a person doesn't just have coverage, but actually obtains the care. To ensure state dollars are used effectively, we must fund the people in our communities that are actually trusted. I also ask for your support of the $100,000 line item in the governor's budget to fund specialized dental anesthesiologists for the Department of Developmental Disabilities. This funding allows patients with disabilities to receive care in a clinical setting rather than a hospital OR. It is more compassionate, more dignified, and far more cost-effective for the state. I also stand here for our veterans. Through Kohai's Salute to Smiles program, funded by Denta Dental, we provide free care to veterans falling through the gaps. But a nonprofit cannot solve this alone. I urge the committee to support a veteran dental pilot program so those who serve our country aren't left to suffer in silence. Finally, I have one last ask regarding accountability. In 2022, this legislature passed the dental loan reimbursement program. It was recognized as a priority then, yet the line item remains at zero. We must follow through. We cannot expect providers to work in our most undeserved areas if we don't fund the incentives we promise them. Furthermore, we must ensure Medicaid rates reflect the actual modern cost of care. A Husky card is only a paper promise if a patient can't find a dentist who can't afford to keep their doors open. Oral health is essential to our ability to work, to learn, and to speak. I ask that you ensure our state's budget reflects the reality that you cannot have a healthy body without a healthy mouth. Thank you for your time and for your commitment to the health of every Connecticut resident. Thank you.
Thank you so much. Thanks for your advocacy and for being here.
Thank you. Have a good night.
You too. Next, we'll hear from 177, Jennifer Cole.
Hi, good evening. Good evening, Representative Gilchrist and members of the Appropriation Committee. My name is Jenny Cole, and I'm the project manager at the Diaper Bank of Connecticut. Thank you so much for the opportunity to testify this evening. I'm here to urge you to support increased funding for Diaper Connections. This is a program that the Diaper Bank has partnered with the Connecticut Hospital Association for, in which we screen for diaper need in hospitals, work with local community partnerships to distribute diapers in all sorts of settings, including labor and delivery units, maternity and pediatric clinics, emergency departments, and primary care settings. More than just providing the diapers, Diaper Connection brings together partners across the state to better support parents, babies, and families during some of the most critical moments. We say this every year, but we truly believe that a diaper is not just a diaper. It's a basic need, and the inability for a family to afford an adequate supply of diapers has rippling effects, including health outcomes, economic outcomes, and educational outcomes. In order to save some time at this hour, I would just ask you to go ahead and check out my testimony or my written testimony with some more specifics around that. But in my position at the Diaper Bank, I've had the privilege to work with a wide network of community members, and often in these conversations, it gets brought up. These questions, are diapers covered under WIC or SNAP? And the answer, while many are surprised at that, is that they're not. And honestly, there are very few programs for families who struggle to afford diapers, even though we know that they are so critical to the health and well-being of both the child and the family as a whole. So Diaper Connections meets families where they're at and ensures that they receive the support that they need. The program allows us to better serve families by reducing barriers to access, strengthening partnerships with community providers, and delivering essential resources directly to those who need them in spaces where they are. And as my colleague earlier mentioned, we are one of the largest diaper banks in the nation, but we're still only serving a very small percentage of the need across the state. The need really exceeds our capacity, our current capacity, and we cannot meet this alone. With the state's investment, we can expand our reach, strengthen our partnerships, and ensure that more families have consistent access to essential supplies that are needed to keep their child dry, happy, and healthy. Again, we really appreciate everyone on this call's support for the work that we've done over the past years. And thank you so much for being here so late. Thank you.
Thank you, Jenny. Thanks for your advocacy and the work you do. Next, we will hear from 179, Bright Johnson. Oh, no, sorry. Sorry, Bright. Give me 1 second. I did skip. 178, Maria Pineda.
Hi, buenas noches. Gracias por estar allí para escuchar nuestro testimonio. Mi nombre es María Adela, tengo 52 años, vivo en la ciudad de Hartford y soy miembro activo del colectivo de defensa. Tengo 3 hijos, unas gemelas de 13 años y un hijo varón de 21 años. Ellos no nacieron en este país. Actualmente mis gemelas tienen cobertura Husky. Mi hijo y yo y mi esposo estamos a punto de perder nuestro seguro médico, ya que dependíamos de nuestro estatus del TPS. Estamos esperando aún respuestas de gobierno de esta administración a nuestra situación migratoria del TPS. El año pasado, en el mes de octubre, tuve un chequeo médico donde fui yo sometida a una endoscopia y me detectaron un nódulo en el esófago. El nódulo no es maligno, pero sí necesito un seguimiento médico donde voy a requerir tanto medicamento como algunos exámenes, los cuales son costosos para nuestro pago si no tengo esa cobertura. Pero necesito ese seguimiento. Este proceso es costoso para nuestra familia para pagar, no teniendo un seguro. También mi esposo tiene programada actualmente una cirugía ambulatoria por una obstrucción de venas en sus piernas. Y no teniendo un seguro médico, esto también sería igual costoso para nuestra familia, en nuestro caso, de pagar. Todas estas costos médicos serían impagables para nuestra familia. Para mi familia y para cualquier otra familia inmigrantes, es importante y es necesario que nuestros niños mantengan la cobertura de salud Husky. Por eso estoy aquí queriendo y pidiendo un apoyo para que nuestras voces sean escuchadas, pidiendo que apoyen a mantener el beneficio de salud Husky para toda la comunidad y la población inmigrante. No se nos quite el Husky. Gracias.
Thank you so much. Thank you for being here and for your testimony. I'm going to quickly turn it over to the clerk. Sorry, Bright, 1 more second.
Good evening. We have a few folks online who've been having some technical difficulties, so we would like to try and give them the opportunity to speak. So first I have Jim Mafoyd. I apologize if I mispronounced that name. So I'm going to unmute you and try and give you the opportunity to speak. I already did. Jim. Okay, we'll come back to Jim. And then the next person.
He probably needs to unmute himself.
is Andre Holly, number 175. Andre?
Good evening. Can everybody hear me?
Yes, sir. You have 3 minutes for your
All right.
testimony.
And thank you for the opportunity to share my experience with the Connection Supportive Housing and Families Program. My name is Andre Holly. Following an extended program of incarceration, I faced mental health challenges and struggled with alcohol dependency. DCF became involved following a fire at my apartment in which I and the other caretaker were found asleep. Emergency personnel were able to wake me up, but the other caretaker struggled to wake up, requiring hospital treatment. I had admitted to drinking the night before the fire due to safety concerns. My son, who was the only child in my care at the time, was removed and placed with kinship foster care. Following the fire, housing became very unstable. I wanted to build a safe, stable life for my son, but I lacked suitable housing. DCF referred me to supportive housing for families, and at the time I was sleeping between my car and relatives' couches. On April 29th, 2024, I was admitted to supportive housing for families. From that moment I entered the program, things began to change. My family support specialist, Kylie, and I immediately started searching for housing, secured a stable apartment. By July 3rd, 2024, the program helped me with my security deposit and monthly rent. They also provided beds, dressers, a kitchen table, and chairs, and essential household items that helped me complete my new home. Initially, I was working through a temporary agency, but I connected with a vocational supportive specialist with supportive housing for families. He assisted me with securing a full-time job at Amazon. My supportive housing specialist helped me identify a therapist who I am still engaged with today. Because of the support of the program, I gained stability, remained sober, met reunification requirements, and reunified my son in January 2025. October 2025, DCF contacted me concerning my 14-year-old daughter, who is not in my care, requesting she reside with me permanently. I rearranged my 2-bedroom apartment to give her a bedroom of her own. Within 24 hours, my daughter was placed in my care. Supportive Housing stood by me with their guidance. I applied for and received a 3-bedroom wrap voucher in January 2026. Our landlord and I built a good repertoire, and he offered me a 3-bedroom apartment. On February 1st, 2026, my family and I moved into a home that truly meets our needs. Supportive housing and families did not just help me find housing, they helped me rebuild my family, strengthen my future, and create a safe, stable place for my children to grow. I'm deeply grateful for your continued support of the program that changes lives like mine. I appreciate you giving me this opportunity to share my story. Thank you for your time.
Thank you so much. Thank you. Truly. Very impactful. Appreciate it. Gonna go to 179, Bright Johnson.
Are you sure?
I'm sure.
Okay. Good evening. I'm Bright Johnson, Connecticut Government Relations Director for the American Cancer Society Cancer Action Network and a resident of West Hartford. We have submitted longer written testimony which details the cost of tobacco use in Connecticut, the benefits of Medicaid access to tobacco use cessation services, and indisputable evidence in support of the vital role tobacco control plays in helping people quit and preventing kids from ever starting. I'd like to use my time today to publicly thank the governor for including $3.4 million in funding for Medicaid cessation services for fiscal year 27. With this proposal, Medicaid enrollees will continue to have access to cessation services, including prescription drugs, nicotine replacement therapy, and counseling. Continuity of these services and programs is essential, as not everyone reacts or benefits the same way from utilizing the various FDA-approved quit methods. Some take longer to be able to quit. Some react better to some therapies, for example, than others. Moving on, regarding Medicaid as a whole, ACS CAN opposes cuts to the Medicaid program, as these cuts will make it harder for many people to receive preventative services and cancer screenings, cancer treatments, and healthcare and survivorship. Medicaid is a lifeline for cancer patients because it ensures affordable healthcare for people who become too sick to work. With the passage of H.R. 1, people living with cancer could have their health care interrupted or stopped completely, and others would lose access to regular cancer screenings and prevention, which would have a devastating impact on cancer patients and their families across Connecticut. In our written testimony, we offer a menu of potential options intended to ensure continuity of care and access to that care for Connecticut's most vulnerable citizens. These recommendations include strengthen the eligibility and enrollment process, broadly define health-related exemptions for patients and caregivers, minimize red tape, limit out-of-pocket costs, educate patients about new requirements and provide robust consumer assistance, promote continuity of care, respect due process requirements, protect patient privacy, and prioritize transparency. Access to Medicaid should be expanded, not limited. Research consistently shows that expanding access to Medicaid increases insurance coverage rates among cancer patients and survivors, early stage cancer diagnosis, access to timely cancer treatment, receipt of cancer screenings and preventative services, and survival rates. It is vital that Medicaid remain a lifeline to comprehensive, affordable health coverage for people with cancer, survivors, and people in need of preventative and screening services. Thank you for your consideration of our comments.
Thank you very much for your testimony. Next, we have number 182, Cindy Jackson.
Good evening.
Good evening.
Senator Austin, Representative Walker, and distinguished members of the Appropriations Committee. I'm Cindy Jackson, representing Birth to Three, and I speak as one of 17 Birth to Three providers. First, I want to thank you for your continued leadership and commitment to strengthening Birth to Three services. As Birth to Three Program Director and for over 30 years and chairperson of the Birth to Three Interagency Coordinating Council that advises the lead agency on system issues, I urge you to fully fund Birth to Three with rate changes as outlined in the rate study using a current tiered system, not the expanded system. As many have testified today, Interagency Coordinating Council and the Office of Early Childhood collaborated on a comprehensive rate study cost analysis in 2023. The study's data was used to inform the system about the current cost of delivering early intervention services, particularly since rates had not been adjusted since 2017. Although funding was increased for fiscal year 27 during the fiscal year 25 legislative session, the allocation was not sufficient to raise the rates to the levels recommended in the report. As a result, the system continues to face significant challenges in employing professional master's and doctorate level therapists and special educators necessary to support families across Birth to Three. Recruitment and retention of high-quality early interventionists remain ongoing concerns. There are several contributing factors, including the fee-for-service funding structure, which we can only bill for services when we actually see the child, so all the indirect costs are not a part of it. Non-competitive pay scale, the substantial number of responsibilities placed on staff, and the nature of Birth to Three home visiting, which was previously testified by Mrs. Davio. Because the system operates under Part C of the Individual with Disabilities Education Act, IDEA, programs must comply with a wide range of regulations, including rigorous personnel standards. These requirements are burdensome to staff, and without adequate funding, programs struggle to hire and retain the workforce needed to effectively serve Connecticut's children and families enrolled in Birth to Three. There has been a 24% increase in evaluations since 2019. Due to the combination of workforce shortages, increased referrals, and the IDEA Part C requirements of a no wait list for any family referred to Birth to Three, children are receiving less services. A child with autism is now receiving 62% less hours than in 2019, and a child with other significant developmental delays have a 9% decrease in services. National research tells us that the quality of early intervention services positively changes the trajectory of a child's life. Connecticut data shows us that nearly 40% of participating children in Birth to Three do not require special education at age 3, which is, as you know, a significant cost savings. Programs want to maintain the level of quality services that support our children. We should be concerned when OEC reported.
Please summarize.
Yes, in the family comments that workforce shortages and staff turnover negatively impact support and services. Our babies can't wait for adequate funding. Please put in place rates that will adequately make our workforce available to our families. Thank you for your consideration and your work.
Thank you very much. Next, we're going to hear from number 184, Bobby Berrio.
Good evening, Representative Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Subcommittee. My name is Bobby Burial, and I would like to speak to you today to ask you to reject the governor's recommendation to stop the phased increases in the asset and income limits in the Mid-Connect program, and to also work to ensure that the income and asset limits of Husky C match those who are in Husky D and the income and asset limits that non-disabled adults currently have. The reason why I'm asking you for this is because as someone with a disability, as someone who has autism, and who's also had to have brain surgery, I want to have the same opportunities as to succeed as everyone else. And to be perfectly honest, I don't want to be I don't want to have autism. I would like to be like everyone else, and I certainly didn't want to have brain surgery or grow up in the foster care system and deal with all the stuff that I had to deal with growing up. But unfortunately, I don't have the luxury of living a life that I wish to live. I can only live the life that I have. And I think it's important, and from a social justice perspective, that all persons with disabilities have the same opportunities to succeed as everyone else, and that no person, whether or not they're disabled or not, should have to choose between accepting an employment opportunity and losing the health care coverage. I think that being able to be gainfully employed while keeping life-saving healthcare coverage is something that every person should be able to have, whether or not they're disabled or not. And then finally, I also agree with Attorney Tubman of Disability Rights Connecticut and his call to adjust the income and asset limits of Husky C to those on Husky D for non-disabled persons. I don't think it's right or fair or just that people with disabilities, because they're disabled and for no other reason, have a lower income and asset limit for Medicaid as non-disabled persons. I want to again thank you all so much for taking time to listen to my testimony, and I hope you have a good evening.
Thank you very much for your continued advocacy. Next, we have number 185, Teresa Coyle, followed, I believe, by Jason Shirley.
Good evening, Senator Austin, Representative Walker, and honorable members of the Appropriations Committee. My name is Teresa Coyle from Columbia, Connecticut. I'm conservator for my brother who suffered a traumatic brain injury in a car accident when he was 19 years old. His injury left him with severe memory and other cognitive impairments, and he needs 24-hour per day support. I've been advocating for my brother's needs for 42 years. I'm thankful for what we now have for brain injury supports. However, we need our state to keep moving forward with resolutions to important DSS funding issues. I'm using the self-directed model of care under the ABI waiver. I choose, hire, and manage my brother's caregivers at the level of oversight needed to keep him safe. Due to payroll challenges in the last several months involving the state's fiduciary agency, his care is now in jeopardy. The payroll inconsistencies are challenging my ability to maintain a stable care team for my brother. We need to be able to rely on our fiduciary agency to handle payroll matters efficiently and consistently. We cannot expect caregivers to stay when we cannot guarantee they will be paid accurately and on time. I spend many hours each week building and managing my brother's care team. He's vulnerable and needs continuous oversight of his care, with caregivers committed to following person-centered protocols. Overseeing self-directed care is not an easy option for families. When it is done right, however, consumers can live quality lives in their communities and avoid institutional placements, which is how our waivers are meant to be used. I can honestly say that my brother is now happy, healthy, and safe with his current self-directed team. Community First Choice is the program that allows us to self-direct our PCAs. If there's any move to eliminate CFC, some waivers will require PCAs to be hired through agencies, meaning an inability to choose, hire, and manage them. For some of us, self-direction of our caregivers is the best option we have. We need our PCAs to remain self-directed under CFC. I believe DSS is hearing our concerns. I believe the union is fighting for us and the rights of our caregivers. We need DSS to have the necessary support to fix the current payroll problems, keep CFC, and protect our ability to keep our family members safe through self-direction. Thank you for listening to my concerns, and thank you for what you do.
Thank you for your testimony. And thank you for your work and your care of your brother. Next, we have number 191, Jason Shirley, followed by Rosanna Ferraro.
Good evening, and thank you to the committee for staying up so late to hear my testimony. I appreciate it. My name is Jason Shirley, and I'm the Director of Outpatient Services for Child and Family Agency. I come before you to highlight the remarkable work that Connecticut's urgent crisis centers are doing and ask for your ongoing support for this vital service. The UCCs face considerable challenges in sustainability. As a newer service, continued work is needed to spread awareness and education to get youth in need to our door. We're grateful for the partnership of Howard Savronsky from the Office of Behavioral Health Advocate, and thank you, Governor Lamont, for the creation of this indispensable post. We're also grateful to our partners at OPM, DCF, and DSS for their collaboration in establishing sustainable Medicaid reimbursement rates for the UCCs. While this progress is significant, commercial insurance rates continue to lag far behind. This gap leads to UCCs not recouping sufficient revenue to match operating costs. To ensure that all families, regardless of insurance status, can access this critical service, ongoing state grant funding remains essential. UCCs have become an irreplaceable part of Connecticut's crisis service continuum. UCCs provide immediate risk evaluation and crisis stabilization with no appointment necessary. From the moment a family enters one of our centers, they are engaged with a dedicated multidisciplinary team. That team coalesces their varying lenses into diagnosis, safety plan, and a list of mental health recommendations that are shared with the family. In the days and weeks that follow, UCC staff continue to work with that family and get them connected to supports. We don't just stand with you in the moment of crisis, we work with you to secure the supports that prevent that crisis from happening again. This model has shown incredible effectiveness in its short history. Over 3,000 individuals have been supported in their most difficult moments. More than 98% of these are able to return to their homes and community without inpatient care. 89% astonishingly walk out having had improvement on their problem from the moment they walk in to the moment they walk out. This targeted mental health intervention averages 3 to 4 hours in duration, which is significantly less than an ED stay, and the cost to the consumer and public is considerably less. The ongoing collaboration between UCCs and mobile crisis services ensures that families have options that best fit their needs and increases the likelihood of timely intervention. Our system must keep pace with the growing mental health crisis in Connecticut, reduce the load on our already overburdened hospitals, and have effective strategies to improve the lives of our struggling citizens. The moment your child comes to you and says they're thinking of taking their own life is a moment no parent hopes to face. Within that crisis point is fear, overwhelm, uncertainty, and a terrifying notion of not knowing what to do. What is needed in that moment is someone who looks you in the eye and says, I'm here with you. I'm going to go through this with you. And together we're going to find a path forward towards hope and healing. That's the experience that the UCCs provide. It's this experience I'm asking you to continue supporting. Allow it to grow and provide invaluable support for the state's most vulnerable youth in their most desperate moments. Please move $4.5 million in the fiscal year DSS Medicaid budget to a grant line in the DCF budget to continue to support our 3 community-based UCCs. Thank you so much for your work and the opportunity to speak here today. Have a great night.
Thank you. You too. Next, we'll go to Rosanna Ferraro, followed by Lenore Riley.
Good evening, Appropriations Committee. Appreciate your time. I'm Rosanna Ferraro. I'm the Policy Director at Universal Healthcare Foundation of Connecticut. At Universal, we envision a world where justice prevails, health is respected as a human right, and equity is realized. This year, we are part of the Health Justice Now campaign. It's not just about one bill or one issue. It's solidarity and support across all of our issues. We are individuals, organizations, coalitions that hold one core value. Everyone needs access to quality, affordable healthcare. Each policy we work on works towards this goal. On the subject of the governor's budget, there are choices that were made that we support, as well as those that we oppose, and a few omissions. We are thankful to see the preservation of the state-funded Husky program that provides access to children 15 and under and pregnant and postpartum individuals, regardless of immigration status. You've heard a lot of those stories today, and it's a critical lifeline for so many. I think you've heard a lot about the Community First Choice program. We agree that we should not end this program and certainly oppose its elimination. As far as omissions, there is no money to be able to implement the funding of community health workers under Medicaid, especially now when the health system is becoming harder and harder to navigate for folks in our communities. I think it's critical that we fulfill the promise of the policy that was passed. There are also a number of immigrant folks who will be losing coverage and folks that have already lost coverage where there is no plan. There's complete silence on how we will ensure that folks that, because of their immigration status under federal policy changes, will no longer be eligible for coverage. I don't think that these changes have to lead necessarily to increasing our uninsured rate. We can leverage our state-funded Husky program to cover folks, ensuring that immigration status isn't a barrier to care. And I also want to lift up the folks that will inevitably lose coverage once we implement the work requirement in Husky D. And I implore this committee to explore every option to keep folks covered with some sort of quality, affordable care. The last thing, I'm just going to reiterate, we need to increase Medicaid reimbursement rates because it makes sure that there are enough providers to serve all the Husky enrollees. And I just urge you to pass a budget that prioritizes quality, affordable health care for all. Thank you so much. Have a great night.
Thank you, and I sure hope we do. We're going to go back to number 192. Scott Cochran, sorry for the mix-up, and then we will go back to Lynn O'Reilly.
That's great. Thank you. I apologize. I had some trouble logging on. Can you hear me okay?
We sure can.
Okay, thank you. Good afternoon to the Human Services Subcommittee chairs, Senator Lesser, Representative Gilchrist, the Appropriations Chair, Senator Austin, and Rep. Walker, and the ranking members, Senator Harding and Rep. Nuccio. And I would like to just acknowledge and thank Rep. Walker for her earlier advocating on behalf of YSBs when she was speaking with DCF earlier today during the hearing. My name is Scott Cochran. I'm the Director of Madison Youth and Family Services, and I'm currently serving as the President of the Connecticut Youth Services Association, otherwise known as CYSA. CYSA leads and supports a unified network of 100 youth service bureaus that serve 137 towns across our state. Together, this past year, YSB served more than 300,000 youth across the state. Today, I respectfully come before you with two requests. The first is $300,000 in new funding for our YSB enhancement grant. The second is a $310,000 request to support the statewide data collection, analysis, and reporting that's required by our state statute. Youth Service Bureaus, as defined in State Statute 10-19M, are the state's community-based support network for youth and families. We provide essential services, including mental health support, diversion, truancy, mentoring, prevention initiatives, youth development, employment skills training, and substance abuse intervention. YSBs are often the first place a family turns when a young person is struggling. Our work at the community level often prevents deeper system involvement and more costly interventions that could occur down the line. However, state funding for YSBs has remained flat since 2019 when our oversight moved from SDE to DCF. Today, state dollars account for only about 14% of the average YSB's total budget, and many of them are working on a very tight shoestring budget. An additional $100,000 for the enhancement grant would acknowledge 6 years of rising costs, increasing demand, and growing complexity of youth needs. Because the grant is distributed through a population-based formula, the additional funding would very likely direct the greatest support to the communities with the highest needs. This is a modest, fiscally responsible investment that strengthens prevention and protects against more expensive outcomes. Our second request is for $310,000 to fund a statewide data collection, analysis, and reporting that our state law requires. YSBs devote significant time and local resources to collecting and submitting data, but that effort only achieves its purpose if the data is properly analyzed and reported in a way that clearly demonstrates outcomes, accountability, and impact. Historically, DCF has funded this work, but at this time, it is very clear to us that this funding has not been requested by DCF for the upcoming fiscal year.
Can you please summarize?
What's that? I'm sorry?
Your time has expired. Can you please summarize?
Yes, I will. Without this funding, the state will lose its ability to evaluate our programs. We'll lose the ability to have any insight to the programs that we're running to support our communities. On behalf of CYSA and 100 youth service bureaus across Connecticut, I respectfully ask for your support of these two requests. And thank you very much. I appreciate your time.
Thank you. Next, we're going to go actually, Port Lenore, we're actually going back to Jim Mafuid, who is 153, who had some technical difficulties, and we're glad that those have been resolved. Jim, you're up, and I promise we'll get to you, Lenore.
Thank you very much, and a big shout out to Taylor, because got me through this, so we figured it out.
Taylor is the MVP of this hearing, but please proceed.
Yeah, definitely a big thumbs up. Very helpful and persistent. So thank you. I'm Jim Maffey. I'm the CEO of the Children's Center of Hamden. We're a 193-year-old nonprofit here with a history of meeting the unique behavioral health, educational, and emotional needs of Connecticut's children and families. Annually, we serve about 500 children and as well as their family members from across the state. I appreciate the opportunity to testify, and also just want to thank you for increases that have been included in the enacted budget for fiscal year 27, but also to request that you increase funding for vital nonprofit programs by $155 million in fiscal year 27. It also would include fully funding Medicaid rate increases for behavioral health services as recommended by the state's rate study. And that study does point out that clinic-based behavioral health rates are grossly underfunded. Compared to 5 other states, we found that the rates to be 17% higher in other states compared to what Connecticut pays. So just really puts a larger strain on already a overburdened system. I think that we, our agency, and the children and families we serve appreciate the significant and real funding increases that the governor and the legislature have approved in recent years. So we are greatly appreciative of that, as well as some coming in this upcoming year here. But unfortunately, after numerous years of stagnant funding, we really are still in dire need of increased funding. I think today and throughout the day, you've heard numerous providers and individuals express their concern about the state's behavioral health system and the devastating impact that inadequate funding has had on us as providers and patients alike. Due to the Medicaid rates that do not cover the cost of services each year, my agency, like others that you've heard from, face numerous challenges regarding continuing to be able to provide services to our state's at-risk and vulnerable individuals. We recently decided to divest from one of our services. I know other agencies that have reduced services and closed programs. My fear is that this trend will not only continue, but will accelerate if we stay on this pathway. We're facing unprecedented uncertainty about funding related to our programs and services and supports for the people that work in our organization. They're highly underpaid. They advocate annually to try to have us pay them more, and we can only afford what we can based on the rates that we receive. We don't get to set or adjust our rates to account for increases in operating costs. As one might in a typical business, our reimbursement rates are set by Medicaid or contract with one of the state agencies, and the rates are significantly below the cost to provide the service. It's not unreasonable, but also unsustainable to place the burden on individual agencies to fund the difference. Our clients deserve more and our staff deserve more. I appreciate the opportunity to testify. Please support increasing funding for community nonprofits by $155 million. And fully fund Medicaid reimbursement rates. I appreciate all of your time late into the evening. We have a great system that lets us let the voice of our citizens be heard, and that we get great representation to allow this process to happen. So thank you very much.
Thank you. Next, we have Lenore Riley, followed by Todd Van Kirk.
To the members of the Appropriations Committee, I am testifying in opposition to the governor's proposal to end the CFC program. My sister, Joy Minervini, would be personally and severely harmed if the elimination were to go through. It would cause involuntary institutionalization. She has a severe form of cerebral palsy, which involves uncontrolled movements. As she aged, these movements have worsened and involve her face, neck, arms, legs, and entire body. She requires total care for ADLs 24 hours a day, 7 days a week. Due to Joy's cerebral palsy, she cannot speak, but understands everything. She uses a communication board with words and letters of the alphabet to complete sentences when she communicates. Joy has a suprapubic catheter, but also experiences urinary incontinence several times during a 24-hour period. In addition, she also has many bowel movement accidents. Both incontinences require her to be cleaned and changed timely to prevent her skin from getting irritated, creating open wounds and infections. Joy receives her nutrients and fluids through a J-tube because of her facial, tongue, and teeth grinding movements made it impossible for her to eat and drink using her mouth. Each day it takes anywhere from 12 to 14 hours for the completion of the feeding. The machine will start beeping when the tubing gets blocked, and Joy's PCAs need to address the issue, prime it, and restart the feeding. Joy has a left dislocated hip that requires her to sleep on her right side. A pillow needs to be placed between her knees and another one behind her back so she stays on her right side. Throughout the night, the PCAs must reposition the pillow behind her back so when she coughs or aspirates, she will not choke. Joy wakes up several times throughout the night, mostly in the early morning hours, and can't go back to sleep. Her panic attacks are triggered. She ends up biting her tongue. Her PCA gets up and places her in a wheelchair to calm her down and clean her up. All the above reasons are why Joy needs the CFC program to continue her 24-hour care 7 days a week. Only CFC covers 24-hour care in the community. If CFC goes away, Joy will not have any choice but to go into a nursing home. And truthfully, she will not receive the one-on-one care she is getting now. The nursing home staff have way too many patients to care for, and quite frankly, Joy would not survive long enough in a nursing home before she passes away, which would be an absolute tragedy. Thank you for hearing my plea to leave this critical program alone and reject the governor's proposal to end it. Thank you for your time this evening.
Thank you. We actually resolved another person with technical difficulties. Sandra, who's number 194, will be up next, and then we will go to Todd Van Kirk.
Sandra, you should be able to unmute now. I see you have unmuted. Go for it. You have 3 minutes.
Thank you so much for allowing me to speak today. My name is Sandra Roberts, and I'm currently a resident in the nursing home in Granby, Connecticut. I am very scared right now. As soon as I heard that the Community First Choice program was possibly going to be discontinued, I became terrified. I've been in the nursing home for the past 2 years. I came here because I was having many health issues, especially with my diabetes. My sugars had gone out of control, and I had to be placed on insulin, and I felt that I needed the oversight because I didn't know, it was new to me, and I was very nervous about it. And also I wanted to come for rehab because I was having a lot of issues with my back, potentially facing back surgery. I am still potentially facing that, but I am pleased to say now my sugars are under control. I've been trying to leave the nursing home for over a year now, and I finally have an apartment and signed a lease in November. And I am now waiting for work to be done on the apartment so that I can move in there. When I heard that potentially the Community First Choice program could be discontinued, I was scared because am I moving out just to potentially move back into the nursing home again? I checked on what the cost here was, and I found out that a semi-private room that I'm currently in is $20,000 per month. I'm not sure if that is the actual Medicaid reimbursement. It might be closer to the $92,000 that was mentioned earlier. But I said, why would they want to potentially put me back in a nursing home or keep me in a nursing home that costs so much more money than having me out in the community? Here, my current plan for the Community First Choice will be 76 hours per week at $23 per hour. That is clearly a lot less than what it would cost to keep me in a nursing home. I am trying to figure out why this is happening. There are so many people on this program, so over 7,000 people who are currently on the Community First Choice. What is going to happen to all of us? We no longer have the Community First Choice. Are we going to be placed on waiting lists? Many of the waiting lists are currently over 10 years long. And I cannot understand why they would want to remove this program that's been a lifesaver to so many people with disabilities. As one of my friends mentioned earlier, Cafe Bloodland, when you're in a nursing home, many times all you get is 3 hours per day direct hands-on care, and sometimes even less than that. There's lack of staff here. Many times there's only 2 or 3 people trying to care for close to 20 people, if not more, in a unit. And you're not getting the care that you would in the community on the Community First Choice. When you're home, you have that one-on-one contact, you get the care that you need, and it's a lot more comfortable. I am only 57 years old. I'm hoping I have many more years left, and I do not want to spend the rest of my life in a nursing home. I also want to mention for the Centers for Independent Living, they've been a lifesaver. Prior to coming into the nursing home, I worked for over 30 years at a Center for Independent Living. So I encourage you to please increase their funds to $1 million. by $1 million because those programs are a lifesaver to many people with disabilities, including myself, who has been receiving assistance to be able to get back into the community. I've been receiving their advocacy by Rickson McLeody, who you did hear from earlier. So again, I ask that you please continue the Community First Choice program. It's an essential program. And also increase the funding for Centers for Independent Living. And please do something about the fiduciary agency, because you're also risking clients being forced back into nursing homes if PCAs are not getting paid properly. It's not fair to the PCAs and it's not fair to the clients. Thank you so much for listening to me today.
Thank you, and thank you for your perseverance in making sure that we could hear your voice. We know it was hard for you to participate, but we're very grateful. Your testimony was riveting, and we're working on all of those issues, and we wish you the best of luck. We're going to do what we can to help support you move back into the community. Next, we will hear from Todd Van Kirk, and then I believe Nicole Lemoyne.
Thank you, Senator Lesser. It's nice to see you again. First, I just want to recognize and express my appreciation to all members of the committee for all that you do in working to advance the state of Connecticut, and in my particular case, funding of supports for individuals with disabilities. It's very much appreciated and acknowledged. Again, my name's Todd Van Kirk. I work for Aspire Living and Learning. We're a multi-state provider of services for individuals with disabilities. We operate in the states of Connecticut, Massachusetts, New Hampshire, Vermont, and Maryland, and I head up sort of our adult services here in the state. We operate about 20 group homes, community living arrangements, as well as intermediate care facilities, which are facilities where folks with disabilities who need much more medical care are. The CLAs are funded by DDS, and the ICFs are funded by DSS. In addition to those homes, we also provide day services, in-home supports, and community companion homes, providing services to approximately 200 people around the state of Connecticut. In addition to the adult services, we also operate 3 transition academies around the state, serving the needs of children as they transition into adulthood. I'm here to support the written testimony that has been submitted by our CEO, Erica Hare, which outlines a few core asks. One of which is enhanced funding for those intermediate care facilities for some of our state's most fragile residents. Another is to enhance room and board rates for both the ICFs and the CLAs for all disability providers. The third thing is the consolidation of CLA and ICF financial reporting requirements. Since those 2 types of homes sort of both are tied to 2 different state agencies, we're required to submit 2 separate cost reports, and we're asking for us to figure out a way to have those 2 combined. In addition, I'm also here to support the current language in the governor's DSS budget proposal, which aligns the planned CLA rate increases that are planned for fiscal 27 and 28 and applies that to the ICF side. If indeed that comes to fruition, we can't thank you enough. It's a critical first step in addressing the chronic underfunding that's been in the system for decades. And lastly, thank you for your time and attention and all that you do for the state of Connecticut, in particular, our folks with disabilities. Thank you very much.
Thank you. And next we'll move to number 198, Nicole Lemoyne, followed by...
Hi there. Thank you for staying so late tonight at work. I really appreciate you hearing our testimony. My name is Nicole Lemoyne, and I work at CHR. I'm in the TSEA program, which stands for Transitional Support for Emerging Adults. And I was lucky enough to be in person earlier this evening, and I was able to bring or attend with some of the young adults that receive these services. We provide supportive, skill-building services to young adults who are over the age of 18, so they're receiving voluntary services from the Department of Children and Families, and we work with them until they discharge. So that can be, up until the age of, now it's 21 years old, unless they have a waiver. We help them to build independent living skills. I thank you for this opportunity to testify. Demand for children's behavioral health services is higher than ever, and I want to thank you for the increases that you've already enacted for the budget year 2027. and to request that you increase vital funding for nonprofits like mine to $155 million for the year. I just wanted to put into context a little bit about what some of the work is that we do and what services this money is going to support. We help these young adults figure out how to access medical providers and learn how to make their own medical appointments. We help with them with employment acquisition and then maintenance skills for keeping their jobs. We help them build a more positive self-perception through the mastery of tasks. We work on stress management, especially as it relates to community experiences. We work with them on transportation needs, with exploration of how to get their driver's license, which is always interesting. Financial literacy with a focus on banking and opening a bank account. Educational needs with exploratory experiences of post-secondary options and whatever it is that they want to do. I thought what would be really nice is if I just shared maybe like about one particular young adult, so that way you could kind of get an idea of what these services are like. So we had this young woman who had many ups and downs. So when we met her, the house where she was living and she was giving money to stay there, she ended up being evicted because it was just subletting this apartment. She had to rehome her pets, which of course was extremely sad. She ended up getting into some legal situations. She got some charges for an altercation she had with her biological mom. She ended up losing her car because she actually didn't have a license. She didn't have any insurance. The car wasn't registered. And this was just within the first few months of us meeting her. But when she discharged from our program, so this was probably about 18 months later, she has her own apartment now. She was able to reunite with her pets. She attended a anger management program that was also sponsored by CHR. All of her legal charges were nullified. She was able to maintain, mostly continuous employment through all of her time at TSEA. And she's maintained positive relationships with people in her family. She has her driver's license and a car, and now she's planning to attend community college. I just wanted you to have an understanding of how it impacts the lives of the young adults that we work with the continued funding that you provide.
Thank you very much.
Thank you.
Next, we go to 200, Selena White. Selena, are you there? Selena's got her hand up.
Selena, if you could please unmute yourself, then you can go ahead and testify.
Try one more time, Selena. Okay, don't touch it. You should be good.
Selena, just start talking.
Selena, can you hear us?
Yes.
I can see your hand. If we can't hear you, so you might want to try logging off, back in.
We can come back to you, Selena. So we will come back to Selena if you can work it out. So now we'll go to 202 Leslie Miller. Leslie, try that again. We accidentally muted you.
Do you hear me now?
Yes, we can.
Okay, good. I'm testifying regarding HB 5032 concerning Medicaid reimbursement rates for medical services. Honorable co-chairs Senator Lesser, Representative Gilchrist, Senator Austin, Representative Walker, and members of the Appropriation Committee. My name is Leslie Miller. I'm speaking today on behalf of the Fairfield County Medical Association. FCMA represents over 1,000 physicians across all medical specialties. I'm presently chairman of the Legislative Committee of FCMA. I'm a past president as well as a previous chairman of the board. When anticipating the treatment of patients with Medicaid insurance, the physician understands approximately 40% of patients suffer from obesity, 24 to 29% of patients will smoke, 28 to 31% of patients will find it difficult to keep their appointments, less than 40% will have college-level degrees, compliance rates will be expected to be lower than the general population for a multitude of reasons. In my experience, disease burden will include, but hardly be limited to, diabetes, prediabetes, hyperlipidemia, hypertension, fatty liver disease, coronary artery disease, stroke, sleep apnea, chronic obstructive lung disease, asthma, increased risk of late-stage cancers, not to mention mental illness. Despite this intense medical need, the 2025 DSS Phase 2 study confirmed Connecticut Medicaid rates are critically low. These rates are in fact below surrounding peer states and medical benchmarks for nearly all related services. In fact, the rates have been frozen at 57.5% of Medicare since 2007. Nearly 20 years with no broad adjustment as practice costs and administrative burdens, for example, electronic charting, IT costs, prior authorizations have risen dramatically. As a doctor, there becomes a point where emotional investment and idealism cannot overcome the financial loss and risk-taking that this deserving patient population requires. This is exacerbated by an already present physician shortage in Connecticut and results in difficulty in obtaining willing and appropriate specialists in a timely fashion. That, in turn, adds to patient as well as physician anxiety and is a risk to both. Connecticut physicians have always worked to keep our state's healthcare the best in the country. Supporting a sustained and meaningful increase in reimbursement rates will serve to reduce wait times, increase available specialists, and increase the number of primary care specialists who can afford to say yes.
Thank you for your testimony and your adherence to the 3-minute rule and your advocacy for your profession. Next, we'll go to number 2. We're going to try with Selena. Selena, you want to go? Your hand is up, Selena. Can you unmute yourself?
Yes, can you hear me?
Yes, we can.
Okay. Good evening, Senator Lester and the honorable members of the appropriate committee. My name is Selena White, and I live in Windsor, Connecticut. I've been a child service worker at SONET South with the Department of Children and Family for 11 years. I am here today to express how critical it is to increase funding and staffing positions within DCF. Over the past 11 years, I've seen many changes at the facility. Unfortunately, I am deeply concerned about the direction we are heading. The workplace has become increasingly difficult and unsafe. Management decisions are not being aligned with the needs of the frontline staff or the care of the children that we serve, and they are paying a price daily. We are facing several staffing shortages, unsafe working conditions, and outdated training. The units are often feel like a war zone. Staff are being injured at a rapid rate, cut in the face, cut in the neck, and bitten in the face lately. We do not have enough staff to respond effectively to emergencies or safety restraints when necessary. Weapons are being made from broken light bulbs that need to be fixed from maintenance. Windows are being smashed and boarded up. Kids are not able to look out the windows on certain units lately. This becomes very unsafe for the staff to work for and work with. The training we receive is outdated and does not reflect the needs of the youth we are serving lately. When we were hired many years ago, we were promised a safe, healthy work environment along with adequate training. The promise is not being fulfilled. I do not want to continue to work in a place that is not assuring safety for myself or the kids that I care for. This is becoming a very serious crisis at SONET South currently. The children can sense when the staff are burnt out from consistent mandates and short staffing. We are not robots, we are human beings. We come to work every day and committed to give the kids the best care, dignity, respect, and care every day. Please do not cut the funding or the positions at SONET South for our child that we care for in DCF, that all the staff that is likely to not want to be there moving forward if we cannot continue to be unsafe. We need to increase the support, not to reduce any of the positions. The safety of both staff and children depend on it. Thank you for your time and thank you for listening.
Thank you, Selena. I'm so glad you were able to unmute yourself and we could hear from you. About 12 hours ago, I made the case to the DCF commissioner that the kids at Solnet, Hospital Solnet South, are the most vulnerable in the state, and we need to do more to fill those positions and to make sure that they have the support that they need. Thank you for your testimony here tonight. Next, we will go to Amy Martin, followed by Rob Burrell.
Good evening, Senator Lesser, Senator Austin, Representative Walker, and honorable members of the Appropriations Committee. My name is Amy Martin, and I am a community mentor and life skills coach. While I am semi-retired, I still work with 2 individuals on the autism spectrum. My job includes helping my clients find motivation and building the skills they need to live more independently. Things like cleaning their homes, cooking meals, decluttering, and managing their household budgets. I also support their social development, taking them on outings like summer concerts, the gym, or out to eat. For these individuals, I help make a level of independence possible that may not have been achievable before. I have worked with one of my clients for 17 years and the other one for 5 years. One of them I first connected with through Key Human Services and later continued with them when they transitioned to GT Independence. However, in late 2024, I was unable to serve that client for several weeks because of delays in transferring paperwork. Even after I was approved to resume working with them in December 2024, GTI told me I would not be paid for weeks. How is that acceptable? Still, I chose to work because my client needed my support. What I did not expect was to go for more than 2 months without a paycheck. That is simply outrageous. I could not pay my bills. I had to ask my stepfather for financial help, and that was humiliating. I was asking my 87-year-old stepfather, who was already caring for my mother and her health issues, to support me. The fact that GT Independence believed that these clients could go without services for that long, or that I could go without pay for that same period, is unbelievable. Taking that long to process paperwork and reconnect a client with a provider they already had simply because of an agency transfer is completely unacceptable. Going months without being able to pay my bills was horrific. It created deep emotional and financial stress. That is something that you cannot easily recover from. It is time for the Department of Social Services to address the ongoing problems with GTI and establish a payroll system that works.
No caregiver should ever go unpaid, not for a day, not for a week, and never for months. Thank you for your time and for listening to my testimony.
Thank you for your testimony. Next, we'll have Rob Burrell.
Good evening, Senator Lesser and Senator Austin and Representative Walker and all of the members of the Appropriations Committee. My name is Rob Burrill. I'm president of SEIU 1199 New England. We represent about 32,000 caregivers across Connecticut and Rhode Island. And I'm speaking to you tonight because Medicaid is really the foundation of caregiving and the healthcare system in this state. It allows seniors to remain safe in nursing homes, people with disabilities to live with dignity in their communities, and working families to get essential health care through programs like Husky. Medicaid dollars save lives. And of course, the latest federal budget proposes, based on the latest federal budget, we see over a $10 billion hole emerging in Medicaid over the next decade. We're going to feel that pain coming very, very soon after those cuts are implemented in 2027. We'll feel it when people lose coverage, when working families are kicked off of Husky, when home care hours are reduced, and when disability services are destabilized. Connecticut has a choice to make right now. We can wait for the federal cuts to hit and scramble to respond, knowing that lives will be impacted and in some cases lost, or we can do what our residents and our patients and our citizens deserve, plan ahead, investigate ahead, and stand up to the federal attacks that are coming on Medicaid, which is going to impact, of course, not just patients, but also caregivers. Medicaid services pay to support tens of thousands of workers across our state in federally qualified health clinics, hospitals, nursing homes, state services, and many other parts of the healthcare economy. I'm also speaking in support of the governor's bill, which is allowing for funding for ICF intermediate care facilities in developmentally disabled group home services. That ICF funding is vital to provide dignity and care to our developmentally disabled citizens in Connecticut. But there's a problem in the way that ICF facilities are funded, and the governor's budget recognizes that by backfilling those dollars that are needed. We are also concerned about the proposal to move home care consumers from the community first choice waiver into the Medicaid waiver system. We're concerned about the disruption that will cause. You obviously have heard any number of PCAs and consumers speak about the already existing challenges in simply getting paid, the PCAs experience. Thus far, we're having a very productive dialogue with the OPM and are committed to continuing those conversations, but we want to make sure that any transition must be carefully designed, transparent, and protects the continuity of care that is so vital for our seniors and disabled citizens. In closing, we urge this committee and the legislature to treat Medicaid funding as the urgent priority that it is. We support the governor's ICF proposal, and we urge you to keep it in the budget. And of course, we urge you to act with extreme caution as you're considering the proposals to change the community first choice services. Thank you for your chance to testify. I'm happy to take any questions if you have any.
No questions, but really appreciate your testimony, Rob. Good to see you. Next, we have Jordan D'Angelo. No, we don't. We actually have, before Jordan, we've got Dr. Brian Lynch. Sorry, Dr. Lynch.
Good evening, Senator. Senator Lesser, Senator Austin, Representative Walker, Senator Summers, Representative Nuccio, and the members of the Appropriations Committee. I salute you for sticking it out this late. I'm Dr. Brian T. Lynch. I'm a practicing optometrist in Branford, Connecticut. Currently, I serve as the legislative chair for the Connecticut Association of Optometrists and have been a Medicaid provider for 45 years. As this committee moves forward with its valuable work, it is my hope that you will consider optometry with that group of providers whose reimbursement deserves to be adjusted. I would also ask you to eliminate that regulation that allows for the disparity in reimbursements between optometrists and ophthalmologists. Optometrists are Medicaid's primary eye care providers. When I first entered the profession, we were the vision care providers. Over the years, we've evolved into those doctors not only caring for vision still, but also meeting our patients' medical eye care needs. Education, technology, and scope expansion have enabled us to treat most medical eye diseases like glaucoma, co-manage our diabetic patients with their PCPs, perform minor surgical procedures, as well as co-manage complex ones. Currently, approximately 70% of the medical eye care rendered to the Medicaid population is delivered by optometrists, both locally and on a national level. In a recent study conducted by our association of our members, we gathered the following statistics. 89% of our members participate in Medicaid. Half of the 11% who do not par would if reimbursements improved. 47% polled shared that 25 to 75% of their patient volume were Medicaid patients, and 4% stated greater than 75% of their patients were Medicaid insured. According to DSS for fiscal year 2024, optometrists performed 120,000 non-duplicated services. Optometrists were reimbursed $13.5 million for the care they delivered to their Medicaid patients. Our willingness as a profession to participate in Medicaid and care for our patients, coupled with a declining number of willing ophthalmologists, will only increase the demand for optometric care going forward. Our Medicaid patients deserve comprehensive eye care, and we have always been there to provide it. In summary, please provide the legislative fix to create parity and reimbursement between optometry and ophthalmology. Please end this discriminatory practice as you did for both podiatry as well as the nursing midwives. Lastly, when adjusting reimbursement rates for providers, please remember the primary eye care provider for the Medicaid patients in Connecticut are optometrists. Thank you very much for your time this evening and the opportunity to talk to you again on this issue.
And thank you, Dr. Lynch, for being with us this evening. Next, we have Jordan D'Angelo, followed by Joe Pandolfo.
Good evening. Good evening, honorable members of the Appropriations Committee. I'm Jordan D'Angelo. I am a personal care attendant and a member of SEIU 1199NE. I've been my mother's caregiver since about 2013 when she was first diagnosed with fibromyalgia. At the time, it was natural for me to step in for her after I started helping my grandmother when I was about 11 to 12 years old when she was diagnosed with dementia. Unfortunately, my mom's health went downhill in about 2016 when she suffered a traumatic brain injury after being misdiagnosed with pneumonia. At the time, she was just 54 years old. And at that time, when she was misdiagnosed, she went into respiratory failure and went into a coma for about 9 days. She was in the ICU for about 13 days. And after coming out of the ICU, she needed help with around-the-clock care. I had to help her relearn everything from how to feed herself, to how to walk, to even how to communicate with us. And even to this day, unfortunately, she is still suffering from a lot of those same issues. So obviously, when her first health issues came into play, I stepped in as her PCA to start, even before being paid. At this point, though, so many years later, we have 2 other PCAs on her care team who help me. And it not only helps her life, but helps my life as well. But of course, life happens. People get sick, need a day off, need a little time to themselves, and on those days when they aren't there for her, I'm there for her. I've been doing this since I've been about 18 years old. I'm going to be 32 this year. But of course, she's my mom, I made a promise to her and I would do anything for her. Is it hard? Of course it is. It's honestly mentally and physically exhausting. Despite all we do for her and all of her care needs, though, she briefly faced losing hours of care due to DSS's change in their calculations from annual to monthly budgets. I was told by GTI that these were miscalculated hours from DSS, and unfortunately, there's nothing we can do. I'll summarize quickly. Long story short, we were told that the miscommunication was on DSS's part, and GTI told us it was, and DSS told us it was on GTI's part. Long story short, one of our caregivers became homeless because of not being paid. Because of that, my mom faced shortage in care, and I stepped in to take care of that. All of this was because DSS did not accurately, according to GTI, calculate the budget. What I'm asking for today is that we properly fund DSS and GTI to make sure this doesn't happen again, because when those gaps happen, we lose caregivers, and people like myself, family members, have to step in to fill in those gaps, and our family members and ourselves also suffer. Thank you for your time.
Thank you for your testimony and for your advocacy on behalf of yourself and your mother. Moving on, we have Francis Driscoll, followed by Jennifer Leduc. Good morning, Francis.
Good evening, Appropriations Committee. My name is Francis Nicholas Driscoll. I'm a professional musician and author who happens to be a C7 quadriplegic. And not recently, about a year and a half ago, I got a really bad urinary tract infection that was so bad, it landed me in the hospital. When they transferred me to the rehab center, long story short, I lost my lease for my handicap accessible apartment. Okay. However, I have written 14 books. This right here is my brand new book, The Hip Hop Concert Chronicles. Okay. It's a huge smash. And I recorded an album of original music when I was living in Las Vegas. And I'm also a filmmaker. This is my DVD, The Francis Sound, live in Las Vegas. Okay. Now, oh God. I am going to make a book and a movie about this situation to help my people here, because I am absolutely disgusted and infuriated at this proposal. If this bill is passed, it will kill disabled people and destroy our lives. And this is not a threat, it's a promise. Because I kept my computer and I kept my camera in this rehabilitation center with me. So the intellectual properties I've already produced, this next book and movie, this will be the best one. Because if this bill is passed, it will be a serious detriment to the health and well-being of many disabled individuals in the state. And this governor, I'm going to flush his career down the toilet. Lamont, Francis Nicholas Driscoll, you better warn him. He better not do this, or I'm going after him with all my might. I waited 7 hours to testify, and I'm falling asleep. Anybody got any questions?
No, but I certainly hear what your concerns loud and clear, and I think we all do. We're going to be looking really carefully at this proposal and have a lot of
Here's what I said. And anybody disabled or elderly that's affected by this, contact me if you want to be in my book or my movie, because it's going to be a blockbuster hit. I'm going to move back to Las Vegas, and then Lamont is going to be down the toilet. Bye bye, rich politician idiot.
Thank you, sir. Next, we're going to go to actually go back to number 218, Darnell Ford.
Good morning.
Good morning.
Thank you, Senator Lesser, Senator Alston, Representative Walker, and honorable members of the Appropriations Committee. My name is Darnell Ford, and I'm from Middletown. I'm a lead children's services worker at Stone South, where I've worked for the past 28 years. I'm here tonight because the Department of Children and Families need to increase funding and staffing. The conditions inside our facility have become increasingly unsafe every year for both staff and youth that we care for. Over the course of my career, I've worked with thousands of youths. I've seen how trauma, mental illness, and instability can shape and actually at times destroy a child's life. I can also tell you that this environment that we're working in right now is not sustainable and it's definitely not safe. We're facing serious staffing shortages. Staffing is so short where everything becomes much harder. Situations escalate faster. Staff cannot respond in the way that we would like to and to keep kids safe emotionally, psychologically, and physically. The youth feel this absolutely immediately. They know when the unit is stretched thin. They know when our staff is burnt out from mandates, exhaustion, and constant responding to crises. And when you don't have enough staff, what you actually do is you put everybody at risk, the workers, and especially the youth that we're in charge to keep safe. We have seen staff get injured at alarming rates. They've been bitten, they've been assaulted. There's worry that they're not going to be able to go home, or even if they do, what to expect when they come in with during the shift with something going wrong. The physical conditions of our building poses a great challenge and more of a problem as time goes on. We have units with smashed and boarded up windows, which limits visibility, which means what we're supposed to be trying to create as an environment of safety then becomes an environment that resembles much of what our children have come from, creates blind spots and increased risks. We have youth who create, unfortunately, based on these type of conditions, create weapons with anything that they can get their hands on, because it's actually recreating what they've come from, broken pieces of light bulbs, pieces of materials that they can get any kind of access to. And these are not small incidences. These are just warning signs that our system is under strain, our staff are under strain, and there's a serious breakdown in our system. The training that we receive is not reflective of what the real reality of what our children are going through today and what our youth need. They come through the door with much more complex trauma than what they ever have before. The trauma is deeper, the mental health challenges are more severe. But I just want to make sure that it's clear and understanding that dealing with these outdated preparations and staffing levels, it doesn't match the reality of the job that we need to do. When I started at DCF, we were promised a safe working environment to provide for the children. We needed the support to do this work properly, and that promise has not been kept. I want to be clear that the staff is Solent. We care deeply about the job that we do, the youth that we care for, the families that we need to keep safe. And it's not just a paycheck. We show up because we believe in these kids. We deserve in the dignity, the structure, and the real support that is needed for these children to grow and be in a safe environment. But we cannot provide that if we're consistently short-staffed and operating in unsafe conditions. Connecticut cannot continue to ignore what is happening in these facilities. And if we want to be able to have the youth heal, if we want to have a real chance at stability, then we need to invest in staffing, training, the infrastructure that makes that possible. Please do not cut funding. Please do not reduce the positions. Please increase the support, increase staffing, and real investment so that we can protect both the workers and the children that we care for. Thank you for your time. Thank you for hanging in there. Thank you for listening.
Thank you, sir. It's good to see you, and always appreciate your work on behalf of the children that you work with.
Thank you, sir.
Next, we will go to Jennifer Leduc, followed by, I think, Kim Durand.
Good evening, members of the Appropriations Committee. Thank you for the opportunity to testify today. My name is Jennifer Leduc. I am the Executive Director of Day Kimball Health at Home and Hospice. I'm also a registered nurse with over 26 years of experience and a lifelong resident of the Quiet Corner. I am also a member and board chair for the Connecticut Association for Healthcare at Home. This evening, I wish to speak to the reality of providing home health care in a rural community and why Medicaid reimbursement is now directly limiting access to care in northeastern Connecticut. Here in the Quiet Corner, about 21% of our residents are age 65 or older. They are aging in place. These are our parents, our neighbors, and the people who built our communities. They rely on home health care to recover after hospitalization, manage chronic illness, and remain safely at home. When combined with shortages of primary care providers, limited transportation, and fewer healthcare resources than much of the rest of the state, home health care is not optional. It's essential healthcare infrastructure. Providing care here is harder every year. Patients are sicker, more economically vulnerable, and often lack family or informal supports. Our workforce is shrinking as workers leave for neighboring states or very large healthcare systems that offer higher wages and benefits. Transportation options are extremely limited, making care delivered in the home not just preferable, but often the only viable option. And still, Medicaid home health reimbursement does not cover the cost of care. Rates have not kept pace with rising wages, health insurance costs, supervision requirements, regulatory compliance, or basic operations. As Medicaid providers, agencies like mine are deeply committed to serving Medicaid patients. But when reimbursement falls short, we must carefully balance capacity to ensure safe staffing, compliance, and long-term sustainability. Northeastern Connecticut faces a real erosion of access to care, where services may technically exist, but are increasingly difficult for patients to obtain. This is why we are asking for targeted Medicaid corrections for home health care. These are outlined in my written testimony, which was also submitted earlier this week, but we would like rate increases through fiscal year 26 through fiscal year 30, restoration of the medication administration rates to 2016 levels, and elimination of the subsequent visit rate penalty, which discourages comprehensive care. These corrective actions preserve access, stabilize our workforce, and prevent far more costly hospital and nursing facility care, helping seniors remain safely at home. Thank you for your time and consideration.
Thank you for your testimony. I actually have a question for you. There's been reporting that the Day Kimball Hospital may be purchased by UConn Health Center, and I was just curious if that purchase would likely also include your organization, the Healthcare at Home organization.
I don't know the complete answer to that question, but I do know that Day Kimball and most healthcare systems in our state value home health services and hospice services very much. We are an integral part of our healthcare system. So I do believe that we will be part of it, but I just don't know the details. And I would defer to our CEO, Kyle Kramer, for that.
Makes sense. Thank you very much.
Thank you.
We are actually going to go, we're going to go back now to Joe Pandolfo, and then we'll go to Kim Durand.
Thank you. I apologize. My internet just went out when it became my turn to speak. And Senator Lesser, co-chairs and ranking members and members of the committee, thank you for putting in these long hours hearing our public testimony, and also long hours and piecing together budget in quite challenging times and the budget adjustments that we're considering this session. My name is Joe Pandolfo. I'm a public director of the board of directors on the Connecticut Society of Acupuncturists. And we would like to just speak in support of the fee increases for Medicaid providers at all levels. And particularly, we just want to request that the committee help ensure that licensed acupuncturists are part of the budget adjustment fee increases this year. The services that the acupuncturists provide in Connecticut in the few short years they've been in the Medicaid program are in great demand by Medicaid patients. And it's really no wonder because the data that's out there showing that acupuncture care really helps patients reduce their use of pain medications and also reduces their use of other more intensive, expensive treatments such as surgery, hospitalization, care with chronic conditions. It just kind of comes to bear in the experience of the acupuncturists who provide Husky patients with services. And the fee increases, I think, will really help encourage more of the acupuncturists to join the network. A lot of them just can't really absorb the cost to their small business offices of taking the kind of I think extraordinarily low Medicare fees that are available now. So I think the fee increases for these providers will really help them serve more patients and save the system more money because there's just great data out there that will show us that acupuncture care really helps systems save money because it helps reduce the use of more expensive treatments, especially with regard to pain treatment, pain medications. And we have a good deal of data, including very recent data, that we would be more than happy to share. If I could pass that along to the committee, I would be happy to do that. And thank you again for your ear and your time with all the hard work you're doing on the budget. Thank you again.
Thank you, sir. Next, we have Kim Durand, followed by Kimberly Smith.
Good morning, distinguished members of the Appropriations Committee. My name is Kim Durand. I'm a registered nurse with nearly 40 years of experience caring for vulnerable patients here in the northeast corner of Connecticut. I am here today to speak about the very real consequences of persistently low Medicaid reimbursement rates on home health services and on the patients and clinicians who depend on it. In northeastern Connecticut, Medicaid is not an abstract policy issue. Our region has approximately 98,000 residents, with 1 in 5 relying on Medicaid health coverage. These are the patients I see every day. They are seniors trying to remain safely in their home after a stroke. They are individuals with chronic illness struggling to avoid another hospitalization. They are children with complex medical needs whose families are doing everything possible to keep them stable. When reimbursement rates do not reflect the true cost of delivering skilled home health care, agencies are forced to limit Medicaid admissions, starter care visits are delayed, services are reduced. In our rural region, there are not excessive providers waiting to step in. The result is predictable. We see preventable complications, emergency room visits, and hospital readmissions that cost far more than adequately funded home care services. But the impact does not stop just with our patients. Low Medicare rates are driving workforce instability. Labor is our largest expense, and when reimbursement remains stagnant, agencies cannot offer competitive wages. Nurses and therapists leave for hospitals, outpatient centers, and travel positions. In our region, registered nurses carry caseloads of 35 to 60 patients. That's compared to our industry standard of between 25 and 30. And it's not sustainable and it's not safe. Clinicians drive long roll distances, overtime becomes routine, and burnout rises. And when nurses leave, it leaves those patients with lack of continuity of care. If we want patients to heal safely at home, we must ensure that our clinicians are providing that care that can afford them to stay in the home health field. Improving Medicaid reimbursement for home health is not only simply an increase in spending, it is an investment in access, workforce stability, and long-term cost containment. With appropriate rate adjustments, agencies can sustain Medicaid admissions, clinicians can remain in community-based care, patients can receive timely services, and costly hospital readmissions can be reduced. Our patients deserve safe care at home, our clinicians deserve sustainable careers, and our community deserves a Medicaid system that funds the care at a level required to truly deliver it. I thank you for your time.
And we thank you. And the last person I have listed is number 241, Kimberly Smith. Kimberly.
Good evening, Senator Austin, Senator Lesser, Representative Walker, and members of the Appropriations Committee. My name is Kimberly Smith, and I'm the Program Director at Disabilities Network of Eastern Connecticut. DNEC is one of 5 independent living centers in Connecticut. Independent living centers are community-based organizations run by and for people with disabilities. We provide core services that help people with disabilities live independently, stay safe, and remain in their homes and communities of their choosing. For years, independent living centers have been continuously flat funded. The reality is simple. When funding stays the same but costs rise, services shrink. When services shrink, people with disabilities suffer. At Disabilities Network of Eastern Connecticut, we are increasingly unable to meet the needs of people in our region, especially in rural areas where transportation barriers and limited service options already make daily life harder. We are forced to maintain waiting lists for services that people need now, not months from now. These are not luxuries. They are supports that prevent crisis, homelessness, caregiver burnout, and unnecessary institutionalization. That is why we are requesting an increase of $1 million for independent living centers statewide, which equals $200,000 per center. This investment would allow us to expand staffing, reduce waiting lists, and reach more people in underserved communities. Independent living advocates are truly jacks of all trades. We problem solve across housing, benefits, accessibility, employment, peer support, and daily living needs, doing whatever it takes to keep people out of institutions and in the community. I also want to express serious concern about the governor's proposal to terminate the Community First Choice Waiver Program. Community First Choice is a critical support for people with significant disabilities who rely on home and community-based services to live independently. Eliminating this program would move Connecticut in the wrong direction, away from community integration and toward institutional care, which is both more expensive and less humane. Connecticut should be strengthening community-based supports, not cutting them. I urge you to include the $1 million increase for independent living centers and reject any proposal that would end Community First Choice. These are smart, cost-effective investments that protect independence, dignity, and the right to live in the community. Thank you for your time and consideration.
Thank you for your testimony and for the testimony of all of the folks who have been here to this morning, last night, yesterday afternoon, and yesterday morning in this lengthy hearing where we were able to dive into some of the big issues facing the state. The Appropriations Committee will be back later today for more discussion. And with that, I believe we can adjourn the hearing. Good night, everybody. Drive